Hi Shiv, Guru here.
Yes, Guru. I think we are
So
live now.
it says it is gone online, but what I wanted to know is, yes, I think it is come. Yeah, we are online now.
Yeah.
I can
Okay.
see
So
you and Minat. Yeah, I'm going to mute.
yeah. So good morning, everyone. I think Anju hasn't joined. She is, I think, the first speaker. Guru, can you actually message her and just tell her that we are waiting for her?
And Minat. Yeah, we'll do that.
Okay. So welcome to the day one of the Crisis Management Symposium. Today we are going to cover the unknowns, something which we encounter without knowing what's in coming up, isn't it? That's what anesthesia is about. So we will talk about cardiac arrest, of course. That's the first thing. We will talk about intraoperative, arrhythmias like bradycardia, tachycardia. We'll talk about hyper and hypotension. Now, increased airway pressures, which Shabat is not here today. He's got his exam, so I will cover that topic for him. And also, hypothermia will be dealt with tomorrow. So we're going to talk about myelin hypothermia tomorrow. So even though it was part of this topic, we will talk about it tomorrow. And once Anju joins, we will start off with cardiac arrest. But if she doesn't, then we will actually, Dheeraj, I would suggest that you be ready with your presentations.
Sure,
Isn't it?
sir.
Yours was the next one, isn't it? Yeah. So we can start off with tachycardia and bradycardia. Some of the presenters do get tachycardia when they are actually in symposiums, but most of you are used to this now. We have actually conducted now quite a lot of these symposiums. So now you're all experts, you're all veterans, so it shouldn't be a problem. Again, today we actually have got, I think, decent amount of time, so don't be rushed in when you are, presenting. Just be at a good pace. Don't rush through things. We have enough time today for presentations. Like I said, one of the presentations we are not going to do, the hypothermia, and I think we are finishing a bit early today, so that's okay. I mean, each day is for 4 CPT points, and we are doing more than 4 hours anyway, so that's not an issue. And we will likely do. We will also take a break in between, a short break for a cup of tea. And those
What
from
is
UK
mine
can.
in sequence today?
Sorry,
What is mine in sequence?
is it yours next? Anju is here. Don't worry.
So mine is second then.
Yeah.
After Anju. Okay.
Yeah, I was going to just ask Dheeraj to do the thing for tachycardia, bradycardia, but now Anju is here, so we will be able to actually start off with AS in the sequence. Okay. Hello, Anju.
Hi Shiv, Dr. Anju Gupta is here.
Yeah, she's here. So we will start off with cardiac arrest, and that will be followed by intraop hypoxia, desaturation, cyanosis by Minati. And then I can cover the increased airway pressure. Shabahat was supposed to do, but he's got exams today, so he's not been able to join us. And Dheeraj will talk about intraoperative hypotension. And Ansh will be talking about bradycardia and tachycardia. And like I said, perioperative hyperthermia, we have actually not, we're not going to do this. We're going to do malignant hypothermia tomorrow. Bhavya will cover that. Fluid management will be covered by Divesh later on. And Minati will then also talk about lactates in perioperative care. And last of the lectures will be on delayed recovery by awakening, which is by Vanita. I've not heard from her, so I'm not sure whether she is there or not. But if it is not there, then we will actually. So we will start off, kick off with Anju's lecture on cardiac arrest. Like I said, don't be in a rush. Okay, be at a good pace so that everybody is able to understand with the key points. Okay, over to you, Anju. Let me allow everyone to share the screen. So over to Anju. Anju, I would like you to give your own introduction. Normally, we actually have the slides of people and things like that. Please go on and introduce yourself. I know you actually have, well, you were working at Lady Harding, is that right, before?
Sir, good afternoon, everyone. Am I audible, sir?
Yeah, you're very audible, yeah.
Thank you very much, first of all, sir, for the opportunity to present this talk. So I'm working at All India Institute of Medical Sciences right now. But yes, I was at Lady Harding Medical College for a good 12 years of my life. I'm a undergraduate, postgraduate, and senior resident from Lady Harding. And mainly, I was interested in pediatric. My thesis was in pediatric anesthesia, and I always it was when I was in Harding, it was most of the time pediatric anesthesia only. Harding has associated Kalavati Saran Children Hospital, which is a excellent tertiary care hospital for pediatric anesthesia. And so following that, I have been to multiple places as consultant. And one of them is CNBC, Chacha Nehru Bal Chikitsalaya, which is a pediatric specialty hospital. Then I worked at Safdarjung Hospital of Delhi, and then right now I'm working at All India Institute of Medical Sciences, Delhi. My main areas of interest are pediatric anesthesia, airway, and regional anesthesia.
Thank you, Anju. I think with your vast experience, I think pediatrics, we have used your experience in pediatric anesthesia symposiums. But today you're going to talk about cardiac arrest. Though it is taught as part of the resuscitation whenever you go for resuscitation training, that is taught. But I think we are going to talk about cardiac arrest, intraoperative cardiac arrest mostly, and how we deal with it. Okay, so over to you. Yeah.
Are my slides visible, sir?
Yeah.
Okay. Thank you, sir. So I'll proceed with my talk on perioperative cardiac arrest. All of us must be, as anesthesiologists, aware of the ACLS algorithm, BLS and ACLS. So the intricacies of BLS and ACLS algorithms are not the objectives of my talk. What I would be focusing during my talk is mainly on the perioperative cardiac arrest and its associated specificities of perioperative cardiac arrest and its peculiarities and management. So I have nothing to declare. First of all, coming to the incidences and outcomes of perioperative cardiac arrest, it is estimated to be around 5.6 per 10,000 cases in various studies, though the incidence varies with the kind of surgery and the surgical population. So it varies with that. It has been seen that the outcome is better than the outside operating room cardiac arrest because of various reasons, which I'll be discussing later on. However, still the mortality remains as high as more than 50%. So it is a very crucial to recognize it early and manage it well. Survivorship with perioperative cardiac arrest is said to be worse with advanced age, increasing age, higher ASA physical status, and for emergency surgeries. Abdominal and thoracic surgery have found to be have the highest risk of intraoperative cardiac arrest, and asystole is the commonest cardiac arrest rhythm which has been found during the first 24 hours perioperatively. So first of all, we need to know what is different in perioperative cardiac arrest. The first thing is that they are always witnessed because the surgery is ongoing and we are monitoring and watching the patient vigilantly during the surgery. And the precipitating causes are on most often known beforehand, because we have seen and we have evaluated the patient pre-operatively. So we are aware of the causes, we are aware of the patient's risk status, various physiological abnormalities, various pathologies which are associated. These all have been evaluated in the pre-operative period. Response is timelier because we are monitoring, so immediately the response is more faster and immediate and focused. It is focused on the causes which are thought to be related to the cardiac arrest, and generally reversible causes such as medication error and airway crisis. These are immediately taken care of, and immediately the response is there. Then caregivers usually will tell you about the relevant medical history preoperatively, or in case of any such event where the patient later on, if the patient goes into cardiac arrest, we can always refer back to the caregivers and they will give us such history in case it is missed. Aggressive measures can be applied preemptively, and so there can be maybe there is the need for ACLS doesn't come at all, and it is recognized immediately and immediately treated, and so the revert back to the response to spontaneous circulation may be very fast with perioperative cardiac arrest. And also in many such cases, especially for the patients who are being taken up for major procedures and those who have major underlying pathologies which are unreversible, and the patient and the caregivers are aware of that, generally advanced directives may be there in place which will guide you regarding the need for escalation and to what level they can be taken. So perioperative cardiac arrest, the potential causes may be related to the anesthesia itself and to the surgery related and to the patient related factors. So causes of cardiac arrest may be related to an acutely reduced perfusion, which can be related to an increased intra-abdominal pressure. For example, in a pediatric child who is undergoing a gastroschisis surgery, if all the contents are acutely reduced into the abdomen and the abdominal cavity is not able to take up that much of pressure, then acutely reduced venous return to the heart can lead to cardiac arrest. These things are known. Then tension, sudden onset of tension pneumothorax, like in case of CDH. So these all things can be related to perioperative cardiac arrest. Then respiratory problems are another very, very important and prominent cause of perioperative cardiac arrest, ranging from hypoxemia and severe bronchospasm. Airway related cardiac arrest is very well known, and in children hypoxemia remains a very important cause of perioperative cardiac arrest. Cardiovascular problems are another prominent reason, because vasovagal reflex is one common cause of bradycardia and asystole. Some surgery where some vagal stimulus happens and the patient already has a baseline high vagal tone, like ASA1 patients who are athletic. These patients may go into sudden cardiac arrest, and under spinal anesthesia, this is one well-known cause. Then hypovolemic or hemorrhagic shock may be another cause. Then gas embolism is known in certain surgeries to happen. Electrolyte abnormalities are common in emergency surgeries. Transfusion related or anaphylaxis related causes may be there. Acute coronary syndrome, pulmonary thromboembolism, pulmonary severe hypertension, then pacemaker failure, prolonged QT syndrome, these all are well-known causes, and oculocardiac reflexes are a cause in ophthalmic procedures. Sorry. Anesthesia related problems we all should be aware of, because these are very much treatable, and if the response is taken timely, then immediate reversal can happen, and the prognosis is very good if it is recognized immediately and treated well, like anesthetic overdose and neuraxial block, systemic toxicity of local anesthetic, malignant hyperthermia. These are anesthesia related causes. So at any time, we should not forget our 4H and 4Ts, which are important to diagnose any such cause of cardiac arrest, whether it is intraoperative or whether it is anywhere else. So 4H include hypoxia, hypovolemia, hyperkalemia, hypothermia, tamponade, thrombosis, which can be coronary or pulmonary, toxins in anesthesia can be overdose of anesthetic agents, and tension pneumothorax. So whenever any such patient goes into any anesthesia, any patient goes into cardiac arrest during the perioperative period, we should at the back of our mind start ruling out these causes. So specific perioperative problems like vagal tone, drug error, local anesthetic toxicity, acidosis, anaphylaxis and embolism, and massive blood loss, these all should be taken care of. And if the risk factors are known, we should always take preemptive measures to prevent them. Recognition of crisis sometimes is more difficult in peri-procedural settings due to certain causes like when a patient is under sedation or under general anesthesia, the mental status assessment is not possible. So that can be one cause. Then respirations are often controlled. So when the patient goes into apnea, there is sudden onset of apnea. These kind of symptoms are ruled out. Surgical positioning like lateral, prone, these all will, if the patient is under drapes, so these all will prevent us from assessing the patient immediately if we are not vigilant enough, like checking for pulse and other parameters. Then failure to rescue is often a cause of cardiac arrest, often an invoked cause of cardiac arrest for the perioperative patient. And sometimes the monitors are also very misleading. They are due to cautery or other causes. They may be buzzing all the time, and we need to take care that we should not directly dismiss any kind of such perioperative, any kind of this alarms which are buzzing. Before silencing them, we should always rule out whether there is any kind of crisis which is happening. And also we have now a very useful tool which is POCUS, bedside assessment using ultrasound, which is increasingly being applied in unstable patient, and it enables us to make a very quick diagnosis and also for many kind of management things. So first of all, to manage any crisis, the most important part is to recognize it timely. If we are able to recognize it timely, then only the outcome will be the optimal. So recognizing cardiac arrest in the OT room, though it can be difficult, but still it is very much possible, and if we stay vigilant during the perioperative period. The reason for difficulty in recognizing, one is alarms can be false alarms. Bradycardia can happen frequently in patients undergoing anesthesia, and if we do not take timely measures when the bradycardia is happening, the patient may land into cardiac arrest. Then finally, a combination of patient's factors can prevent the use of routine monitors. Features of cardiac arrest in the perioperative setting, there can be certain features which are seen in the perioperative setting, like ECG is showing pulseless rhythms. So we should not dismiss it straight away that some lead may be dislodged or it is due to the cautery interference. We should immediately start looking for the cause, and we should immediately start instituting the measures. So, and then if there is a loss of carotid pulse for more than 10 seconds, loss of ETCO2 trace and loss of plethysmograph can happen. And if the arterial line tracing is in place, which can be very much the case if the patient we expected we are anesthetizing is a high risk case, generally we will secure a arterial line tracing, and if that goes, that is also one of the early indicator. However, loss of end-tidal carbon dioxide is the most reliable, and it is an immediate measure which can show you the possibility of cardiac arrest in the patient. So we should always at all times keep the end-tidal CO2 monitor, check for it that it is working, and it should always be used in all kind of anesthesia. Pulseless cardiac arrest, as described by AHA in 2015, had two branches, that is shockable and non-shockable. That is VTVF was the shockable rhythm, and pulseless electrical activity in asystole was a non-shockable rhythm. So it mainly focused on high quality CPR and early defibrillation. It focused on giving epinephrine every 3 to 5 minutes, diagnosing using 5H and 5Ts. And VTVF, in case of VTVF, it was refractory to shock, then use of lignocaine and amiodarone were advocated. Article by Moetra et al. Specifically focused on ACLS algorithm, which are specific for the perioperative period. So they what the main key points in their article were to look for specific intraoperative causes which are prevalent at high incidence during the perioperative cardiac arrest. They advocated the use of calcium chloride for in the algorithm for VT due to hyperkalemia. Then vasopressin was still on the algorithm as a epinephrine alternative. Epinephrine, instead of the 1 milligram boluses 3 to 5 minutes, it was advocated to be used as a titrated boluses of 0.1 to 1 milligram. Also, perioperative cardiac arrest, we should think of early ECMO or rescue PTCA because these are most of the time very reversible causes. However, the mainstays still remain early and quality CPR and defibrillation. So never forget uninterrupted chest compression even intraoperatively whenever any kind of such crisis happens. And we should always avoid hyperventilation, which are the basic principles for ACLS also. So the immediate action whenever such a crisis happens intraoperatively is first to declare cardiac arrest to the theatre team. We should not withhold the information from the theatre team because we work as a team and they need to be aware of such kind of crisis. We should declare it to the team and we should note the time when it happened. We should notify the surgeon to stop surgery and to start evaluating any kind of surgical variables like traction on a gut, anything which could have contributed to the this kind of situation. Then we should turn off or reduce our anesthetic agents, provide 100% oxygen. We should give boluses of IV fluids, ensure that vascular access is adequate. If it is not, then we should always secure a wide bore vascular access. We should delegate one person immediately to chest compressions because instituting the chest compressions timely is the most important parameter, is the most important factor in restoring the circulation. So we should immediately call for help, which is a very important thing. Even if you think that you are very senior and you can manage the crisis yourself, you want to hide the thing, you don't want to declare it to the other people. In such a situation, the patient safety comes first and your own ego and rest of the things come last. So we should always at all cost call for the next senior which is nearby, and we should call on any emergency number which is there. We should always immediately summon the cardiac arrest trolley, and as soon as possible we should start evaluating the potential causes, that is the 5H and 5Ts and anesthesia specific causes. Then ensure adequate delivery. We should ensure that the airway is maintained patent and the ventilation is happening, and we should increase the fresh gas flow, provide 100% oxygen. We will not be able to provide ventilation with the low flows which we are using during our anesthesia, and we should provide 100% oxygen instead of using air at such time. And we should check the measured FiO2 whether what we are delivering is actually being delivered. Then we should check the breathing system valves whether they are functioning, because we should start from the equipment end and reach the patient end while we are making any such diagnosis for a patient, especially for a patient who is having hypoxia. So we should ensure a secure airway, provide 100% oxygen, evaluate the EtCO2 graph, whether the ventilation is happening properly. And for acute changes, we should monitor, and rapid hemodynamic assessment should
Looks like there's some problem from the internet. Sorry, Anju, I think you went offline. Can you switch on your mic, can you? Yeah.
Yes, sir. Sir, am I audible?
Yeah, you're audible. I think your PowerPoint.
Sir, am I don't know. I'll share screen again, sir.
Yeah, no problem.
Sir, it is I'm not able to share the screen, sir. It is showing.
No, no, you say it has started sharing. It says this started sharing screen, but it's not come up yet.
Sir, are my slides visible, sir?
No, they're not.
Now, sir?
Yeah, there. It is fine. Yeah.
Sorry, sir. Probably
No
some.
problem. Yeah.
So I'll begin again. The immediate measures, I've already discussed that we should start looking out for causes which can prevent oxygen delivery. We should ensure a patent airway, give 100% oxygen, increase the flows, check for the breathing system is intact or not. We should confirm that the bellows are moving, provide manual ventilation, and evaluate the EtCO2 graph whether the ventilation is happening properly. And it can also be used as a rapid hemodynamic assessment, because in case of anaphylaxis or any such cause which can lead to a reduction in the acute reduction in the cardiac output, there will be a sudden fall in EtCO2, which is a very good indicator. In addition to this, we can consider POCUS. We can get chest X-ray done if fluoro is available inside the OT, and TE if the expertise is available. Then airway, we should check the position for the airway device intraoperatively and during induction. Airway not being able to secure the airway is one very important cause, and even intraoperatively sometimes the tube may get blocked. So we should always check the position of the device, and we should listen for any accidental extubation may have happened. So we should always auscultate and ensure that the airway is patent. If we suspect that the tube may be blocked due to any reason, we can pass the suction catheter and confirm that the tube is patent. If the expired CO2 is absent and we had intubated, then we should always we should think about esophageal intubation, and we should when in doubt take it out as a dictum in such situations. Then for breathing, we should check for symmetry of chest, breathing breath rates, SpO2, measured expired volume, EtCO2. We should evaluate airway pressures by switching over to manual ventilation. We can feel the compliance of the bag, and this will also help us in diagnosing sudden bronchospasm, these kind of things. For circulation, we should check the rate and adequacy of chest compressions. That can be done by titrating our CPR to an arterial line diastolic pressure of 40 millimeter mercury and an end-tidal CO2 of a value more than 20 millimeter mercury. This is the same which has been advocated by the ACLS algorithm also. We should always encourage rotation of the personnel which are performing compressions to maintain the quality of compressions. Then if IV access fails, then next possible option to give the drugs and fluids is intraosseous route. We should always, even during intraoperative period, should not forget that we have that option also available. Then ECG rhythm should not be checked for more than 5 seconds because we want to minimize the minimize the interruption in the chest compression. We should systematically evaluate the potential underlying causes. We should start thinking in our mind what could have happened depending on the with the background of the patient's pathologies and preoperative status. We can start thinking of the most probable causes and we should act accordingly. And then if we attain a return of spontaneous circulation, we should decide on the final surgical plan with the surgeon in the team. So there are certain drugs in the perioperative cardiac arrest which have been recommended, and the doses like fluid should be given in boluses of 20 ml per kg. For an adult, of one single whack of normal saline or ringer lactate can be rushed immediately. Then adrenaline is given in the dose of 10 mics per kg. Adults generally we give 1 milligram bolus, but it can be given in increments of 0.1 milligram. Atropine is given in the dose of 10 mics per kg. And for an adult, it is recommended to be given in the dose of 0.5 to 1 milligram. If the vagal tone, the vagal tone is the most likely cause. Like in cases where there has been a visceral tug and this thing happens under neuraxial block, the most common cause is the high vagal tone, and then atropine can be used. Otherwise, atropine is out of the ACLS algorithm. So amiodarone 5 milligram per kg for children, and in adults generally for a cardiac arrest situation we give directly 300 milligram bolus after the third shock. This is given in a shock refractory kind of cardiac arrest. Magnesium should be considered for polymorphic VT, and if hypomagnesemia is suspected to be the cause, like in patients who are chronically malnourished and certain category of patients where hypomagnesemia has been persistent, and we know that, so this can be tried. Calcium chloride is a recommended drug for cardiac arrest in perioperative period, because hypocalcemia and hyperkalemia are a very prominent cause of VT rhythm during the perioperative period. So this can be tried. And in case we are suspecting a massive pulmonary embolus in patients who stand at a high risk of pulmonary embolism, we can consider thrombolysis. Now, don't forget defibrillation perioperatively also. So continue compressions while you are charging your defibrillator. Always, whenever you anesthetize at a new location, you should always check your defibrillator first thing in the morning. You should check it yourself. Even technicians do that, but don't rely on other person for the life of the patient. Defibrillator should be checked yourself every day whether it is charged, and it should be given when initial cardiac compression is not effective in relieving the return of spontaneous circulation. We should immediately start charging the defibrillator and give a 4 joules per kg for children and 150 to 200 joules depending on the type of the defibrillator. Biphasic current should be given. We should not check the pulse but immediately start chest compressions immediately following the defibrillation. Sometimes in cardiac catheterization lab, it has been recommended that we should use the 3 stacked shocks. It provides a better kind of return of spontaneous circulation. We should never forget that to use EtCO2, because if case we are giving compression and there is no cardiac, no EtCO2 capnograph is seen, then one possible cause can be esophageal intubation. Rarely CPR may not be efficient and pulmonary circulation may be disconnected from the systemic, like in major trauma, like for pericardial tamponade or tension pneumothorax. So CPR may not be effective unless you recognize the cause timely and relieve the cause. Sudden increase in end tidal CO2 is most likely the return of spontaneous circulation, and if there is a sudden rise, then we can check for the central pulse, and if it has returned, then we can institute the post resuscitation measures. Then optimal position should be ensured for chest compression. Your position as well as the patient position should be ensured. If the patient is in lateral position or any abnormal position, patient should be immediately turned to supine position and on a hard mattress, and on the OT table itself the compressions can be instituted. Pregnant patient never ever forget the uterine displacement. Left uterine displacement should always be maintained while providing a small wedge under the hip. So this will be the most appropriate thing. One person in a should be delegated to manually displace the uterus to one side, left side, while you provide the chest compression, if you want the chest compressions to be effective. Then ventilator should be set to volume control at this time. This is a common sense, and we should always avoid hyperventilation. So this is a very useful algorithm for perioperative cardiac arrest. I will discuss it one by one at each step. This was described by Moitra et al. In his article on cardiac arrest in operating room. So this is a comprehensive algorithm which discusses the management and assessment of a patient who undergoes a perioperative cardiac arrest. We should communicate the change in status with the surgeon who is operating. We should call for help immediately. We should check all our monitors like ECG, oximeter, capnometry, skin and field blood color. This is one very good indicator in case the monitors have not been helping you, and sometimes capnograph may not be working. There may be some situation in periphery where EtCO2 may not be available. So if we are vigilant on both sides, on the patient screen, on both sides of the screen, towards our anesthesia side as well as the surgical field side, there will be a dusky coloring of the blood which is oozing from the surgical side. This is one of the indicator. We should complete the check of the circuit immediately, confirm that cardiac arrest has happened, there is a asystole rhythm, A-line tracing, or there is a VT-VF. Then we can check for the central pulse, plethysmograph, capnogram, call for help, defibrillator should be charged, hold the surgery, discontinue anesthesia, discontinue your anesthetic agent, inhalational agent, start ventilating with 100% oxygen, start rushing the fluid, start CPR at the rate of 100 to 120 per minute, and titrate the CPR to a EtCO2 of more than 20 millimeter mercury and diastolic blood pressure of more than 40 millimeter mercury. We should avoid hyperventilation at all costs because it will reduce the venous return, and we should always maintain a patent airway. We should simultaneously start thinking whether it was related to a increased vagal tone or it was related to hypovolemia due to excessive blood loss. Was it related to any possible air embolism or gas embolism, thromboembolism or fat embolism, or whether the regional anesthesia had been given shortly and it can be related to any kind of local anesthetic toxicity, whether hyperkalemia can be a cause in patients who have existing risk factors. We should always start thinking on these lines. Then we should decide whether the rhythm is shockable or non-shockable. Shockable rhythm like VTVF, the management part remains almost the same like your ACLS algorithm. We should give one shock immediately using 120 to 200 joules biphasic, then resume CPR immediately, and we should give calcium chloride 1 gram IV in case of a VT, ventricular tachycardia, and if the patient had some existing risk factor and you suspect that these can be if there is a high index of suspicion for hyperkalemia as a cause, we should immediately give calcium chloride. If CO2 is more than 20 millimeter mercury on capnometer, we should check for the rhythm, and if the rhythm is still shockable, we should continue CPR and give one shock, resume CPR immediately. Epinephrine can be given in titrated doses, especially for conditions like local anesthetic toxicity. It has been recommended not to give 1 milligram bolus stat. Instead, start with 0.1 milligram boluses, and we can repeat it timely at the interval of 3 to 5 minutes. We can also replace, this algorithm suggests that we can replace 1 dose of epinephrine with 40 units of vasopressin. So then if CO2 is maintained at more than 20 millimeter mercury, then we can again stop and check rhythm and check whether it is still shockable, give another shock, then resume CPR. Now we can consider antiarrhythmics after 3 shocks, and the antiarrhythmics which are preferred is amiodarone in the dose of 300 milligram IV. Always remember, whenever you give any drug for cardiac arrest, we have to follow it up with a bolus of saline so that it reaches the central circulation. So we should always give a 20 ml saline bolus and elevate the limb so that the drug is effective. Then as an alternative, lignocaine 1 to 1.5 milligram per kg IV is also recommended. Magnesium sulfate can be given 2 gram IV in patients with polymorphic ventricular tachycardia like torsades, especially in patients who are known cases of prolonged QT syndrome. Because in preoperative evaluation, ECG is done in many cases, and we will know whether a prolonged QT syndrome is existing. And we can use always POCUS or transesophageal echocardiography to diagnose. And this algorithm also suggests that we should consider an early institution of ECMO and rescue PTCA. Then for algorithm which is, if the initial rhythm was found to be asystole or PEA, that is non-shockable, similar to the ACLS algorithm, we should immediately start providing high quality CPR. Chest compressions should be given at the rate of 100 to 120. Good quality chest compression with a chest compression of 5 to 6 centimeters, and avoiding hyperventilation. These all things should be maintained. While we institute echocardiography or focused ultrasound, which may rule out many of the causes of asystole and PEA, then epinephrine can similarly be given in titrated doses, and 1 dose of epinephrine can be replaced with vasopressin according to this algorithm. And if hyperkalemia remains one differential, then calcium chloride could also be considered. Now, common causes of asystole rhythm, pulseless electrical activity especially, it can be ruled out by using POCUS most of the times, and we should start thinking that whether it is a hypovolemia, tamponade, tension pneumothorax, otopeep is also one cause in mechanical ventilation. Then any kind of embolism can also lead to PEA. And high neuraxial should always be a differential in cases where the surgery is being done in neuraxial block. Intra-abdominal hypertension can be used can be one of the cause of PEA, because the rhythm will be maintained but the circulation will not be there, because there will be no venous return. Then we should check for ST segment and T wave in case we are suspecting a intraoperative MI. If all these things have been done and specific measures have been instituted and still there is no return of spontaneous circulation, then we should always simultaneously keep on checking in between whether the rhythm has now become shockable. If the rhythm has become shockable, then we can go to the first algorithm and we can start giving shocks. If it has not turned after many cycles of CPR, then and the rhythm is still non-shockable, then we should start considering early ECMO. We should always titrate our CPR to a ETCO2 of more than 20 and diastolic pressure of more than 40, because sometimes arterial line trace is there, arterial line is in place, but we are not aware of these factors, so we are not looking for them. So we should always look for these and titrate provide a good quality CPR, which will definitely improve the patient outcomes. So extracorporeal CPR nowadays, there is a lot of literature coming up on eCPR. ECMO is the use of extracorporeal circuit and gas exchange to provide temporary relief, temporary circulation to the patients who have been found to have a reversible cause of pulmonary and cardiac failure. So in such cases, to restore and to maintain the circulation for time being, till that patient recovers spontaneously, or by our management, the patient, the cardiorespiratory system, they revert back to the normal function. Till that time, we can provide eCPR. Now there is one entity known as prone CPR. There are many surgeries like neurosurgery, spine surgeries, which are done in prone position. And if such a patient lands into cardiac arrest, it is always a good idea to start providing a prone CPR till the time we can we are ready to shift the patient to supine position. And sometimes even this prone CPR is so effective that it itself may restore the spontaneous circulation if the event which happened was a very transient event. So it can be provided by placing our hands on both sides of the incision on the at the level of almost scapula, or we can place a hand on one side of the chest, and on other side we can keep a fist below the sternum and we can provide the chest compression, because the heart needs to be compressed between two rigid structures. So it has been seen that even this kind of prone CPR provides a very good outcome, because it reduces the time to first compression which the patient receives. Because in case we wait for the patient to be turned supine, until that time patient does not receive any kind of CPR, the outcomes may be worse. And for perioperative cardiac arrest, we should remember that for prevention is the best cure. So we should at all times remember this crisis resource management algorithm, which will prevent most of such crisis events if we follow it religiously. Like, we should call for help early. We should delegate one team leader we should know that who is the leading the team, so that everyone is not deciding for themselves, and everyone should be a good follower who is listening to the leader, and as well as who can provide. The leader should also in turn be such that he can listen to the team members in a constructive way to improve the patient outcome. Ultimately, what is important is the patient outcome. We should always have the clarity of the roles. Who will do what, who has what limitation, who is good at what skill. Everyone should be aware of that. We should distribute the workload. Every team member should be assigned specific tasks according to their capabilities and limitations. And in case someone is overworked or someone is not failed to do, we should always revise the distribution, and we should always keep on revising whether the instructions which have been given are being followed carefully. Then we should communicate effectively with each other. There should be no fear among the team members that they cannot communicate things to the leader, and vice versa. We should anticipate and plan timely. We should know our environment well. We should use all available resources, allocate attention to all the things. We should avoid getting fixated. Fixation error is known to be one important cause of such kind of crisis. We should mobilize all the resources well, including equipment, additional help. Everything should be mobilized quickly, and we should always start using cognitive aids, like we should use the all kind of media or social and on resources on internet. Everything can be utilized to our benefit in case we are aware and we know how to use it. So we should support the effective use of all cognitive aids. We can paste such kind of crisis algorithm in our OT for easy referral. So all these things can be done. So to summarize, intraoperative cardiac arrest has some unique causes which are specific to the operating room environment, and rapid evaluation and management of these causes generally require some kind of modification in the traditional algorithm, which we should be aware of. And these events are mostly witnessed, and rescue and provider have the knowledge of the baseline status of the patient and the procedure which is ongoing. So these kind of arrests have a very good prognosis if managed timely. Manage of the perioperative cardiac arrest patient should be based on expert opinion, physiological rationale of the CPR. We should simultaneously evaluate and treat. We should keep the specific intraoperative causes of cardiac arrest in our mind and act accordingly. And we should have the understanding of the context in which all these events are happening. So it is important to always remember that CPR is not a definitive treatment of cardiac arrest, but it is only a means of establishing and maintaining respiration and circulation till the time the underlying pathology which led to the cardiac arrest can be corrected. Thank you everyone for your patient listening, and thank you Shiv sir for the opportunity again. Can I stop share, sir?
Thank you. Yeah, thank you, Anju.
Thank you, sir. Any questions? I'll be happy.
There are no questions, and I think somebody has commented on your lecture. He said that it's gone beyond 20 minutes, but don't worry about that.
I'm sorry about that.
No worries. It is a topic. I think I need to actually change the timing on the lectures, because some lectures will take slightly longer than the others. So moving on to the next topic. This is on intraoperative hypoxia, desaturation, and sinuses. And Dr. Minati will be covering this topic. She's professor at the Cardiothoracic and Vascular, well, CTC it was called. I think it is still called CTC, Cardiothoracic Center, or CNC, Cardiothoracic and Neuro Center it used to be.
It used to be Cardiothoracic and Neurosciences Center, but now we called it Cardiothoracic Sciences Center and Neurosciences Center separately. We are having two different letter pad nowadays.
Yeah. The red building, as it used to be called.
Yes, now the people also know it as a red building only now also.
Yeah. Okay. Yeah. So again, Minati is a great contributor for our cardiac symposiums. But today she is going to take us through two topics. I mean, the first one, she'll come back again with a topic on lactates, but now she's going to take us through hypoxia, desaturation sinuses, and how to recognize it, how to assess it, and how to manage it. Over to you, Minati.
Thank you, Dr. C, for the opportunity. And I think I am audible clearly and my screen is visible.
Yes, there it is.
Okay. So in the next 20-25 minutes, we are going to discuss about hypoxemia, desaturation, and cyanosis. I have no conflict of interest. And at the end of this lecture, you will understand what is hypoxia, desaturation, and cyanosis, how to recognize the problem perioperatively, assessment in general, management, the basic management, because the specific management belongs to some disease condition and some emergency situation which can be dealt by different speakers, and some case studies. So desaturation basically is a reflection of the hypoxia or hypoxemia. This is a pulse oximeter finding. And when you can say the patient is desaturating, when the saturation is less than 95% for more than 10 seconds, or but provided the patient should not be a cyanotic child or cyanotic adult, should not be obese and having any airway difficulties. In this situation, the definition is a bit different, and you should correlate the decrease from the baseline of their respective value. Hypoxia is failure of oxygenation at the tissue level, and it is a varied etiology. It can be anemic, stagnant, histotoxic, or hypoxemic. And in this talk, we are basically will deal with the hypoxemic hypoxia. Because anemic hypoxia, the hypoxia come in a very low hemoglobin situation, that is a different situation at all, and we're not going to deal with that extensively. And hypoxemia, again, when you are measuring the arterial oxygen tension, if it is less than normal, means that it's less than 80 to 100 millimeter of mercury, then you can call it hypoxemia. And excess degree of hypoxemia may manifest as a cyanosis. And you should understand hypoxia and hypoxemia may or may not occur together, especially suppose patient is anemic. Patient is having hypoxia at the tissue level. If it is 10, suppose the hemoglobin level is 10 and tissue level hypoxia is there, but certainly it cannot be manifest in the pulse oximeter reading, or your PO2 may be normal in the room air, or it doesn't show a decreasing in trend. But hypoxemia is the most important cause of tissue hypoxia. And cyanosis, as I said, it manifests later in hypoxia. So we may not observe cyanosis because it is manifested once the marked desaturation is there, and this is because we have pulse oximetry as a boon. So that is the reason we cannot see hypoxia. Desaturation is most of the time is the first warning in the many of the incidences. The causes of hypoxia are many, and starting from the airway, it can be laryngospasm, aspiration, difficult intubation, and it can be related to breathing like hyperventilation, bronchospasm, pulmonary edema. Or there may be hypotension, very low blood pressure, bradycardia, myocardial ischemia. It can be related to some drugs. They can cause also hypoxia and desaturation. And you should not forget pneumothorax, pulmonary embolism, and anaphylaxis as a source of hypoxia as well. In the perioperative period, it can occur at any point, starting from induction, maintenance, and recovery. But what is more important, if you have to act immediately. If there is prolonged desaturation, it may lead to infarction, lobar collapse, and the cardiac arrest. So the general management, you have to go like, as Dr. Anju said, like to manage a patient who is having impending cardiac arrest, A, B, C, D, etc. And you should understand that, and you should remember, and before managing the patient who is getting hypoxia or desaturating, the displacement of the probe, you should check it first, because this is the one of the most common thing, and equipment malfunction as such, any leaking. So these things are usually not noticed and usually avoided. We jump for more difficult causes. So these things should be checked first. So coming to the airway, you should look for if the patient is on the marks or additive, if there is any position is correct, if there is a leak, you have to observe and see the additive position. You should see the cuff inflated or not properly, if there is any leak side, if there is any sound, and you should exclude aspiration, laryngospasm, any obstruction at the same time in the additive or in the laryngeal marks area. Once you are confirmed that airway is patent and protected, you see what is the breathing pattern, even if the patient is spontaneously breathing or you are giving IPPB, and you have to observe, you have to auscultate, rule out any bronchospasm, any edema, any hyperventilation, and address the situation accordingly. Even again, extensive blood loss can give rise to hypoxia, and look for the ECG changes. If there is any bradycardia, tachycardia, or any ECG changes, ST segment changes, if there is an impending arrest. So you have to manage the impending cardiac arrest, as Dr. Anju said, and immediately you can administer some crystalloid blood or vasopressor and CPR also. Drugs, and you have to check whatever drug you have given. At time drug error also causes hypoxia, and whether the lines are erroneously flushed with some drug, or if there is any anaphylaxis reaction, and get ready with the antidote accordingly. And especially you should not forget any air embolism, any air in the pleura, any pneumothorax, and in perioperative period when the patient is desaturating. So every point of time you check the patient, you talk with the surgeon, communicate with the surgeon, and you hold the surgery if possible, and to find out the cause and treat it, and then go ahead. So the most common causes again in the perioperative period are endobronchial intubation, bronchospasm, bronchial plug, and excessive bronchial secretion, especially in small kids, and obesity syndrome. Most of the obese patients, they suddenly desaturated during induction as such because of less of FRC. So you have to be careful about this common cause. In emergency cases also hypoxemia occur, and you have to do a quick check in oxygen supply, anesthetic machine, anesthetic circuit. If there is any leak anywhere, if the patient is having a patent airway, you have to exclude any obstruction either in the filter or in the native airway itself. Look for if the patient is getting ventilated adequately, if the chest movement is all right, if the bilateral air entry is all right, if there is any sound or any decrease in the sound at any side of the chest, if the patient is having any low cardiac output syndrome, or if the tissue uptake is very high, especially in case of fever, thyrotoxic crisis, etc. So you have to rule out all these cases things simultaneously. Again, if there is hypoxia, if there is any leak and disconnection of the machine, there is transient apnea. This can give rise to increase in PaCO2 to 8 to 15 millimeter mercury in the first minute, and then it decreases down to 3 millimeter mercury per minute. So you have to rule out all the causes of decrease in end-tidal carbon dioxide, but there are many causes, especially in the esophageal intubation, accidental extubation, air leak again, and ventilator setting. At times you should not forget, suppose patient is not hypoxic but EtCO2 is decreased down. If you are doing over enthusiastic bagging, in this case also EtCO2 will go down. Higher pressure, in some patient having hypoxia have higher pressure. In this condition also, you have to check the entire equipment circuit, starting from the gas supply, anesthesia circuit, patient airway, and pleural space, patient chest wall movement. All these things should not have any obstructive lesion at any part of the thing. So you have to rule out any atelectasis, pulmonary edema, or endobronchial intubation at the same point of time, because all these things, they give rise to higher pressure. So now come to few cases. We'll see how we manage the perioperative hypoxia, desaturation, and cyanosis. The first case is a small baby for PDA ligation, and the patient was otherwise normal. You can see after draping, the saturation was 100%, and the things looks perfect. There is no tachycardia. It was perfect for the age, and blood pressure is normal. FiO2 was 50%, and however, after 5 minutes, the saturation just suddenly started falling from 93 to 87. So we just asked the surgeon to stop for some time, and we thought there might be some leak, and increase the fresh gas flow to 8 liters per minute, and we increased the oxygenation also 100% FiO2, but the major FiO2 was 67%, and pulse oximeter was fixed all right. Chest movement was, however, was a decrease visually. And visual inspection of the entire breathing system show that all connectors are intact at the machine end. And then we thought probably it is for a transient period, but however the saturation was getting down, and 1 minute later you can see the EtCO2 curve, and plus the anesthesia machine showed the fresh gas signal, leak signal at the same time. And the FiO2 was 100, the inspire O2 was 65, and the expire O2 was 50. and just the ET tube and the circuit connection junction was checked, and it was there was some loose connection at the same at that time, and it was underneath the drape, so it was not visible, and we missed it at that point of time. So connection was established, and manual ventilation was given, and after 3 to 4 breath and post correction 50% FiO2, you can see the saturation was increased and everything become fine. The second child, again a small child, and planned for plastic surgery under GA, and she was otherwise normal. The surgical duration was 1.5 hours, and before the final skin closure, there was sudden fall in saturation to 95%, and it's shown a decreasing trend. That time we were planned to extubate the child, reverse the child and extubate the child, but we stopped that plan, and we increased the fresh gas flow thinking some leakage there, but there was no change, and the expire FiO2 was 89%, and there was no fault in the machinery end, and ventilator belows are moving nicely, and but however patient was taken manually. There was moderate resistance in the bag was found, and there was a pulse oximeter was placed perfectly, and extremities also warm. They didn't show any sign of poor perfusion. So we thought there might be some bronchospasm, or there might be some mucus plug inside the tube because the child is small. So bilateral air entry on what we visualized was decreased. On auscultation, there was fine crepe, and capnograph shape shows the feature of obstruction in the airway breathing circuit. The HMP filter filled with pink product secretion, it was removed, ET suction was done, and manual ventilation was started. There was mild improvement in the situation, and patient was reconnected into the anesthesia machine. The airway pressure at the same time keep on increasing to 40 millimeter of mercury, and the resistance was also increased while manually ventilated. So we thought the probable cause was pulmonary edema secondary to accidental fluid overload, and which gave rise to bronchospasm and hypoxia and desaturation. The dose of relaxant was repeated, and the blood pressure was mildly down. 88/56 was 110 before, and the heart rate was 130 per minute and regular. The child was done head up position. The maintenance fluid was stopped. Furosemide was given 1 milligram per kg. Terifilin was given, and as there was no sign of awakening, and the last dose was given at 40 minutes ago. So we planned for elective ventilation for 1 to 2 hours. So he was shifted to ICU, and elective ventilation was given at the PEEP of 8. Diuresis was started, and the maintenance fluid was restricted to 1 ml per kg per hour, the chest was clear, and 30 minutes later the things improved, saturation became 100%, and blood pressure was 112/65, and the child was awake at 1 hour 40 minutes, and she was struggling, and CPAP was given for 20 minutes till full recovery, and she was extubated, and there was no extubation sequel. Third case is again a small child, 800 gram for quart repairs, and he was admitted for quite some time because of the prematurity, and in the NICU, and in the air over everything was looking fine, and but there was some leak in the ET tube, so we changed the ET tube, and we thought we will put a femoral artery for measurement of both radial and femoral pressure, because it was a case of coarctation by aorta. But while the positioning, we saw the saturation gradually drop down, and heart rate was increased to 180 per minute. So ABG shows a quick ABG was done, and PaO2 was 78 millimeter mercury, and the initial value was 92 millimeter mercury. So diagnosis of the desaturation with hypoxemia was done, and the cannulation procedure stopped. Again, the same thing, we increased the fresh gas flow, 100% oxygen, but however, nothing was changed. There was no leak anywhere, and equipment was perfect, and endotracheal tube was perfect. But however, because the baby was small, reservoir bag compliance could not be appreciated. So there was no problem in the pulse oximeter, and there was no sign of poor perfusion again. And there was capnograph shape was looking like this, and ET suction, nothing specific came out. Manual ventilation was done without any connector. We thought maybe there is some resistance because of the connector, because the child is small. So without any connector, we started manually ventilation, but however, this decreased the SpO2 further, and cyanosis appear at the same time. Heart rate again reduced down to 116 per minute. BP further decreased 45 to 35. Volume infusion 5 to 10 ml. There was no improvement. So we diagnosed it again a hypoxia, desaturation cyanosis with hemodynamic instability, and but problem in the airway excluded as a cause. But we noticed there was a gross decrease on the chest movement on the right side of the chest, and there is decreased ETCO2 with the obstructive pattern persistent in the capnogram. There is absence breath sound on the right chest, and there is massive increase in the peak airway pressure and the plateau pressure. So we thought there might be pneumothorax, and it is tension pneumothorax again, and the probable cause might be barotrauma because of low birth weight, premature lung, prolonged ventilatory support, and manual ventilation could be added more tidal volume. So the child again didn't respond to noradrenaline also for the to support the hemodynamic, and which was that because this hypoxia is because secondary to pneumothorax, so we have to take out the cause. So a 16 French chest tube in the right fourth intercostal space in the anteaxillary line was put and connected to a water cell drainage, and gauge of air came out. There was improvement in circulation to 95%, and then 100% over 15 minutes, and but the surgery was postponed to the second day. And the final case is again posted for mitral valve surgery. Patient was otherwise normal, and this lady has LSCS under general anesthesia, which was uneventful. She was on digoxin and diuretic, and during draping we found a sudden increase in heart rate, and patient started desaturation. Saturation came down from 95 to 88 and so on. However, the blood pressure does not have any change. So the surgeon was requested not to start the surgery, and we follow all the parameter again, increase F5 to quick check of everything, and everything was normal. The ventilator graph, there it doesn't show any leak, and ventilator bellows was moving perfectly, and the pulse oximeter was again normal, and there was no sign of poor perfusion. Endobronchial intubation was excluded because tube was fixed at 20 millimeter mark, and capnograph again no change in shape, and the patent airway is confirmed. But however, pink for the secretion in ETT was noted with blockage of HMB filter, and connector was replaced. Manual ventilation was done. There was no improvement. Patient was reconnected with the machine. And then chest wall movement, it was bilaterally symmetrical, but it was decreased, and at the same time in the next 2-3 minutes the peak airway pressure started increasing. Manual ventilation, we came to know there is moderate decrease in the compliance, and the depth of anesthesia and muscle relaxant was reconfirmed again, because this can also be cause of decrease in compliance, but this was adequate as noted by the BIS monitor. And this patient was accidentally transfused 1 liter of ringer lactate, and the CBP was suddenly increased. The blood pressure say 65 to 56, heart rate was again 95 and regular. So the potential cause was pulmonary edema, and the probable cause was cardiogenic plus fluid overload. This patient was done reverse trundle position. Rapid ET suction was done to take out the froth. HMB filter was changed. She was given diuresis, and afterload reducing agent was given NTG, and plus adrenaline 0.1 mic per kg per hour started. She was ventilated with the PEEP of 8. And 12 to 15 minutes later, the ETT was clear, blood pressure, heart rate, and CBP was improved, and the peak airway pressure also decreased down, and the surgery was proceeded further. So the hypoxia, desaturation, and cyanosis can happen any phase of the anesthesia, and mostly it happen in 90% things are happen at the induction and at the maintenance rather than the recovery. And the assessment should be quick, within a minute or two, so that you should not lose the patient. Always start with a check for oxygen delivery, airway, and breathing circuit functioning, and check for the chest movement and auscultate for the breath sound, and patient is not draped, and chest movement or lung movement when the chest is open. It is important to feel the compliance of the reservoir bag, confirm the adequate depth of anesthesia and the muscle relaxant, because inadequate depth may be a cause of bronchospasm leading to follow-up saturation, and you can misdiagnose a problem also. So treat the unstable conditions simultaneously, if any. If there is laryngospasm, bronchospasm, drug error, pneumothorax, pulmonary edema, you have to treat everything at the same point of time while you are checking your machine, and also you always should ask for the help. Find out all the routine causes and manage. They are especially in the child. Increase in secretion is one of the causes, and while difficult intubation, inadequate oxygenation, all these things should not be forget. Again, you should not forget undiagnosed congenital heart disease. At times it is missed, especially when the person is coming for a emergency surgery. So if no improvement in the routine checkup, you always should go for a ABG and chest X-ray in closed chest situation for the further management. And you should remember that monitoring equipment are reliable, but failure may happen. So clinical judgment is extremely important, and it should go with the monitoring at the same point of time. So always call for a help, because patient safety is utmost important. So thank you so much.
Thank you, Minati, and for a nice presentation. I'm going to actually cover the next one for Shabahat, and mine will be like a summary of your presentation, basically. It's about increased airway pressure. So it makes things very clear for people. Obviously, it will also be like a recapitulation of what you have discussed, causes for it, hypoxia and for desaturation. So similar things will be discussed in the next lecture. Again, I don't see any questions, but if any of the panel members want to actually add anything, you're most welcome. Otherwise, we will.
One person has asked, Hemant sir has asked, each quad child, why after treating pneumothorax surgery was postponed next day? You have to start from scratch. Was any central line was inserted? Yes, central line was inserted at that point of time. And because surgeon was not comfortable, because the child was very small, 1800 gram only, and there was a lot of intervention during that time, putting a chest tube, and they were thinking there might be some extra hemodynamic instability and all. So let's wait for 1 day, because child was already waiting for 4 days. So why not to wait for 1 day? So that's the reason we just postponed the surgery. It was nothing else.
Yeah, well, this symposium is more to do with the causes of various conditions we face, crises we face. I think the decision whether the patient we need to go ahead with the surgery, or we need to, wait or go ahead, will depend on the discussion between the team. It's not, can't be at least said, okay, yes, we will, because this has happened, we need to postpone, or this has happened, we continue. It is always a decision between the surgeon and the team, the anesthetist and rest of the team. They decide what is the best for the patient. I think in any crisis situation, you actually have to take a step back. I know your ultimate aim is to actually get the surgery done, but here it is better to take a step back and think what is the next best thing for the patient, because patient has come through a crisis now. Will putting the patient to surgery increases risk? That is more important.
Because this child also had bronchopulmonary dysplasia.
Yeah.
And necrotizing enterocolitis. So many things were simultaneously was there with the child. So we thought better to relax the child for some time, and then we'll go for it.
Can I ask
Maybe
one more
stabilization?
question?
Yes, stabilization matter. Sorry, Dr. Hemant.
Can I ask one more question?
Ji, sir, ji.
See, which side did you put the central line? Is it on the right side?
Right side, sir.
So that may be the cause of pneumothorax.
No, that is not the cause of pneumothorax. We put the line on the neck only.
So that may be the cause of pneumothorax, because I make it a point that in children specifically, if the thoracotomy is on the left side, I put left interjugular vein cannula. If thoracotomy is on the right side, I go for the right interjugular vein. That is very important in pediatric patients, because a small pneumothorax.
We routinely go for the right IJB. I never seen IJB causing pneumothorax.
So you should, that is how it should be. So that if there is a problem, you are anyway opening the chest, thorax. So it is treatable. So we don't have to get into problems like that. So whichever side,
because
even during lung resection, I always put on the side of the thoracotomy. It is very easy.
we usually go like this. Unless there is a LSBC, then we go on the left side. Otherwise,
We are not talking about LSVC. We are talking about
yeah.
thoracotomy.
Yeah,
Because it's a coarctation.
Even
coarctation.
if it is thoracotomy, if the child is having a LSBC, we go for the left side.
No,
otherwise we go
madam,
for the right side.
we are confusing. I'm not talking about LSVC at all. I'm talking about the coarctation.
You are saying,
Coarctation is
sir,
done on the left thoracotomy. So it is if there are any complications of central or
I
interinterval,
actually agree. I actually
it is
totally agree with
easily
Dr.
manipulated. It is easily diagnosed and easily treated. If you would have put it on the left side that day, this surgery would have been carried out because it takes only 10 seconds.
Okay, I think we need to stop here. I think we need to stop here. This is, I think it's a very valid point that if a patient actually has got a surgery on a particular site and you got a better site on the side, then to actually have a central line in case a complication occurs, you're not affecting. Same thing hold good for thoracotomies for other causes as well.
Yeah.
That it is actually on the side of the where they're going to open the lungs, they're going to open the chest. Then it's easier. You don't want to actually have one side chest which is open and the other side chest which has got this. Then that we are in a bigger crisis. So I think it does make sense in what Dr. Hemant is saying. But then again, this symposium is not about the conditions as such, a particular things, but I think basic things. If we can avoid it, it's possible. Then again, this symposium was about unknowns, and that's why it is important. And this kind of points, when it comes out, it helps in understanding or managing these patients better in the future. Okay, so I think we will actually move on to the next one. Like I said, this is probably a summary of what, I don't know what's happening here. Is my whole screen visible, or is it a split screen?
full screen is visible.
Full screen is visible, okay. Okay, so this lecture was to be taken by Shabahat, but he has got an exam today. So I said, okay, I'll cover it for him. So it's about intraoperative increase in airway pressure, and Minati has actually covered quite a lot of it. So I'm going to keep it pretty brief, not too many slides in this. And none of us have got any financial things to declare, so nothing. So coming to increased airway pressure. Okay. So one of the things which we might notice is a wheezing during general anesthesia. Now, wheezing is actually heard. It's actually may not be there as such if you have an endotracheal tube, but what is evident is the increased airway pressures. Now, these can happen because there is partial obstruction of the tube. If you have pushed the tube too much into the trachea and it is abating the carina, or it's gone into one side of the lung. Intraoperative bronchospasm can actually happen. Patient can go into pulmonary edema. Minati has just covered about that. And in patients who have got this risk of, or who's got full stomach, there is a risk of aspiration. And it doesn't have to be complete aspiration. Microaspiration do happen in patients. And that can also lead to increased airway pressures. Then pulmonary embolism, can happen in patients who are at risk, and that's why all patients should be assessed for DVT. And intention pneumothorax, rare, but especially if you have actually done any procedures near the lungs, so central line through subclavian or through internal jugular. Just now we were discussing about it. And then foreign body into tracheobronchial tree. There are few interesting case reports where patients actually have been, sucking on a what do you call, in a kind of sweet, and they don't tell you, and that got aspirated. There have been also, not only just in the tracheobronchial tree, there are actually case reports where there have been plastic found within the circuit as well, causing obstruction. So you need to look at the whole thing. So you need to go step by step when you're dealing with such problems. So if you need to classify them, we can actually look at anesthesia equipment related problems. Excessive tidal volumes itself can be a cause for increased airway pressures. So you need to make sure it is adjusted to the patient body weight. High inspirative flow rates, again, can lead to that, but not necessarily. But like as mentioned, the foreign body within the anesthetic equipment should actually also be kept in mind. So changing the circuit or having a good inspection of the whole breathing system is equally important. Airway devices, if you're using a much smaller size tube, you've had difficult intubation, you couldn't actually use a size 7.5 or 8 tube and end up putting a 6 size endotracheal tube, that itself can lead to increased airway pressure. Endobronchial intubation, cut the size tube, you use an uncut tube, you pushed it all the way. And sometimes these tubes are actually become flexible with time. And if there is any kink or a block, they will increase the airway pressure. Looking at the patients, obese patients have higher airway pressure. There are a lot of tissues on the chest wall. And so if your patient is lying supine completely, you can actually see that to maintain the tidal volumes, you need to apply much higher pressures. All patient has been put into head down position, as happens in some of the colorectal surgeries. And in patients where pneumoperitoneum is created for laparoscopic surgeries. Tension pneumothorax can develop anytime, and bronchospasm itself, as said, for whatever reason. And the commonest one has to be anaphylaxis. You have to always remember anaphylaxis is the cause of bronchospasm and rule that out quickly. And if you put a stethoscope, you will actually hear expiratory wheeze. There is prolonged expiration, which can be seen as a shark fin waveform on the capnograph. If you're monitoring pressure, you will likely see obviously increased inflation pressure. The patient might desaturate, which is again was covered a minute in the last lecture. The CO2 might actually go up slowly, up and up. So it is not a sudden increase, but with time it will go up. And as shown in the graph on the shark fin sign, there's upsloping because of airway obstruction. And in severe bronchospasm, there could be silent chest. So silent chest is actually more ominous than actually hearing a wheeze. That means that severity it's a severe kind of bronchospasm. So coming to assessment and treatment, when you get this kind of situation, especially if the patient is desaturating, okay, so rapidly desaturating, you do call for help and you increase the oxygen to 100%. You will ask any stimulus which is happening like surgery to be stopped. And you need to actually have access to the chest to be able to auscultate, inspect, palpate, okay, and find out what's actually going on in the chest. Is it just a wheeze or there is no air entry on one side? Is there equal air movement happening? That is very, very important. So you should have a stethoscope available on every anesthesia machine to be able to auscultate the chest. Now, if your depth of anesthesia has not been monitored, or if you have a vaporizer which is actually gone empty, and then the end-tidal anesthetic agent concentration actually comes down, and patient goes light, that is one of the commonest causes for patient actually going to bronchospasm. Some of the agents, now this is actually not true for intraoperative period. It is more to do with the initial, at the time of induction. If you actually use very high concentration isoflurane or desflurane, this can cause airway irritation. But intraoperatively, if you maintain the patient on isoflurane, desflurane, increasing the concentration do not cause bronchoconstriction, rather they are bronchodilators. So this is only at the beginning of the case, not intraoperatively. Again, malpositioning can happen anytime, whether you're using a supraglottic device or endotracheal tube. They can get malpositioned, the cuff can turn, especially the older generation or the first generation endotracheal tube, the supraglottic devices, they used to actually turn around quite a lot. Patients who are edentulous, a lot of space in the mouth, there again, airway actually, the supraglottic devices can get misplaced. And the endotracheal tubes can actually, a patient become light, they chew on them. So again, the concentration of anesthesia need to be ensure the patient is deep enough. And if they have been using neuromuscular blockade, that is working adequately. Okay. And intraoperatively or at the time of induction, if this is happening, do make sure that tube is in the right place. It's not esophageal intubation. or it's not gone too deep. So look at your ausculted both sides, make sure there is air entry bilaterally. And as I mentioned before, when you get bronchoconstriction, do look at these two things carefully. Is there anaphylaxis? Are there other signs of anaphylaxis? Is the patient becoming tachycardic? Is there a rash? Is the airway pressures obviously go up? There is bronchoconstriction. The patient might have rashes. Okay, do consider anaphylaxis. Do rule out anaphylaxis because it's a treatable cause, easily treatable cause. But if not diagnosed or not, if you don't recognize it, then it can lead to catastrophic consequences. Aspiration, especially if you're using a supraglottic device, and if you're, I know everyone wants to use a supraglottic device for things. Make sure that there has not been a silent aspiration. Sometimes the aspiration can be silent. In some patients, you do not know. They might have a hiatus hernia, Tachycardia, which has not been diagnosed. They can still have aspiration, even though they have been fasting. Okay, so do make sure that this is kept in mind. Okay. Treating bronchospasm, we will likely talk about it tomorrow again, because this is unknowns, but salbutamol still remains a first-line treatment. And if you're using the inhalers, okay, so you need to actually give 6 to 8 puffs. Okay, not just 1 or 2. You need to actually give 6 to 8 puffs, because some of these will get deposited within the tube or the airway. So if it has to reach all the way to the lungs, you need to actually deliver at least 6 to 8. There are various methods of actually delivering this, so make sure that you know how you can deliver that. You can use nebulization, but be careful that a lot of things goes on. They dilute the anesthetic gases, and your monitoring will go haywire. The various doses will be covered in the lecture on bronchospasm, so I'm not going to go through it. But again, people have used like second level drugs. Okay, so first line drug, second line drug, which are like hydrocortisone, ketamine. All these things actually come as second line treatment. The first line treatment still remains salbutamol. And if it is anaphylaxis, adrenaline will be your first line treatment. So that's why diagnosis of the cause is very, very important. And you need to also think of what are the mimics for bronchospasm and where you get raised airway pressure. So obstruction of larynx, trachea, bronchi, because of many causes. The patient has got, some anatomical disorders. So we need to look at that. Obstruction in the breathing part, like I said, sometimes plastics within the breathing system can cause. Okay. And pneumothorax, again, high suspicion in patients who are smokers or patients who have got COPD. They will have bullae, which can rupture at any time. And if there is a audible wheeze, always look for pulmonary edema, misplaced devices. Okay. Patients who have got suspicion of they come with sepsis, then think of ARDS. They can go into ARDS, intraoperative lung surgery can go into ARDS. Okay. And towards the end of the surgery, never forget about laryngospasm when you've taken out the tube. Okay, so don't miss out on laryngospasm. What about intraoperative ventilatory strategies? When airway obstruction occurs, main thing is your oxygen. You need to maintain the oxygenation. CO2 is not an issue. Okay, see if CO2 rises, don't worry, 50, 60 millimeters of mercury makes no difference. So permissive hypercapnia is fine. Right? You need to make sure the way you are actually ventilating the patient, make sure there is enough expiratory time for the CO2 to be vented out, or the gases to be vented out. Okay. And in some cases where there is history of asthma or COPD, pressure control ventilation is probably better than your volume control ventilation. And you need to be alerted if there's a breath stacking. So if you're not allowing enough time for expiration, that's what is going to happen, one breath after other. So you need to avoid that as well. And this has already been discussed in the last lecture, management hypoxia, desaturation, cyanosis. Okay, you might in certain situations need to actually get an X-ray into the theater to make out what's going on. Say, for example, there is a foreign body which is you're not able to diagnose that the only way to do is to get a chest X-ray or put a bronchoscope through the endotracheal tube. And in the end, once the patient has recovered and surgery has gone through, you need to think, can this happen in the postoperative period? Again, is there a risk factor for it happening? And in that case, you need to think of where would the patient go postoperatively. Do you need to keep it in a monitored area, or do you need to just have an extended recovery? Think of that as well. Okay. So with this, I will likely end this lecture, and I'm happy to take any questions if you have any. Any thing from the panel members? Any comments or anything to add? Any questions on? Nothing? Okay, okay. So I think then we move on to something more interesting, the cardiovascular system. We covered a bit of respiratory system. I think there was a comment about the cardiac arrest, lecture on the first one by one of the members. Well, I think that's my mistake because I said only 20 minutes, but this is a lecture which actually requires more time. There's lots to cover. It is common to most of the lectures. I'd rather say important part of the crisis management. Cardiac arrest is part of it, important part. It covers a lot of areas. So ideally it should be around 45 minutes lecture. So moving on to, like I said, a bit of cardiac. So we'll be talking about management of blood pressure and heart rate. And the first lecture is by Dheeraj. So I've combined his two lectures. This is hypertension and hypotension. So he'll be talking about both. So this is going to be 40-minute lectures at least. And so interruptive management, hyper and hypotension. Dheeraj, over to you.
Yeah, thank you, sir.
Dheeraj has got quite a lot of degrees. He is actually a person you want to go. I say, if you're a trainee and you want to actually know about examination, how to pass them, okay, do contact Dheeraj. He is done even, European diploma intensive care. He is an intensivist and anesthetist both, and he's a professor at MGIMS Sevagram. So if any one of you have got any things about examination preparation, do get in touch with him. Thank you, Dheeraj.
Thank you, sir. I'm audible, I suppose, sir.
Yes, and your slides are visible as well. So please go on.
So thank you for giving me the opportunity to talk on this topic. And I'll be talking about perioperative, but mostly intraoperative hypertension and hypotension. And we'll be trying to cover this topic within 40 to 45 minutes. I have nothing to declare. So the most important learning objectives for this session, I have tried to keep the animations to the minimum considering the online presentation, is to do through a RAT approach, that is the recognize, assess and treat approach. As it has been very rightly pointed out, the first day of management, the crisis management symposium is all about the unknowns. That is, you don't exactly know what is the reason behind a particular thing, and we are trying to treat a particular sign or a symptom and to fix or temporize it at the starting, and then as the time evolves, then try to get to a specific diagnosis and then come to that part. This is something which is very common. It happens with all of us in our operation theater in day-to-day practices, isn't it? We have a case, we get called by our trainees, or even when we are doing the cases, we suddenly see that there's a tachycardia, there's a hypertension, or the other end of the spectrum, there might be a hypotension, there might be a bradyarrhythmia. So we need to know that how do we approach to this thing. And one of the easiest ways on which this symposium is based upon is the quick reference handbook guidelines for crisis in anesthesia. This is given by the Association of Anesthetists, and this is what the basis of this whole talk is going to be. The approach is going to be very clearly recognize, assess and treat. That is RAT approach. When I talk about recognize, I mean that we need to understand, we need to clearly define as to what is a complication defined as. I mean, like for example, hypertension and hypotension. How do you define it when it is occurring intraoperatively? What are the clinical complaints which can be associated with this? Then the important thing is when you say assessment and treatment, for unknowns, this is very important. I cannot emphasize it enough that both of this has to go simultaneously. You cannot have assessment followed by treatment. In the initially part, the assessment and the treatment, or the recognition and the resuscitation, both of them have to go simultaneously. The assessment part will be definitely answered by the questions what, why, and how of any particular. I mean, what is a hypertension? Why is it happening? How is it happening? And the treatment will be, of course, what is the key basic plan, and then coming to the specific diagnosis based treatment. One important thing I would like to clarify, as everybody is doing in this talk, is we are not going to deal with the pathophysiology of hypertension and hypotension into great detail. That is not what this symposium is about. This is about a quick reference and to get a quick handle on the things when they go wrong, when the crisis is happening in the operation theater or in a peri-operative care for that matter. So just before we go on to this topic, 1 or 2 slides as to why is it so important. The important thing to understand is, and my pointer is visible, you can see that there's a spectrum of a blood pressure. We can have a hypotension on the other side, we can have hypertension on the other side, and there is something as an optimal blood pressure range. Now, this is something which will vary from individual persons. A hypertensive patient, a young patient, this will all have slightly different ranges, but we can still agree that there will be a range to it. Now, if you look at the blue graph and the organ blood flow, what you can see very nicely is that within this optimal blood pressure range, there's a pressure autoregulation happening, and which will sort of balance the fluctuation, even if there's a little bit of fluctuation happening in the blood pressure, and it will ensure that the organs, they get appropriate blood flow. But what happens when you have an extreme of hypotension or hypertension? Your morbidity and mortality, both of them in the increase. Look at the hypotension. If there is a hypotension, your organ blood flow is decreasing, and there will be chances that the morbidity and mortality will go up as the hypotension increases. Same for hypertension. And one very interesting point to note is hypotension causes more amount of morbidity and mortality rather than hypertension. Many times when I talk to trainees, I find that this is probably a concept where they are lacking. They feel that hypertension probably is a more important thing to be dealt as compared to hypotension. Now, one more important thing is the duration of this thing, the hypertension and hypotension, not only the absolute number, that how much it has been fallen or how much it has risen, for how much period it has been above or below the baseline, that also makes a significant difference. And the last thing is the patient baseline characteristics. Of course, as a young patient, they will tolerate more, but a patient who has old age, diabetes, hypertension, comorbidities, whose auto flow is sort of restricted, the organ reserve is restricted, they will have even more problem with even minimal variation. Now, this is a very nice recent article from 2021. They almost had 325 patients who had a significant amount of morbidity, mortality, and they compared it with 326 age-matched and appropriate rest of the parameters matched patients. Now, this is very important. This is from a hypotension point of view. What they seen was there is an increased odds for post-operative myocardial infarction, especially type 2, 3 times if the systolic blood pressure decreases by 41 to 50 millimeters of mercury for at least 5 times. And now look at the second thing. It increases by 20 times if the systolic blood pressure is increased. I mean, it is decreased by more than 50 millimeter mercury, and the duration is as little as 5 minutes. So as an anesthesiologist, we need to be really, really vigilant as to why it is happening this. So we understand that hypotension and hypertension both are into a crisis, and we need to manage them. So how do you manage them? So this is the QRH approach. This is what everybody has been discussing and will be discussing in the newer thing. So this is very nice reference handbook which is easily available on the net, and this is again very nicely it has been written. This is not intended to be standard of ultimate medical care, but it has to guide the clinician in the light of clinical data presented and the diagnostic and treatment options available. So the whole presentation is going to be based on this thing. Now, before we go on this thing, it is very important to get ourselves familiar with the this guidebook. It is very nice if all of us can have this guidebook in our operation theater. If you see at the top, there will be an edition. So this is the latest edition, you will know. Then there will be instructions as to how to use this guidebook. We'll come to that part. Then there is a nice thing, that is location of emergency equipment and drugs in operation theater. This is many times a problem. We know the solution, but we are struggling to find the right amount of equipment or drugs. So this is very important that this is also taken care of. Then there is one basic key plan, which is a sort of a single guideline for a crisis where signs, symptoms, and underlying problem are not clear. This is like a initial approach to any problem of this thing. Then there are 3 other sections, and today we are talking about the unknowns. When I mean by unknowns, this is guidelines for crisis which are manifesting as signs or symptoms where the diagnosis and treatment are commonly simultaneous. It's like not exactly vague, but it's sort of a collection of symptoms. For example, there can be a cardiac arrest, hypoxia, airway pressure. We are talking about hypo or hypertension, and then we'll talk about tachycardia, bradycardia, and arrhythmias. Then there will be specific known sections, and then there will be something like others, for example, oxygen failure, electrical failure, emergency evacuation. And all of this has been very nicely arranged in a concise way, easy to follow. So this is how a chapter will look like. I purposely sort of blurred the diagram just to highlight the whole body of how a chapter in this QRH book looks like. For example, if you look at 1, this is a guideline number, a name and a version it is given. Then the second part is a brief description of the clinical situation for which the guideline is written. Then this is the body of the guideline. You have to follow it one after another. It is numbered 1, 2, 3, 4, 5. And then there will be intermittently, there will be some boxes which are given a call out. For example, give adrenaline, box A. So you'll be having something here. And these boxes are again color coded. They are, for example, orange critical changes, blue drug doses, green CPR information, black box will talk about equipment instruction, and purple will be a reference information. Intermittently, you will find some links given to some other thing. For example, just now Shiv sir talked about anaphylaxis and bronchospasm. So here this is nicely being pointed out. If bronchoscopy is persistent, go to guideline number 4, that is bronchospasm. That is how it will look like. And this guideline number is repeated for easy finding without need for a tab folder. This is the one. Very easily, you just go to that page, and that is how it will look like. And one pager is all it is all about. Now, actually, how do you use this guideline? Ideally, all of us, this is the reason this symposium is happening, that we should be familiar with all of these guidelines, but then a hard copy should be present in a operation theater. One person should read the guideline, whereas other person should perform the actions which are mentioned in the guideline, especially when there is doubt as to you don't remember the sequence exactly. Then it is very important that all of this is followed systematically and thoroughly. You don't go to step 1 and then somebody comes and say, okay, give some IV fluid. Then they say, go to airway. Then they say, oh, whether analgesia is given or not. All this has to be a sequential algorithmic approach. That is what is very going to be important. Then another important point which is emphasized is whenever some senior experience comes, or that is a call for help is given, always sort of give a leadership to a senior person so that he has a fresh pair of eyes, his experience comes in, and you will be able to have a sort of a good outcome ultimately for the patient. Now, before I go exactly onto the hypertension and hypotension, this is what a key basic plan looks like. This is something for as a initial management for all the crisis. So what happens is when you follow a key basic plan, it increases the chance of identifying the problem. It reduces the risk of missing the problem. And most importantly, we don't get distracted here and there. So this is what very commonly it happens in any crisis. There will be a lot of people coming in to help you, but at the same time, there will be a lot of opinions happening. Sometimes you might be missing on a particular important thing and giving an attention to a non-important thing. So this becomes very important. Now, how does this key basic plan work? You have a start from here, and as I just discussed, you go in a systematic way. Now, this is very important. The first important thing is, again, it's sort of an ABCD approach, but before airway, it comes an adequate oxygen delivery. This particular slide, I'm going to read it out very importantly. Pause surgery wherever possible. check the fresh gas flow for the circuit in use, and check the measured FiO2. Minati madam had just highlighted a very beautiful example for that. Visually inspect the entire breathing system, including the valves and connections, and rapidly confirm that the reservoir bag is moving or the ventilator bellows are moving. This is very important. It ensures that we are giving adequate oxygen to the patient. Next important thing is airway. In airway, we again do a check position of airway device and listen for noise, that is larynx and stomach. We sort of put a stethoscope and try to listen whether there is an obstruction or whether the air is getting into a wrong place. Capnograph becomes very important. Capnograph is the most important friend in the operation theatre. Dr. Anju had very nicely emphasized on the same. Confirm that the airway device is patent. This can be done by considering passing a suction catheter, and consider whether you need to isolate the equipment. There's going to be a separate talk onto that. Then after A, it comes the breathing. In breathing, we are again ensuring that the chest is symmetrical, the rate which we are giving is okay, auscultation, breath sounds are good, the end result, that is the SpO2 and the EtCO2 are both important, but additionally in operation theatre, especially under general anesthesia, we have additional importance of expired tidal volume, which is very good marker that you are able to ventilate the patient very nicely. Then important thing is to have the feel. This is something which the senior people, the teachers always tell us, that always have the pressure or feel the back as to how you are getting, whether there is a resistance, whether it is you are not able to ventilate or something. This is very important. After airway and breathing comes the circulation part of it. That is the check rate, rhythm, perfusion, and recheck the blood pressure. This is very important, that you are checking the blood pressure, but especially for hypertension, do not hesitate to relook or recheck the blood pressure again. And in D, we have what we call as the depth of anesthesia. Ensure appropriate depth of anesthesia, analgesia, and neuromuscular blockade is there. Once this is done, then you can look at the surgical problem and then call for help if problem is not resolving quickly. This is something many people will do at an early stage, and probably not a bad way to do this thing, isn't it? So this is how a basic plan will look like. Now let us come to our two important problems, that is two important crises. One is the hypertension and second is hypotension. We'll start with the hypertension, perioperative hypertension. When we talk about perioperative, we can talk about preoperative, intra and postoperative. Won't deliberate much on preoperative issues, but just to highlight few important points. Is there a magic preoperative BP number for which elective surgery need not be postponed? It has been very clearly found that hypertension is one of the leading causes for cancellation of surgeries, isn't it? And the evidence behind this is quite vague. What it is generally accepted is a systolic blood pressure less than 180, a diastolic blood pressure less than 110, without end organ damage or without end organ clear-cut ischemic signs, is probably good to have a case need not be cancelled for this thing. This is what the literature says. But then again, there will be individual protocols which we need to understand. In case of emergency surgery, we cannot postpone the surgery. You have to do a risk stratification and you have to manage. For pre-operative thing, we all talk about medication management. There is two different school of thought about AC and ARBs. The most commonly accepted thought is that they need to be stopped 24 hours prior to surgery. But the important thing which we forget is that they should be preferably started within 12 to 24 hours of surgery. Otherwise, the chances of recurrent or rebound hypertension followed by ischemia is something which is significant. So that is important thing for us to note. And of course, pre-operative intervention like decreasing the anxiety, pain, proper morning medications, especially antihypertensives, all of this has to be taken. Now coming to the intraoperative part, the approach is RAT. The first component of R is to recognize. So how do you recognize this? This is done by the clinical cues. For example, there can be excessive surgical field bleeding. The surgeon might be able to alert us. Under spinal anesthesia, we can still see the end organ effects of high blood pressure. For example, if there is some sort of altered sensorium happening, if there is a chest pain to the patient because of high blood pressure, he will be able to tell this thing. But under general anesthesia, we need to be very vigilant because this is something which get masked away and your monitors becomes very important. So in monitor, blood pressure reading becomes very easy. Non-invasive blood pressure, standard minimum 5 minutes every reading. which is very important. And as the case demands, our invasive blood pressure becomes very important. And of course, ECG changes and rest of the parameters also are very important. Now, the next approach is A and T. I'm going to repeat this again and again. The idea is to get the RAT approach into the picture. Now, initial assessment and treatment and approach towards the specific diagnosis. So this is how the hypertension QRH slide looks like. We all know how to use it. It has to be from start and then we go towards the end of the slide. So again, initial first thing is to recheck the blood pressure and increase anesthesia and reduce the stimulus. This is the most important thing. If possible, the surgeon can be asked to pause the surgery. You need to recheck the blood pressure, see and increase the anesthetic depth, isn't it? Now the next thing is adequate oxygen delivery. We have all seen how it goes. Then the airway becomes important. Then for breathing, additional important thing in this slide is that you exclude the hypoxia and hypercarbia as the causes. So this is how it will look like. Start, immediate action, adequate oxygen delivery, then airway and breathing. In breathing, hypoxia and hypercarbia as the causes needs to be ruled out. Then important is the circulation. So what happens in circulation for hypertension? We check the rate of the patient, rhythm, perfusion, whether the end organs are getting adequately perfused or not. We increase the frequency check of BP checking. That is very important. The curve size and location, they are adequately checked, whether this is proper or not. And as the need be, we might consider placing an intra-arterial line for continuous monitoring. Of course, then comes the depth, that is analgesia and anesthesia. It has to be properly seen. And then we need to consider the underlying problems, call for help, and the temporizing drugs. So this is exactly how it will look like. Start, look for the underlying potential problem, and then temporizing drugs for hypertension. Again, be very clearly, this is sort of a temporizing measure. This is like a broad approach to a broad problem. We are not exactly focusing on to individual problem. If we talk about underlying problem, inadequate depth of anesthesia, analgesia, we talked about, and neuromuscular blockade. Omission of usual antihypertensives can be a cause. Distended bladder, very common at times. Vasopressor administered by the surgeon and it has gone intravascular. Surgical tourniquet, excessive fluid, probably iatrogenic. Medical causes can be drug interaction, renal failure, raised ICP, seizures, thyrotoxicosis, pheochromocytoma. We all need to keep these exact causes in the mind. And once this is done, we can start looking for temporizing drugs. Now, what is in this thing? So we have something to increase the analgesia. For example, an opioid like alfentanil or fentanyl, which is easily available in India. Propofol to increase the depth of this thing, or inhalational agent, whatever is available. Then a beta blocker, a hydralazine, which is a vasodilator, and a glyceryl trinitrate. More important is to know the dosages of this drug, but probably for me, it is very important to know the contraindications of the drug. At times, my teacher used to say that indications are important, but more important is to understand when not to give a particular drug. For example, labetalol, we all know it's not a selective blocker, it is alpha and beta blocker, and especially if it's a bronchospastic disease, it might be a problem, something like that, isn't it? Glyceryl trinitrate, a right ventricular infarction, if we are having a raised ICP, this is not going to be our first drug of choice. So this is something we need to understand. Now we have looked at the hypertension part of it. For example, we recognize hypertension, how it is happening. Then we assess and treat. While we assessing, we look for the A, B, C, D approach. Then we try to see whether we can look at a specific cause. And while we are doing this, we try to go into a temporizing measure by giving appropriate drugs or intervening so that our hypertension is getting controlled. And then we can focus on the specific cause. Same will happen with the hypertension. For preoperative hypertension, again, there is no magic preoperative BP number for which the surgery can be postponed. But again, in an emergency surgery, especially if the patient is in shock, we'll have to do a risk stratification and take the patient. And we'll also have to be careful about the medication. This is more or less same as we do in any of our pre-anesthetic checkup. Then if you look at the recognized clinical cues under spinal anesthesia, under general anesthesia, same thing, blood pressure readings become very important. One important thing is the respiratory associated variations in arterial or pulse oximetry waveform. This becomes very important. So again, the approach becomes assess and treat. So same thing, A, B, C, D, and E. But the specific important point which I would like to highlight is hypotension is commonly due to unnecessarily deep anesthesia, neuraxial blockade, hypovolemia, or combined causes. Pause the surgery whenever possible. For breathing part of it, exclude intrathoracic pressure, high intrathoracic pressure, a pneumothorax as the cause. And for circulation, check the heart rate, rhythm, perfusion. If heart rate is less than 60 beats, consider giving anticholinergic, consider giving vasopressor, consider giving fluid boluses, and treat arrhythmias, tachy and brady, which will be the next talk by Dr. Guru. So we know the causes. There can be surgical causes like decreased venous return. There can be blood loss. There can be a vagal reaction, or there can be embolism. So these are most common causes. And then you need not forget the other causes like ischemia, local anesthetic toxicity, sepsis, or some endocrine causes. So this is how it will look like. Coming to the last part of this thing, that is the treatment part of it. So once we have done the assessment, the treatment part will be the anticholinergic drugs like glycopyrrolate and atropine, especially if it is associated with bradycardia. And then the vasopressor drugs, we need to know again the exact effect. For example, ephedrine, phenylephrine, metaraminol, adrenaline or noradrenaline. How do you use? What are the indications and what are the contraindications? So once we know this thing, we can initially approach the problem of hypo and hypertension. If the time permits, I would like to take few cases. Sir, I think there is 10 minutes still more in for my lecture. Is it okay?
It's fine, Abdul. Continue. Absolutely. Continue, please.
Okay, sir. So we have seen the overall approach. This could have been even great, as sir was saying that probably if it was one-to-one face-to-face lecture, this case examples or vignettes could have been even more interactive one. But for what it is worth, we'll go through few of the cases and we'll try to answer these cases. This is not like this is new or this is something which we are not doing. We are doing this day and in and out in our operation theaters. But let's try to focus and try to get answers from what we have seen the approach just now, isn't it? For example, a case one, uterine myoma removal for primary infertility. Experienced surgeon. This is a real case which has happened with me. Induction smooth, no problem, routine maintenance. And then of course the anesthesia resident was given. We had gone to another case and the anesthesia resident noted that intraoperatively the BP had gone to a sinus tachycardia of 160 and BP gone to 210 by 124. The resident starts to panic and then he asks the question, how do we approach? Now the first important thing is, answer is very clear. The answer is QRH. Look at the A, B, C, D, E, what we do. Then try to see what causes can be there. So if we are very vigilant, we know probably the surgeon must have done a vasopressor injection for a myoma removal, and a senior surgeon at times might not give a good communication to the resident and you might be able to miss it out. So vasopressor administered by surgeon, it went intravascular. Now even before that we get to exact problem, we can start some sort of treatment, and one of the easiest way to start treatment can be do a ESMO. So this is one of the approaches. Of course, over a period of time, depending upon the case, how it evolves, whether it goes into a cardiac arrest or whether it settles, you will have to further keep on evolving. But this is how it happens, isn't it? So the action is, first thing you start, then you go to your potential underlying causes, and then you start doing the temporizing measures. This is how a QRH or a RAT approach would look like. A second case, ASA2 well-controlled hypertensive patient on telmisartan. She was operated for modified radical mastectomy. She had omitted telmisartan 24 hours prior to surgery. Query allergic to NSAIDs. After IV induction, it was smooth and patient was properly being maintained. After around 30 minutes of surgery, the anesthesia resident noted that the heart rate and BP, again, there was a sympathetic response. What can be the reason? Now, the reasons can be manifold, isn't it? You'll have to approach. At times, you might not even be able to get to a particular cause. But the approach again remains the same. A, B, C, D, E. And I mean like the anesthetic, airway, breathing, circulation, and depth. And when we can see, there can be anything. One of the reasons can be that was probably inadequate anesthesia and analgesia. You give a fentanyl or you give a alfentanil or opioid, it can be diagnostic. You see the BP has started to come down, you give some amount of propofol, things start to settle down. You get a help in the meantime to see that probably there is no other cause which is happening. So this is only for initial. This doesn't mean that you give this thing and you are sort of relaxed. There might be something else which is going underneath. So you need to be very sure. So probably propofol, some opioid was given and things started settling down. Again, emphasizing the same thing. First ABCD, underlying problem and temporizing the drugs for hypertension. Now the third case, this same patient, surgery has happened. Now the patient is gone to PSU, and on day 2, the patient was shifted to wards. On evening round, the anesthesiologist noted that the BP was continuously in more or less the same range. So he was saying that there is no analgesia. I mean, the analgesia is very good. There is no significant pain. But then he goes to ask to surgical resident, and surgical resident is not aware. So what will you approach? ABCD, why is it happening? So this can be extended even to a PSU. And the reason when you look at the drug thing is, this patient was on telmisartan and it was not started post-operatively. And this is what happens. It starts going up, and it was a nice thing that we detected it probably before going into even a bad complication. So the treatment was probably to give some alfentanil to see if there was pain or not. But when you see the drug chart of the nursing chart, you say that the telmisartan has to be started, and this is how it works. So this is again a very systematic algorithmic approach to a problem. Case 4, Shiv sir, you can just stop me whenever you say. Three more cases.
Go on. We are not limited by time as such.
Just 3 more cases. Thank you, sir. So case 4, 62-year male patient, hemorrhoidectomy, 10 milligram heavy bupivacaine plus 25 micrograms fentanyl, something like a low spinal anesthesia. Procedure uneventful, received around 1.5 liters of fluid. Post-operative ward, around 4 hours, the nurses call the anesthetist and surgeon that the patient is complaining something lower abdominal discomfort, but then he's sort of sweating, there's diaphoresis, there's a tachycardia, blood pressure, the room air saturation is same. Now the reason is, again, the resident is called. How can he approach even before the help is there? So he starts looking at the A, B, C, D, and then he starts looking at the sum of the causes. So he looks at the abdomen and he sees that the spinal which is given has caused to a retention of the bladder. There's a distended bladder and which is causing the sympathetic response. He simply put a Foley's catheter, he drains it and probably gives some amount of opioid and drains the urinary bladder, and the problem is resolved before it becomes a major crisis. So again, a simple algorithmic approach. Again, if you look at my flow chart, the reason I'm trying to say repeatedly is keep the approach very systematic. ABCD, underlying problem, and then go for the temporizing drugs for measure. Simultaneous assessment and resuscitation. A 72-year ASA2 patient, fracture neck femur, preoperative BP was in the range of 180 by 100. But not very significant other comorbidities. So yes, we can take this case, and especially because it's a hip fracture, we should not wait it out. Then again, if you notice here, it's a 8 days old fracture. Unfortunately, this is common in some part. Otherwise, hip fracture should be fixed within 24 hours. So he receives a spinal epidural anesthesia. Post-spinal, he had a BP drop of 108 by 76. If you look from preoperative, this is again a significant fall. But after around a half an hour, the BP is gone to 86 by 56, and there is some amount of chest discomfort. We all know what is happening, isn't it? But the approach should again be ABCDE to see that I am giving oxygen, my flows are properly started. And then we recognize the cause. 8 days old fracture taken to fixation without a antithrombotic prophylaxis can be an embolism, and then you do a appropriate specific management for the case, isn't it? Then the last case, a 32-year ASA1 patient, uterine myoma removal. You remember the first case? Same thing, but this time instead of bradycardia, instead of tachycardia and this thing, there is an unexpected sinus bradycardia with monitor suggestive of advanced grade heart block rhythm. Peripheral pulses are not palpable. Residents start to panic. How should one approach? Now this can be anything, isn't it? ABCD, look at the causes. The causes can be probably there has been some sort of drug error, probably there has been an embolism, or probably there was a wrong drug like a noradrenaline, which is gone intravascular and causing a bradycardia, isn't it? So we will need to look into this thing, but at the same time, we'll have to treat it. There's a bradycardia associated with an hypotension and which is unstable. So atropine is what I'll give. It will temporize my thing. And then depending upon how my case evolves, I'll have to think about whether I need to use adrenaline and how do I support my case, isn't it? So appropriate diagnosis and management becomes the next thing. ABCD, reasons and temporizing measures. Last case, ASA2 patients, COPD, diabetes mellitus, hypertension, hemimandibulectomy, intraoperatively okay. On the evening, patient's BP is on the lower range, 100 millimeters, and some sort of breathing complaint is there. Now, there's no chest pain or something. You look at ABCD, then you say there's something wrong. You look at this thing. You remember, yes, a diabetic patient, a high-risk comorbidity patient might not present exactly with chest pain. There is a cardiac ischemia possibility. You try to go to exact drug and treatment, and you look at the specific diagnosis and management of the cause. So this is what it is. So just to take home message will be that RAT approach or a QRH approach is very useful. Try to have this handbook with you. Try to be familiarized with this thing. Go through all the algorithmic approach. Try to train your team so that they all work in the same language. And remember, this is unknown which we are dealing. The recognition, assessment, and treatment all has to go simultaneously rather than one after another. So that is how it should be. For hypotension, even you can do a leg raising test, which is not mentioned here. But if it is not a contraindication, you can definitely do it. Thank you.
Thank you, Dheeraj. That was very comprehensive, I think, and having the case presentations at the end, it actually makes it interesting, but also then it emphasizes how you will deal it in a clinical situation. And as you rightly pointed out, in unrecognized is always that you have to be thinking constantly, what is happening, what is the cause, what we need to treat, and it's something which is actually like a real emergency. It is a real crisis. In knowns, which we'll discuss tomorrow, there that okay, bronchospasm happened, this is the cause. You can systematically go through, but here you are assessing, treating, reassessing, so that cycle goes on constantly till you actually find the cause.
Yes.
But in the end, it is about maintaining the vitals of the patient, make sure there is enough oxygenation, blood pressure is maintained, and at the same time, because these are happening during anesthesia, you need to also ensure the patient is not awake, is not aware.
Yes.
And in one of the common things which people do when they actually see hypertension is to reduce the level of anesthesia. Okay, that if patient is paralyzed with neuromuscular blockade, then awareness becomes a problem, an issue. And that's why I think it's important that you need to look at what are the causes of hypertension. Is it surgeon doing something? Is there been a blood loss, or we are not given enough fluids, or we given something by accident? Those things need to go hand in hand. So very well covered.
Yes.
And again, I don't see any questions as such being asked, but Dr. Naresh Paliwal did actually mention, he says, in case of hypertension and tachycardia, why not dexmedetomidine? So I will actually come to that. I was actually writing that. Now, these are actually based on UK practice. And in UK, dexmedetomidine is actually costly. And that's why you don't see that drug mentioned that often. Though it's a wonderful drug where you will actually get quite a lot of actually advantages, by giving little amount of dexmedetomidine. You get sedation, you get analgesia, you can control tachycardia. So it is actually an excellent drug to be used, but because it is not easily available, it's costly, and that's why it doesn't feature in these algorithms. Any comment from your side, Dheeraj? Would you use it?
Yeah. two issues, sir. It's a very nice drug. We use it day in and day out. Almost from 2012, we are using it.
Yeah.
The reason is, as you rightly mentioned, it's a UK-based protocol. So I didn't want to deviate. The second important reason is familiarity with the drug. Again, it's slowly getting familiar. Third thing is there are still literature reports mentioning about a paradoxical initial reaction, hypertensive and tachycardic reaction, especially in hypertension. But that said, it still works very well. We use it almost for all the cases. And fourth thing, there is a specific indication which is even mentioned in the QRHs, especially if the patient has been on clonidine, and if there is a strong chance that you have forgotten to take the clonidine, giving a clonidine through a nasogastric tube, or even better, to have a drug like Dexmed, which can be easily titrated, really makes a great sense. So yes, probably in next few years, we might see that it might start coming up in algorithm very well.
Yeah, that's why I say, because in UK, like myself, I've never used it. No, not saying that I never used it. I would be wrong, because I have actually got it, and it actually took me a week to actually order it, and it was to be used in a selective patient. So I did actually get the drug, but then again, my experience was probably minuscule compared to what most of even the registrars would actually have more experience with dexmedetomidine than anybody in UK. And yes, the rebound hypertension seen with the alpha to agonist, like you're talking about the clonidine, if patient has been on them, they stop, or on that, for that matter, ARBs or ACI inhibitors, they can actually get a rebound hypertension. So you need to be very cautious with these kind of cases. I think you presented one of the cases with telmisartan,
yes, sir.
Patient who had not taken it. So if the gap is more than 24 hours, then you will actually see some amount of rebound hypertension. And the way we've actually followed this case is that we try to actually give them at least half the dose in the post-operative period, and then see and measure, and then see the response. Sometimes they can actually, because patient would have had less amount of fluid, so they might be dehydrated still, blood loss, and you give them bigger dose, and then you see severe hypertension. So I think one need to be very careful. But otherwise, we tend to introduce the next day post-op. So they miss out for 24 hours and then reintroduce in for 24 hours. But those things are actually, yes, important. So moving on from hypertension and tachycardia, well, hypertension, we move on to tachycardia and bradycardia, the commonest. We don't call it, they're not arrhythmias, they can be physiological as well. So Anshul is going to actually deal with these two. They're not, again, I won't call them crises as such usually, but these can be observed intraoperatively, but they can happen at any time. That's what is the importance. So how do you actually go through them? So Anshul will be talking about them.
Hello.
Anshul is a freelancer, so he's a very good orator. I've heard him quite a few times now, so I'm sure he will actually do great justice to this topic. So this topic was last year covered by Guru Cynthia, but they have decided to exchange, and which is a good idea. I think within the faculty, we should try to actually see that the different people take up different topics, and it gives opportunity to read through other things as well and present different ones. So over to Anshul. Anshul.
Thank you, sir. Good afternoon, everyone. I'll share the screen first. Okay, so I hope I am visible, audible.
You're audible, but your screen is still not actually come up, so it's probably taking a little while.
Yeah, it's not going on full screen.
It says started sharing screen, but it hasn't come up yet.
Okay, everything has frozen. Just give me a minute, sir.
Best thing is to actually restart the thing, I think. Yeah, just unshare.
That stop share button is also not working. Can you stop my sharing, sir? Because you are the admin. Because everything has frozen here.
Oh.
Yeah, nothing is working. Yeah, just a second. Okay.
Yeah, it has come up now. Yeah.
It has come up. Okay.
Yeah. You can go back to your initial slide. Go back to first slide.
Yeah, it's hanging, sir. I'll just stop the sharing and again reshare it.
Okay, that not a problem. That's good.
Okay, this is acting funny.
Hey, just go on the slideshow.
So can you see my screen? Because I'm.
I can see your screen. I can see the first screen,
Okay,
but it's not the
but it's
You're
not
not
going
gone
on
on
the,
slideshow, yes.
it's not going on the full screen mode, and again everything has hanged. Some problem.
Okay, send it to me on WhatsApp.
Just a second, sir. I'll try once more.
Yeah.
Yeah. So
Yeah, seems to be working now. Yeah. Go on that.
yeah, now it's working.
It is.
So yeah, good afternoon, everyone. I'm Dr. Anshul Divakar. I'm a freelance anesthesiologist, and very happy to be a part of this QRH symposium, crisis symposium again this year. Last year I was doing laryngospasm. I'm a diploma and DNB anesthesia. I practice in a very small town called Rajnandgaon, Chhattisgarh. I am also a teacher for postgraduate entrance exam for anesthesia. I'm a national faculty for them. So I teach a lot of undergraduate students all over the year, and very delighted and very proud to be a part of this amazing organization where we pitch in and we try to solve basic problems. And so there are a few things I would like to begin with. The first is that the topic that has been given to me, I've taken, is something which is related to everything what we have already listened to till now, right from cardiac arrest to hypoxia to increased airway pressures to perioperative hypertension and hypotension. Everything eventually is a part of what I am going to discuss. So I was patiently waiting because everybody has covered almost everything that I'm about to tell you. Also, it is my earnest request to everyone who is listening to or who will listen to this symposium that if you really want to have a very good feel of how to recognize and to treat brady and tachyarrhythmias, that is the whole paradigm of all the changes that are happening with the ECG, then you can all go and listen to last year's crisis symposium that was given by Dr. Guru Santhia. It is an amazing presentation. I'm still in awe of it. And precisely for the same reason, this year, when I wanted to do this thing, I did not want to include all the same things which she has included. I would basically try to give an overview of how things have to be approached in terms of what happens intraoperatively when the heart rate increases and decreases, and how it is being related to the things that are going on as a whole paradigm of the patient care and how we approach it. So it will be mostly a gross guideline based thing. Most commonly because when hypertension and the tachycardia and bradycardia happens, our initial responses are usually somewhat misguided, just like what Shiv sir told, that if you are doing a case and there is sudden hypertension, we tend to increase the depth of anesthesia immediately, and if there is sudden hypotension and bradycardia, we tend to decrease the level of anesthesia. So an overall approach as to how we would the patient would present and what would our approach be in such situations. We have been given a very good understanding of how to approach a crisis by this quick reference guide that we are forming our basis of our discussion. And what we are discussing today is the unknowns that are associated during anesthesia. And the line that catches my attention is that these guidelines for crisis manifesting as signs and symptoms where diagnosis and treatment are commonly simultaneous. So you have to keep doing and thinking at the same time. And my whole discussion was based on how these guidelines are so beautifully designed. But Dr. Dheeraj has actually very, very pertinently and in a very practical way covered all the things which these guidelines are trying to tell you, how systematically you can deal with stuff and you can change things immediately and do it in a step-by-step manner so that you manage the patient at the same time you go ahead and try and treat the basic cause. So now what I am going to do is I'm just going to give you a brief overview because nothing much is left to be said about this topic. So I'll start with first financially declaring that I have nothing financial to declare, and then a very basic case scenario that I'm presenting is a 60-year-old 20 kg male posted for squint surgery. The moment I write this line, most of the people know what I'm talking about, but I'll still say that the case was supposed to be done under routine general anesthesia with endotracheal tube. So we gave a standard induction, midas, fentanyl, followed by propofol, atracurium, and a cuff endotracheal tube was inserted, and the patient was maintained on sevoflurane. Usually painting and draping in a case like this where the head end is very far away takes little time. So painting, draping preparation took around 10 minutes of time, but it's a child, we don't want to give over anesthesia in the time when there is no surgical stimulation. So the MAC was kept around 0.4 of sevoflurane. But as soon as the surgeon started the case, the patient's heart rate dropped from 100 to 30 and BP dropped from 100 to 100 by 55 to 70 by 30. Now, this is a very typical scenario which everybody gets, right from resident on day one of anesthesia to somebody who's been practicing since 20-30 years. Everybody gets this kind of cases, and it's our anticipation about these things which keeps us on toes. But this is the kind of thing that we are talking about when we specifically talk about intraoperatively or perioperative bradycardia, that is sudden decrease in heart rate. So let's introduce bradycardia in the simplest of the terms. Bradycardia is when heart rate is considered to be 60 per minute. Obviously, less than 60 per minute can be physiological. Some people might not sustain a bradycardia of more than 60 also, say 70 would be less for them. So it all depends on the clinical condition of the patient. But in the terms, in the essence of number, we consider 60 as the benchmark for defining brady and tachycardia. And it has multifactorial cause. I cannot say more than this because everything that happens with the patient eventually gets reflected in the heart rate in the ECG, because heart is like a mirror to what happens inside the body. So as we started our discussion in the afternoon today with cardiac arrest, and we saw what happens when the heart stops, and then we saw what happens when there is hypoxia, and then when there is, so we saw that in every clinical scenario that we are getting, somewhere or the other, every clinical scenario leads to change in heart rate. So either there'll be hypertension, there'll be tachycardia, or there'll be bradycardia. So it has wide variety of things that can happen. So just introducing bradyarrhythmias, that is just for the purpose of completing what we know about bradyarrhythmias, that one is sinus bradycardia. That means the PQRS T complex is normal and the rate is the only thing that is decreasing. Then you have three types of heart block: first degree, second degree, third degree. This is more of a theoretical discussion from my perspective, because what I have understood over the years in practice is that intraoperatively, when the surgery is going on, we are only able to understand whether there is a brady type of arrhythmia or a tachy type of arrhythmia, and we have to treat it then and there. We don't have time, resources, energy to actually go on and diagnose the rhythm, because even if you want a 12-lead ECG in a patient who's been operated, say an abdominal surgery, as in under the drapes, is practically you have to stop the surgery and then do it. So idea is to know that all these things are possible, but also to know that in anticipation, you can always start the treatment and later on you can confirm the diagnosis if at all the surgery gets over, or you get time, or you get the space to get a 12-lead ECG done. So first degree heart block is simply prolongation of PR interval. It is an innocuous condition. Most of the time it is physiological. Second degree heart block, again of two types, Mobitz type 1, type 2. In Mobitz type 1, there is subsequent prolongation of PR interval. It keeps on happening till one atrial contraction fails to get transmitted. So there is a drop in QRS, which is called as a missed beat. It is also an innocuous condition, but it is Mobitz type 2, which is problematic, where there is fixed prolongation of PR interval, but then there are some atrial beats that they don't get converted into the ventricular contractions. And this Mobitz type 2 is something that can be symptomatic, and it can then eventually convert into a very grave form of bradyarrhythmia, that is third degree heart block, or called as complete heart block, where there is no correlation between the atria and ventricles. So there is, the P waves are going in their own world and the QRS complexes are going in their own world. So there is no correlation, and the heart rate goes to very low as 30, 20, and that is something that often presents symptomatically. This is the part of the discussion that we are here for, and we all know everything theoretical about all the arrhythmias, but this is what we want to discuss today, that in a case of intraoperative bradycardia, what are the things that we are supposed to look for and do. So the guidelines have been very nicely described by Dr. Dheeraj. I will reiterate these things, that the first thing, whenever something happens which is odd, and these are broad general guidelines that have been given by the UK Council, is that you stop whatever you are doing, because most of the times what we do causes the problem. So if we stop and we let ourselves assess that situation, then it always becomes better. And sometimes when the offending agent is immediately removed, we actually diagnose the thing early, that what was the reason. Also, we start the treatment properly. So stop any stimulus that you are giving, because stimulus is one of the reasons why you can get sudden bradycardia. Check pulse, rhythm, blood pressure. That is something that is basic. We all keep doing that. Now here comes the catch. Now in every scenario of bradycardia and tachycardia, just like what we discussed in cardiac arrest also, pulse is very important. So at the end of the day, it is the clinical implication of the pulse that comes into picture here. If there is no pulse, that means whatever you are seeing on the monitor is either only electrical activity of the heart, or the heart has totally stopped. You're not seeing anything on the monitor, right? Also, I would like to point out, which is a very, very important part of the cardiac arrest algorithm as well, that checking the ECG lead also becomes one of the most important things, because sometimes you think that something massive has happened, a sudden cardiac arrest has happened, while only the ECG lead has been removed. So checking the pulse helps you in recognizing both these conditions. One, if pulse is present, you know that this is not a cardiac arrest. Also, if pulse is present and you are not getting a ECG waveform, that means you know that there is some problem with the lead, which becomes lead check becomes one of the important things during a sudden event of cardiac arrest. Also, the first step is always to check the leads, right? So if there is no pulse, or this not sinus bradycardia, or there is severe hypotension, that means now the clinical picture of the patient is also interpreted. It is not just the number on the monitor that is important, but overall what the patient is feeling. So if it is under the surgery, he's not going to tell you what is happening. So severe hypotension, then you will immediately go for atropine. In case the pulse, severe hypotension, pulse, mild pulse is present, then you go for atropine, that is 20 mics per kg. That usually in India we get around 0.6 milligram ampules, so you can give that. But the dose that they have described is 0.5 to 1 milligram. If there is no pulse, you know that immediately start CPR. A very small point for infant and neonates, less than 60 heart rate is considered to be low pulse, and you start CPR directly. You don't give any vagolytic agents like atropine. You immediately start the CPR. So the first and the most important thing is to recognize that whether this is something very grievous or not. So no pulse is very grievous. There's cardiac arrest, and for cardiac arrest, you have CPR, which we have discussed already, all the things that you're supposed to do. If it is severe bradycardia associated with hypotension, then of course, atropine in adequate doses should help you. And then from there, we move on to the general 4 things that we have to look for. First, adequate oxygen delivery. Second is airway. Third is breathing. Fourth is circulation. That is the ABC that they have described. That is a general guideline. Any crisis, you have to follow these 4 things. And then specifically for intraoperative bradycardia, you have to look for depth. Sometimes increased depth of anesthesia can cause bradycardia. Also, sometimes in a milder plane of anesthesia, in milder planes of the depth that you have maintained, a sudden surgical stimulation can also cause vagal stretching, like creating a pneumoperitoneum in a laparoscopic case can cause sudden bradycardia. So assessing the adequacy of analgesia and anesthesia now becomes very, very important. And then you start looking for the underlying problems. So the box C that we have here, the box C that you can have here is the potential underlying problems. And you can see that most commonly what we think for bradycardia is that it might be a drug error. It could be a drug error. By mistake, we have given a beta blocker or we have given a calcium channel blocker. It was there loaded and we didn't see, there was no label, something like that. So you do consider drug errors when there is sudden bradycardia. So consider whether you have given or made a drug error. Consider known drug causes, like there are certain drugs which are known to cause bradycardia, like remifentanil, digoxin. Surgical stimulation in inadequate depth. So that is a low depth and you have had a vagal stimulation, something like creation of a pneumoperitoneum, or something like the pressure on the extraocular muscle while doing squint surgeries, or perianal surgeries, which are known to cause sudden bradycardia. Again, stretch receptors, vagal stimulation, sudden bradycardia. Then there are certain factors beyond this. These are common things. Certain factors beyond this. High intrathoracic pressure like pneumothorax, sudden pneumothorax again can cause sudden bradycardia. Pneumoperitoneum, that is what we commonly see in lab cases. Local anesthetic systemic toxicity. Now, this is something which has to have a high degree of suspicion because you have given a regional anesthesia. So you have just deposited the drug and there is a possibility you might have deposited it intravascularly, or you have used a high dose for a particular patient. It was a failed block and then you have given a reblock. So you did not really care that how much local anesthetic you have taken, or you have started a infusion of local anesthetic for the purpose of continuous analgesia, and sometimes that can lead to last. So last is something that has a very, very wide implication here. And then again, last management is completely different, where you go for CPR and then, give drugs and intralipid and all that. Beta blockers, digoxin, calcium channel blockers, these are drug that can be given intraoperatively that can cause sudden bradycardia, right? Myocardial infarction, one of the very common, not very common, I'll say, but very valid reasons which you can diagnose also, and inferior wall MI does present with bradycardia and hypotension. Hyperkalemia, you need to have that kind of patients, septic patients, patients with acidosis, then diabetic patients, these are prone to get hyperkalemic. Hypothermia, long surgeries, you don't expect hypothermia to happen first 10-15 minutes of the surgery, but yes, suppose you're doing a Whipple's 8-10 hours, there's a possibility hypothermia. Raised intracranial pressure, we see Cushing syndrome, where there is bradycardia, hypertension, that is like a reflex response. So raised ICT while doing neurosurgery or a trauma patient. So something to look for in a potential cause of why this has happened. And these guidelines are very, very specific in the way they deal with these emergencies, and they always insist on trying to find the cause. So you get a condition, you start treating the condition, but it is very, very important for us to try and find the cause of the condition, because unless and until we know the cause, we treat the cause, we are never going to get past it and move on with the surgery. We'll keep seeing these problems again and again. And these guidelines have a very, very important component of calling for help. Calling for help becomes very, very important. I myself have experienced this in the recent past 4-5 times, because when we work as freelancers, getting help in itself is a very big deal, because usually freelancers, they don't come around, and they're not in the vicinity. Sometimes they're coming away from different cities, or they are also doing different cases. But what we have realized is, whenever we are trapped in some condition, then calling for help gives a fresh perspective. They come, they ask, they analyze it in a better way, because they are fresh and they don't per se have any baggage of the case, the emotional baggage that comes with a complication. So calling for help to resolve the problem quickly becomes very, very important. And a very, very important point of transcutaneous pacing that I will come later on when we'll discuss what are the indications of transcutaneous pacing. So these are the QRH guidelines, the crisis management guidelines that have been given. And these are very, very simple, because they want you to know that in what condition, what is the first step, second step, third step, fourth step do you do, and how do you go about and trying to find the cause and solving it. So this is what forms the crux of both perioperative bradycardia as well as tachycardia. But this is the part which we all need to know, keep on revising and keep on discussing, so that in case we land up with these problems, we do it efficiently and in a better way. Let's come to implications. Why are we discussing bradycardia? So bradycardia can be without pulse, with pulse. The biggest implication is when it is without pulse. When it is without pulse, that means it is cardiac arrest. So you would proceed with CPR. The guidelines for all of that has been already taught to you. With pulse can be symptomatic or asymptomatic. It can be an asymptomatic bradycardia, like what we see normally when we give spinal anesthesia, or we are giving high thoracic epidurals, where we inject the drug and it is a cardiac fibers which are gone. It is not necessarily always associated with some symptoms. The patient doesn't complain hypoxia. The patient doesn't say, okay, I'm breathless, I'm restless, my BP is falling. No, sometimes they tolerate a heart rate of 40 as well. So one of the professors who taught me, she used to always say that unless until patient gives you a problem, never consider the physiological parameters as the problem. So we also have to understand that we discuss guidelines based on numbers. Less than 60 is bradycardia, but it is not always necessary that you gave spinal to a 21-year-old for hernia surgery and somehow the level came, heart rate is dangling between 40-45. So you have to give atropine to the patient. No, you don't need to treat a problem that has not yet occurred. Yes, if the brady is associated with hypotension, yes, if the patient does say that he's feeling some problem, if you feel that it is too high, you feel that the pulses are becoming low, then is a condition that you can treat it. But otherwise, a physiological low heart rate should never be touched. This is the summary of what all can go wrong. And we have already discussed it. The H and HT includes the 5H and 5T of cardiac arrest, because eventually bradycardia leads to cardiac arrest. That is what we say, that initially there is an assault, there is some problem that leads to decrease in heart rate, and then that eventually goes to stopping of the heart. So hypoxia, hypervagal responses, hypovolemia, hypo or hyperkalemia, acidosis, hypothermia, hypoglycemia, all of these things can lead to bradycardia. So we are only trying to look at the causes right now: tamponade, tension, pneumothorax, trauma, thrombus. Thromboembolism can cause both tachycardia, bradycardia, depending on how you diagnose it, at what stage it is being presenting to you: QT interval prolongation, toxins, pulmonary hypertension. There are certain cardiac reflexes which we all know, but just for quick remembrance, these are the things that we see intraoperatively, and we know that this is a reflex slowing of the heart rate. Cushing's reflex seen in raised intracranial pressure, oculocardiac reflex, Ashner-Dagini reflex, that is what we call, happens when we are doing extraocular surgeries, when pressure on the eyeball can lead to sudden sudden bradycardia, and sometimes even retrobulbar block while giving the block also can cause oculocardiac reflex. Therefore, even if you are trying to give blocks to a patient, always try to do it in a area where you have monitors and you have basic airway equipments and emergency drugs, because even the intraocular blocks, ocular blocks can cause OCR. Then Bezold-Jarisch reflex, which is a coronary chemoreceptor reflex that happens because of left ventricular coronary chemoreceptors that they get. It can happen sometimes while there is a sudden prick, like suppose we have given a head low to a patient for a central line, and without local infiltration, suppose we put the needle, sometimes that can cause bradycardia. Sometimes interscalene block can cause reflex bradycardia. It has been implicated with Bezold-Jarisch reflex. High spinal anesthesia causing bradycardia is one of the very, very common things that we see around us. Reverse Bainbridge reflex is something that is more of theoretical when the level is below T4. So we say with high spinal, the bradycardia is because of T1 to T4 getting blocked. But in reverse Bainbridge, there are certain conditions where even when the level is before T6, the stretch receptors cause bradycardia. So it's something of a theoretical kind of a thing. Local anesthetic systemic toxicity, yes, one of the things to look out for. And interscalene block, as I told you, that sometimes the stretch receptors can cause bradycardia. The idea of these guidelines is recognize, assess, and treat. Here, recognition is predominantly clinically based on the pulse check. So even with all the monitors in place, with everything in place, I always feel that whenever we are in doubt, whenever we feel that something is going wrong, putting hand on pulse never creates trouble. It always gives you more information than you already have. But yes, we have all the advanced monitors. We have ECGs where we can see rates and rhythm. Assessment intraoperatively, of course, there is no assessment. But if the patient is awake, suppose the patient is in the perioperative period or under regional anesthesia, symptoms can be acute altered mental status changes. There can be chest pain that can develop. Patient can say restlessness. And signs can be signs of shock in severe bradycardia. You can see hypotension. You can see congestive cardiac failure. Most of the time, sudden bradycardia associated with desaturation, low EtCO2 because of low perfusion. So all of these things are something that you want to see and assess before you move on to the treatment part. Treatment part is very simple. Actually, everybody knows about it. If it is bradycardia without pulse, you go ahead with CPR. If it is with pulse, everybody's go-to drug has always been glycopyrrolate. We know the advantages of glycopyrrolate. It's a quaternary ammonium compound, no blood-brain barrier movement and all that. So 5 mics per kg. Ephedrine, it has dual action. It will increase the heart rate as well as increase the blood pressure, indirectly acting sympathomimetic, 100 mics per kg. Atropine, go-to drug. Every OT, everywhere you go, first drug you prepare, atropine 10 mics per kg. Again, here we try to give half dose. There is always this debate that low dose atropine can sometimes cause bradycardia. I have personally not seen it, but I have read a lot of literature about it. So that is something that needs to be seen. Isoprenaline is a pure beta agonist. So again, like Dr. Dheeraj said, you want to give a drug, giving excuse me. Giving a drug is very, very easy, but we should also know where not to give the drug. So again, a beta agonist drug, sudden massive increase in heart rate, you need to know where all these drugs should be avoided. Adrenaline, when in very emergency, the patient is deteriorating, it is something like anaphylaxis, somewhere where adrenaline can give both inotropic, chronotropic action, then adrenaline becomes our go-to choice. It is usually the third or fourth drug that we give intraoperatively for any sort of cardiac hemodynamic complications, but it is something that is our very reliable friend. Later on, it has a very, very important role in CPR as well. And a drug called glucagon that is given when you suspect beta blocker overdose or beta blocker toxicity that can reverse the effect of beta blocker. Then we come to something called as Mobitz type 2 or refractory bradycardia that is not responding to pharmacological treatment or a complete heart block patient. And it is a rarity for an anesthetist to see all these things happening intraoperatively. So this is the part of the guideline which happens, I think, preoperatively or postoperatively in the ICU, where all the electrolyte changes that has happened with the patient or whatever is the pre-existing condition of the patient can lead to something that becomes a refractive bradycardia. And there we use transcutaneous pacing. Obviously, it is done cutaneously, so there are pads that you apply. And this is the part of the guideline that needs certain emphasis. Not everybody gets hands-on transcutaneous pacing. Usually pacing is reserved for, at least in India, for cardiologists. If at all we need pacing, we need to involve him. But yes, if you have a transcutaneous pacer, it is almost like a defibrillator kind of a thing. You attach the paddles, the ECG will be read. You set it on pacing mode, you set the pacer rate. Usually we try to keep it around 60. And then you start increasing the pacer output from 60 milliampere till you start getting capture spikes. That means where the pacer has started to induce the heart rate, and then you confirm it both electrically and mechanically. Electrically by looking at the ECG, and mechanically by checking the femoral pulse. You are getting the pulse, and you do it in a condition when the patient is hemodynamically unstable, and then you set the current 10 milliamperes above it. So this is something that you need to keep in mind if at all you get a hands on the transcutaneous pacing. This is my takeaway message for intraoperative bradycardia. It's actually everything is takeaway only, so there is nothing much for me to write. Recognize early, very, very important. So being vigilant, being inside the theater, watching the monitor, listening to the monitor, keeping a hand on pulse never goes wrong. Calling for help when you know that you are not able to come to the reason for bradycardia. Treat and assess simultaneously. Never think that I will first assess what the situation is. I'll try to no. In these conditions, what is very, very important is that while you are assessing what is wrong with the patient, you keep on treating the patient as well. And a very, very important point that always comes to my mind is in conditions like these, always involve surgeon with you, because we don't know what happens on that. And sometimes he might be the reason. He must be doing something that is causing these problems. So immediately inform the surgeon, call for help, tell them to stop the stimulus, and then wait, assess, treat, and then move forward. So this is something that I wanted to talk about in intraoperative bradycardia, which is just an amalgamation of what has already been told to you, right? So I will move on now, sir, to intraoperative tachycardia, or do you want me to stop for some questions or discussion?
Go ahead, Anju.
Okay, sir. Next topic is again perioperative tachycardia, and this was beautifully described by Dheeraj sir when he was talking about hypertension and hypotension. Both hypertension and hypotension intraoperatively can cause perioperative tachycardia. And although we tend to be very afraid of bradycardias intraoperatively, but it's a tachycardia that has wide variety of reasons and needs treatment. So let's discuss what happens and what we are supposed to do in perioperative tachycardias. I have nothing to declare financially. And again, I'll present a simple scenario, the one that is very commonly seen. 48-year-old female posted for laparoscopic cholecystectomy, ASA1 under GA, standard induction, and case was started. As soon as the surgeon inserted the Veress needle for pneumoperitoneum, heart rate shot up from 76 to 130, followed by hypertension. Now, I have specifically included this example, this case scenario, because although we tend to believe that pneumoperitoneum will cause vagal response and bradycardia, yes, sudden pneumo can cause bradycardia, but it is the nick on the abdomen and the insertion of Veress that is one of the most painful things at the start of a laparoscopic case. And there is a sudden hypertension tachycardia because usually by that time the depth of anesthesia has been very less. So this is something that we will discuss today as to what are the implications and what are the things that we need to look out from when we get tachycardia. So again, by number, heart rate more than 100, but if somebody has a preoperative heart rate of 100, then you need to decide whether it is tachycardia or not. So change in heart rate is more important than the absolute number. It has to be never treated as an isolated variable. There is nothing that will cause only change in heart rate. It has to be always associated with a cause. So find the cause, treat the cause, and automatically you don't need to particularly treat the condition of tachycardia. For our quick discussion, again, narrow complex, which is normal, narrow complex tachycardia, wide complex tachycardia. Narrow complex tachycardia will include sinus tachycardia, which we see more often than not. Supraventricular tachycardias, flutter fibrillation, multifocal atrial tachycardia, which was very beautifully dealt by Dr. Guru Sandhya in her last year's presentation. Wide complex tachycardia, again, QRS more than 0.12 seconds, which we get ventricular tachycardia and fibrillation. Again, the QRH guidelines are very, very easy to understand. The first thing when we get tachycardia is to stop stimulus. Again, something that is happening on our end or the patient's end from the surgeon's perspective is the reason or will be the reason why these things are happening. So first is stop the stimulus, check pulse, rhythm and blood pressure. Reassess, always reassess at that point of time. Again, no pulse, CPR, nothing can be done, or impending arrest. So what we will do, we will assign somebody, start CPR. CPR has to be our first priority. But if the pulse is present, very feeble pulse, very weak pulse, we can see that there are gross changes in the ECG. At that point of time, we don't know what is happening. Always consider electrical cardioversion. So you can call for a cardioverter, or you can call for the defibrillator cardioverter that comes combinedly, and you can start thinking in terms of, okay, if the hypotension persists, I might have to use this. If there is narrow complex and not hypotensive, so there is normal ECG and the patient is not hypotensive, then more often than not, the reason for that is the inadequate depth of anesthesia and a surgical stimulus. So you will increase the depth of anesthesia, give more analgesia. And here I would like to again reiterate the point of Dr. Naresh Paliwal, which he said that dexmedetomidine has become a game changer for us, especially in this part of the world where procuring and keeping opioids have become exceedingly difficult. So this opioid-free anesthesia, where we want to have a very good stable hemodynamics as well as good post-operative outcomes. Low dose dexmedetomidine is the go-to drug, and I use it every single day on every case. So it's like it is something that has solved the problem of low depth of anesthesia as one of the reasons for perioperative tachycardia. Then we'll do what the basic things that we are supposed to do in any crisis situation, that is adequate oxygen delivery, airway, breathing, circulation. Once we do that, then we move on to the next step, that is box B, that is consider the underlying problem. Again, considering the underlying problems becomes one of the important steps in the management of any crisis. Here, underlying problem could be a stimulation in the inadequate plane of anesthesia, which is very, very common, because when we induce and by the time the surgeon starts, there is always a considerable gap. One. Second is that sometimes we are not able to judge how fast a surgeon would start the case, and they are in a hurry, so they don't give us time to reach that adequate depth and the surgery starts. And something that is very common in institutions is when that is the point of time when the resident is there on the case, he's writing notes, and there is some form of distraction, so we are not able to keep that depth properly. So stimulation in the inadequate plane is the reason. So you would deepen the plane of anesthesia. Consider drug error, again very, very common. Instead of giving bolus of atracurium, you have given bolus of atropine, something that can happen. And then you can start considering different things like central line of wire. Although central line causing the wire of the central line causing would happen while you are doing it, so that usually causes arrhythmias. They present to as PVCs. So yes, there is a tachyarrhythmia, but a central line that is already in place then usually would not cause tachycardias. Hypovolemia, one of the very, very common reasons. Already the patients are over fasted, especially in India, where even if the surgery is next day at 4 p.m., the patient is fasted from a day before and no IV fluids. So hypovolemia. Primary cardiac arrhythmias, it could be a tachyarrhythmias. There can be myocardial infarction, electrolyte disturbances. Last, again, we don't very oftenly see last causing tachycardia, but yes, it can present with any type of arrhythmia. Sepsis, so that kind of patient we need to take care of. Circulatory embolus, this is one of the unknowns. And this is our go-to diagnosis when we are not able to pinpoint the reason on anything. Then circulatory embolism becomes one of the common things. And it has such a large number of surgeries these days that we do that can cause these things, right from laparoscopic surgeries to head neck surgeries to neurosurgeries to surgeries which are in head up position like shoulder arthroscopies. So there are so many places where we can spontaneously get some form of circulatory embolism. Either it can be gas, fat, amniotic. Anaphylaxis presents as tachycardia. Along with that, there will be so many things we saw in desaturation. There will be bronchospasm. Sometimes the grade 4 anaphylaxis can directly present with cardiac arrest and shock. Malignant hyperthermia that will be discussed tomorrow is one of the reasons, although we are fortunate not to get this complication practically in our life, but yes, this is one of the differentials. So we will consider the problem. So this is unknown. So along with considering the problem, we have to also treat it. So we'll start treating the causes. We'll start treating the condition. So very common cause, hypovolemia. So we have already done something about increasing the depth of anesthesia and analgesia. We'll start by giving fluid 10 ml per kg. For pediatric, usually around adult, you give 250 to 500 ml bolus fluid. Magnesium is very, very helpful. It is also a part of the multimodal analgesia. So it covers both the things. Amiodarone, labetalol, esmolol, adenosine. Out of this, amiodarone and adenosine is not something that we commonly use, but labetalol and esmolol is something which is ubiquitously present in all theaters. And this is just to tide over the crisis, that you don't want the heart rate to go 140, 150 and hypertension and then, ooze from the surgical side. So you will give these drugs. But yes, amiodarone is very specific. When you are seeing wide complex tachycardia. And adenosine is very specific for SVT. If you can diagnose SVT intraoperatively and you have the availability of adenosine with you, then you can try. But although that is something that, again, subject to whether it is available or not. In case, again, the patient has symptoms or the patient is not able to achieve an adequate control of heart rate with these things, then we will consider electrical cardioversion, right? So next, what I'm going to do is we are going to discuss the commonest cause, that is sinus tachycardia, and we have already discussed that inadequate depth is one of the common reasons for which we'll increase the depth of anesthesia, will increase either inhaled anesthetic agents or, like Paliwal sir told, dexmedetomidine or bolus of opioid or propofol. Hypovolemia, anemia, so fluids. Procedure related factors are very, very important. Sudden stimulation in any part of the surgical aspect of the things, or sudden blood loss. Embolism is a rare, but it is a cause when we cannot pinpoint on any other cause, and anaphylaxis is very, very common thing. It also associated with other things. And so as a whole, when we see the picture, then anaphylaxis is something that we rarely miss. This is something that we have discussed. And adenosine, of course, it is given 3 to 18 milligrams. So usually I think they give a dose of 6 milligrams and you have to double the dose in every next. So 6, 12 and then 18. And it has always to be followed by a push of IV fluid, 10-20 ml, because it has a very, very short onset of time. So you don't want the drug to get metabolized before it reaches the heart. Now, tachycardia, again, very large paradigm. We cannot discuss everything. And the arrhythmia part is little tricky to diagnose intraoperatively. So normally what we tend to do is we tend to follow some broad guidelines as to what we do. So tachycardia with pulse, we will assess, support ABC, give oxygen, monitor ECG, try to identify the rhythm, right? Most importantly, what is the question that is asked is the patient stable? Stable means unstable signs include altered mental status, ongoing chest pain, hypotension, other signs of shock. And most of the times rate related things, they appear after 150. Before 150, never somebody will say I'm having palpitations or tachycardia, right? So if the patient is stable, then we will establish IV line, obtain 12 lead ECG, and we'll try to look at QRS. But if the patient is unstable, remember, in unstable, there in bradycardia also, if there is unstable, we'll go for transcutaneous pacing. Here, unstable will immediately go for synchronized cardioversion. That means we'll try to revert the rhythm back to normal. But this is in an awake patient with pulse, right? This is different from defibrillation. But if the narrow complex tachycardia is there in a stable patient, then we'll see whether it is regular, irregular. If it is regular, then we'll try to break it using vagal maneuvers like carotid massage. If that is not helping, then adenosine. And then we'll ask the question whether the rhythm gets converted or doesn't get converted. If it is converted to normal rhythm, then we will then continue with adenosine or a long-acting CCB like diltiazem or beta blocker. If it doesn't convert, then we'll consider other causes of this condition like atrial flutter or ectopic atrial tachycardia, junctional rhythms, and then we'll obviously involve a cardiologist here because we cannot alone consider all the factors and do the treatment. But if it is a irregular narrow complex tachycardia, then our diagnosis comes to be atrial fibrillation, atrial flutter, or multifocal atrial tachycardia, which intraoperatively, of course, we can manage by beta blockers and diltiazem. But we need to involve the cardiologist along with them so that we can further move ahead in these guidelines. Wide tachycardia, broad principle that I have found very useful is whether it is with pulse or without pulse. If it is without pulse, straight away it is pulseless VT. That means you will start CPR. But if it is with pulse, then ventricular tachycardia can be monomorphic, polymorphic. Monomorphic can be stable, unstable. The principle remains the same. If it is unstable, go for cardioversion. If it is stable, we'll try drug therapy. Polymorphic, something that you can see in an old defibrillated patient, somebody who is prone to these conditions, and you give a QTC interval prolonging drug, say let's see ondansetron, which is very commonly given intraoperatively. So you can get polymorphic ventricular tachycardia. Again, the management remains the same. Little bit about electrical cardioversion and defibrillation. Electrical cardioversion is when we synchronize our electrical current through the QRS complex, because we want the wide complex arrhythmia to terminate and sinus rhythm to resume. There are certain things. One, the patient is going to be awake and you are going to pass an electrical current, so you need to ensure that there is adequate sedation. Secondly, it is always synchronized with QRS waves, and the energy that we use is lower, 50 to 200. So we start with lowest energy and then we move forward. As opposed to defibrillation, where we pass unsynchronized electrical current, the patient is usually collapsed. There is no pulse, there is no heart rate, the patient is in cardiac arrest, so there is no question of sedation. It has to be done immediately. We normally see two types of defibrillators. AED is used in BLS, can be used by anyone. We don't know what is happening, what is going to the patient. Everything is preset. While manual defibrillators is what we use in ACLS, what is there present in our theaters. We try to use maximum energy that it can deliver if we don't know what kind of defibrillator it is. But if we know, then biphasic defibrillators, we always start with 120, maximum up to 200 joules. So for adult perioperative tachycardia, take home message, again, recognize early, assess hemodynamic status simultaneously, whether it is associated with hypotension or hypertension, whether the patient is stable, unstable, awake, or unconscious. Oxygenation in all of this becomes very, very important, because we have to make sure that the patient is well oxygenated while we are trying to treat all these hemodynamic problems. And ultimately, the solution is in treating the cause of the condition. So this is what I wanted to talk about in adult perioperative brady and tachycardia. And this is just an amalgamation of what has already been discussed in all the unknowns that have been discussed before this. So thank you so much, and thank you for patient listening.
Oh, thank you, Anju. That was very comprehensive. And I think both Dheeraj and you have covered almost everything related to heart rate and blood pressure.
Actually, sir, Dr. Dheeraj had covered already everything. And
it's never, it's a good thing that when there is obviously overlap and
because he covered the symposium part so well, the idea. So because I included all those things in my slides, so the moment he started explaining that, I started deleting my slides. So my slides became very
you don't actually have to. I think repetition is good. It reinforces what has been discussed. So like my lecture itself also, that what Minati has talked, a lot of things was actually just, reinforcing thing, repeating it thing, and then the idea get reinforced. Anything else any of the panel members has to add to these topics till now before I think it's time for us to actually take a short break. But we're happy to actually see if anybody wants to add anything. And then we can start the second part of the symposium. Dheeraj, anything you wanted to add? Because we got 3 topics later on this afternoon. Well, it'll be evening in India.
Yeah, it's already evening in India.
Yeah. So chai ka time?
Yes, absolutely.
Yeah. So we will actually have a short break. It's nearly going to be midday here. So around 15-20 minutes, we'll be back for the symposium. Okay. I'll still be on this thing, and we just have a short break. We're not going to, switch it off, but we will be on here. Dr. Hemant?
Yeah, Dr. Anshul, it was
Yes,
a
sir.
very nice presentation. I just wanted to know, what about amiodarone? Did you mention that, whether I missed it?
Sir, I missed it. I mentioned it in tachycardia.
You mentioned it.
Yeah, I just mentioned it. Drug therapy, I have per se not included, because my idea was not to give drug therapy of all the tachyarrhythmias. It would have become too vast for me to cover in a short time. Also, I wanted to give more of the practical aspect of things. And the emergency use of amiodarone has already been discussed in cardiac arrest, 300 milligram, 150 milligram. So I did not really include the exact dosing and how we put an infusion in case we get a wide complex tachycardia. But yeah, it's there. I think one of the most commonly used drugs that we have.
In practice, actually, clinical practice, the combination of amiodarone and beta blocker does wonders in in tachycardias or even in AF. So no, I missed
And
early
the
part
other,
of early
I
part
wonder,
of
other
cardiac
wonder
arrest.
drug is magnesium sulfate, which you
Yes,
should
Correct.
focus on.
Magnesium sulfate.
Absolutely. And magnesium sulfate is something that for of course, somebody like Dr. Vaikar using antiarrhythmics is like using midazolam. But for us, it is always, there is an inherent anxiety because we are alone. And although we might feel that we know a lot about every drug, but we basically don't remember much of the details about the complications that can happen. So there's always this anxiety that what if we use and there is some untoward drug related complication. For that way, I think magnesium sulfate is a wonderful antiarrhythmic because we know that the safety profile is very good.
I think it's one of the most underrated drugs.
Yeah, but I think Shiv sir has elevated it to a very great heights, like, you know.
You still get questioned why magnesium sulfate, like.
And the best part about magnesium sulfate is that it is so cheap that the moment we started using Shiv mixes in the operation theaters, nobody raised an eyelid ki yaar, why are you using a new drug? Because every time we try to call for a new drug, like this is happening with Ropin now in India, like Ropin is 4 times expensive as compared to bupivacaine. So I immediately get a call the moment I tell that guy to keep a Ropin. He says ki yaar, why do you need it? Bupivacaine mein koi problem hai kya? And I'm like, no problem, it's a new drug. So the best part about max sulfate is it is very, very cheap.
Magnesium is never an underrated drug, I can say. We routinely use magnesium, and at times we use a lot of doses of magnesium. And you give magnesium start of the theater, in between, and later also. At times, patient doesn't respond to amiodarone, but respond to very high dose of magnesium. That's what my observation.
That's the difference between the cardiac and the non-cardiac part of it. For non-cardiac, people are still not using it. I started using it after my PDCs in cardiac at Sri Chitra, and after that I use it regularly. But even if you look at the other way around, for non-cardiac surgery, people are not using it. It's like only if they find a very compelling reason to use, then only they are using it. It's not like routine use. That's why
maybe institutional policy. My institute people use it a lot. Maybe.
I think the problem is, I'll tell you with the magnesium, I think it's the dose used is small. Most people actually think that 1 ampule would be enough. But if for arrhythmia purposes, you need to use, at least, well, it comes in different. We get ampules of 4 millimoles per ampule. So we're looking at 20 millimoles is around 5 ampules. But there are bigger ampules as well. I think you get 10 millimoles ampules as well. So they tend to use a much lesser dose. Instead of giving 40 to 50 milligram per kg, they still. Oh, I'm okay. You able to hear me? I thought you were saying that I'm not able to hear. So they need to actually. Well, and the problem is hypotension with that. If you give it too quickly, then you do see hypotension, but that can be treated with your vasopressors. It's not a big problem.
A lot of apprehension about use of Maxelf also comes because of a basic understanding of magnesium sulfate is from management of PIH. So we tend to always think in terms of respiratory depression and decreased urine output and stuff like that. But they use almost 10 times more doses than we use. And they are pretty happy. They don't even check for, I have never seen a gynecologist check for DTR in the ward. Ki, haan, isko maine.
No, they won't. They won't. I think that even though that is actually sad. The other I think issue with anesthetics is that it does potentiate the effect on neuromuscular blockers, non-depolarizers, but it's not to great extent. It's not that easy. Now, people don't use neuromuscular monitoring because probably it's not available that freely. But in a patient who are breathing spontaneously, you don't even have to worry about it. But if you have neuromuscular monitoring and if you use it, you'll see that the increase in duration is actually not significant. you will end up using the same doses at same interval of time. But if you're worried, then actually, yes, better to confirm at the end of the surgery, confirm that you got the 4 twitches before you give your neuromuscular blockade. The another thing you can actually give them, instead of giving a single bolus of 50 milligram per kg, either you can give it an infusion slowly, or you can actually then divide. You can give like 8 millimoles and 8 millimoles and 8 millimoles. You can divide it for other purposes, and it works quite well for it. Amiodarone, only probably used it maybe once or twice intraoperatively. We have pre-filled syringes for amiodarone in our drug carts, but very rarely used it. More commonly in intensive care. The dose is you have to give 300 milligrams slowly over at least 20 to 30 minutes, and then it's followed by 900 milligrams over the next 23 hours. So it is actually, it's not a, I wouldn't call it as such a neat drug, but then in emergency, when things are not working, you will have to give it at least 150 milligram bolus. And I have actually intensive care, I've given it once, active bolus, and things reverted back to normal. So yes, that's the apprehension with amiodarone, but pre-filled syringes of amiodarone are available. You might have to reconstitute it and give it slowly. Don't give us a sudden bolus again.
Even I believe it is indicated in cardiac arrest when there is a ventricular fibrillation, and then if it is not turning into a sinus rhythm, then you does give 150 milligrams of amiodarone and try to revert it.
Yes.
Only problem of amiodarone is the toxicity. I mean, over a longer period. It is nicely said it is toxic from the hair to toe. So every system is.
That is long-term use. I think the people who are on long-term use.
I think oral
amiodarone. That yes.
So that's the only problem. We are very. In cardiac, we are very apprehensive of converting amiodarone into some other drug like beta blockers later on for the post-operative period. Minimum we give about 1 or 2 weeks, or sometimes 6 to 8 weeks, and after that you change over to some other drug.
Yes, if you want to actually have a cup of tea, that's fine. You can keep chatting if you want to. That's okay with us. Go and get a cup of tea, and we can have chai.
Has anybody tried double defibrillation? Because I had tried twice. So giving using 2 defibrillators in resistant arrhythmias. Actually, I posted it on the anesthetist writer. So
do you actually change the polarity? Do you change the polarity of the other one?
No, sir. We do double defibrillation. That means you defibrillate twice simultaneously. So you keep 2 defibrillators. Defibrillate once and then charge the other at the same time, and then defibrillate another. And I think, sir, October 2020 ACC/AHA guidelines, they have mentioned it in one of the last points, and they have said that although this can be tried in certain conditions, but then they have not found any clinically significant effect in whatever studies they have done, because theirs is a retrospective data for all the things that they do. So I feel, I mean, if we are lucky to get even 1 defibrillator working in the theater, so I'm not sure. Plus, I think you see intraoperative cardiac arrest more than non-cardiac anesthetists. So,
So, but are you talking about this to be a biphasic defibrillators or monophasic ones?
No, sir, 2 biphasic, but you do double sequential defibrillation.
Separate 2. It's 2 defibrillators attached.
I know, but I'm not talking that, but are you talking about using 2 monophasic defibrillators or 2 biphasic defibrillators?
2 biphasic defibrillators.
Okay, that is a very unusual thing.
We have a 4 pads in the front.
I know, I understand
one is
that.
Behind, and the idea of that, suppose you give a usual one defibrillator with 1 shock, it traverses across the left arm or left shoulder to the apex of the LV, and that's how it defibrillates. But the problem there comes with the ventricular septum. The ventricular septum does not get enough energy to convert itself into the sinus rhythm. So this, if you crisscross these pathways of two shocks, then it's only as they have said like that if crisscrossing of this pathway may defibrillate the ventricular septum, and that's how the sinus rhythm may take over, because it
that's
changes
what
the
actually
axis.
happens in biphasic, isn't it? You go positive and then negative. There's turnover, and that's what people used to do with monophasic. They would try from the right arm to the apex and then turn over the pad, so the current is traveling the other way. And the problem was that there is actually a gap between them. So that's why I asked, if it was monophasic, then it makes sense that you're actually sending current one way and the other one after the other.
No,
then it is understood. But with biphasic, we won't. The other thing is that if you are using monophasic, the amount of energy which is actually lost in the subcutaneous tissue, and if your lungs are still inflated, is huge. You lose around almost 70 to 80% of energy is lost. So you end up getting only 20% of energy. So you need to make sure that the lungs are completely deflated. Right. And the depolarization which happens with first shock, that helps to actually for the energy to be transmitted through the tissues. And that's why you always used to, with monophasic, you say 360, and then 200. It was that 200 which ultimately actually reached the myocardium. But then I wasn't aware of the thing about the septum being interventricular septum being the raised part.
Yeah, that's the main thing. They're saying that septum receives very minimum shock. So that's how recurrent ventricular fibrillation takes place. And this cycle is broken by possible use of these two defibrillators. But it has to be done simultaneously. Yeah. And the thing is that paddles should not touch each other. Otherwise, the company will not take over the. I mean, if there is a damage to the machine, the company is not. They won't accept anything. So the paddles should be a little bit away. One is behind the scapula.
So could it be that you actually have like anterior posterior position on one and the right arm and apex is something like that kind of a positioning of the pads?
And you need a constitutionally large patient.
Yeah.
Yes.
No, you have a smaller pedals also. We sometimes for the second machine you use the pediatric pads, so that is very much easier to do that instead of adult pads. Use pediatric pads.
Yeah, just that there is chances of burns that increases because your surface area is reduced, I think.
Correct.
But these are, I think, probably maybe in future we might actually have better kind of defibrillatory techniques. But I think without actually knowing the basis.
I used it in 2 cases only. That was in MICU, where we are given shocks for 3-4 times. It didn't help. Then we tried this, and it
then
worked.
You got the second one.
It worked. So somehow it worked. I don't know whether it was just a fluke or whatever, because it is not yet recommended in clinical practice, clinical practice, but guidelines. It is not yet recommended.
Yeah. I think something which people should consider when they actually have
only in rare cases like where you fail to convert it into sinus rhythm with repeated shocks, because repeated shocks causes transmyocardial burns, which is not seen usually by naked eyes, but microscopically, and can cause severe heart failure in the post-operative period or post-shock period.
What is the chances of actually direct myocardial injury? Because it is seen with defibrillation. You do get increase in the troponin levels.
Yes.
But that could be because patient has already had a cardiac arrest. But also, how do we know that it is because of the cardiac arrest, or is it because we have been shocking the heart and delivering current to the heart, to the myocardium?
But it is, I think, it's natural to have some damage because you are passing a huge current through the myocardium. So that's why that biphasic came with a 200 joules maximum. Otherwise, earlier we used to give 360 was the norm, but it has been reduced to 200. So in the 2 defibrillators, we had to give 400 joules. So it is much higher than the 360 joules. But that's a disparate.
But you're still giving like that in sequence. So it is still a sequence.
Not in sequence. It is simultaneous. Together.
Wow.
Both pedals, both buttons has to be pressed together.
That is interesting, because that what you're saying now is that we are almost delivering the double the amount of energy
400 joules, but
simultaneously.
at the crisscross levels through the, I mean, from the right shoulder to apex,
Yeah.
and then
And anterior to posterior.
back, yes, anterior posterior.
Yeah, yeah. It's an
There are
interesting concept.
There are only case reports about this, but I have used it only 2 patients and both succeeded. So that's what I mentioned here, that in a desperate condition where you're not getting the results of routine defibrillator, then we can work trying. But as you said, it is very difficult to get 2 defibrillators at the same place.
You will have to
We
rush,
have
but
it.
I think cardiac centers will have them.
Yes,
Your
yes.
centers will actually have that, because
yes.
the cardiac unit, so
Every
theater
ICU,
and ICU, everywhere there are.
every ICU theater, or we have got 14 theaters. The 14 theaters had 14 defibrillators.
Yeah, so it would be easier for you than to have it.
It is a non-transferable this thing
Cardiac
item.
center, yeah.
Nobody touches that.
No, it's always nice to know the basis of why people actually are doing it. I think, like, I wasn't aware of that septum is intraventricular septum is one of the areas where there can be issues with.
It seems about septum receives on an average 15 to 20 joules only.
Only, yeah.
That's all.
And is that the reason why, like in open cardiac surgery, you're able to deliver, because you're very close to the heart, you're able to deliver that?
Yeah, you
So
deliver
does
with
that-
5 joules only. We start only with 5 joules. We don't give more than 5 to 10 joules.
Yeah. No,
And
that's why I said, because you are.
And sorry.
No, that's why I was saying, I was talking about the tissues, the build of the patient. It's a bigger build. So you have the subcutaneous tissue, you have the bone, you have the muscles, you have the air in the lungs. You're losing a lot of energy there. There's a lot of tissues which need to be depolarized before the energy is directly delivered to the heart. Whereas in you're directly now, when the open heart, you have direct access to that. So you don't need that much energy.
Yeah. Usually sufficient 5 to 10 joules are sufficient. And if you pre-treat them with the intravenous Zylocard, then even the joules, the amount of joules required for the defibrillation comes down, definitely. So we always give Zylocard first and then defibrillate.
Okay. I think, Minati and Dheeraj, anything else you want to add to?
Whoa. No, nothing more I have to add. Lot of discussion already done.
Yeah.
We also use Zylocard first, then defib. It becomes more effective in that way. Anyway, we try the drugs also. Unless it is a life-saving emergency, then we go for defib first. Otherwise, in intra, there is stability is there, hemodynamic stability is there, or coming a bypass. Then we go for drug first, then defib. Because we think more you defib, more the myocardial injury and more the reperfusion damage again, and there may be continuation of arrhythmia at sometimes. So unless it is life-saving, we avoid defibrillation.
Yeah, because in the routine practice like ours, defib is actually kept as a standby, and we don't see that kind of arrhythmias as you people see, because you're dealing with cardiac cases mostly. So ours is mostly terminated by drug therapy in most cases. Very rarely we would need to. I mean, the last time I used a defib, it was not again in my patient, was in a patient in a adjacent OT where my friend actually called me. This is a patient for hip fracture, having gone into fast AF and was becoming unstable, and then we needed to shock the patient. So we don't use it as commonly as you guys would use it, but it is there. And our theater corridor, they are kept in recovery area and in the post-op critical care area. Sometimes we actually have it like patients come with AICD and then you have to have the pads on because it's switched off the ICD. In those cases, we will actually have the defibrillator again. I haven't heard anybody actually having to use the defib So it's a very, very uncommon to use.
So in ICU patient, like we always used to try the drug first, unless there is severe hemodynamic instability or cardiac arrest and defib. Otherwise, we try drug first. Similarly, in the OR also, unless we are doing very small child like anomalous coronary and all, and while opening patient has a cardiac arrest or fibrillation, and you have to recover back the hemodynamic immediately, in that case we used to give a shock, but not also in very frequently, because at times there is a lot of intractable fibrillation, especially in the cases having aortic regurgitation while coming up. So that time also 1 or 2 shock maximum, then we used to go back on bypass and try drug therapy and come back. We also avoid defib frequently. And think of it causes a lot of myocardial damage. Edema and all, requirement of inotrop also.
I think the two things, I think more than the respiratory problems, which are probably easier to deal with, getting oxygen until this patient obviously had something like a pulmonary embolism and stuff, which are irreversible sometimes. I think cardiac arrhythmias, I think people get scared more of cardiac arrhythmias.
Absolutely. At times I have seen even amiodarone, the recommended dose, whatever his guidelines say, that doesn't work. We give different doses, and the patient, they varied also. At times they don't respond also to that drug, and they respond to high dose of magnesium, and some respond to digoxin. So it varies from patient to patient. Maybe that work, most of the fibrillation, they are genetically mediated, unless there is lot of chamber enlargement is there. So in that case, that is drug pharmacogenomics, I can say. And different drugs work. That is my personal experience in my cases.
I think you see
we do almost more than 5,000 open heart surgery in a year. And more than that number we deal in the cardiac cath lab as well. So many patients, they behave very differently when arrhythmia is concerned. So I'm excluding the patient like valve surgery. They have a fixed pattern of arrhythmia. But the other cases, they behave very differently. Coronaries, they behave differently. Children, they behave differently. Some children with jet, especially the tetralogy of Fallot, simple Dexmed, they work very wonderfully. And some patients, they don't at all respond. They go back home with jet. They don't respond to anything. So the response varied a lot.
I think there is a lot of like channelopathies and
absolutely,
which I think are genetic, and then they are difficult. I think what we are dealing in adult population is more of a lot of our patients come with AF, and or they might be deficient in magnesium because of nutritional causes, elderly patients.
Absolutely.
And then there are arteriosclerosis happening, and they're developing dilated right atrium, right ventricle, left atrium, and going into AF. AF is, I think, one of the commonest arrhythmias we see in our setup.
Yes, AF is, we also see a lot of AF in all kind of surgeries, all spectrum cardiac surgery. Again, AF is very, very common rather than the other arrhythmias. And again, genetic polymorphism, especially endothelin gene polymorphism, count a lot, which contribute to atrial fibrillation also, apart from chamber distortion.
Have you seen any of these cases having like maze therapy and
yes, initially we used to do a lot of maze therapy intra, but now again we stopped doing it. At times we do, but in many cases we just ligate the left atrial appendage, and in the cath lab also, when they're doing a percutaneous mitral valve dilatation, they first obliterate the appendage, LA appendage, then they go for the mitral valve fixation dilatation. And same in the OR also. At times we reduce the left atrium as such. If there is very huge LA, we reduce that. So mostly we do surgically. Initially we used to do a lot of maze cryoablation. Then finally we thought nothing is working, because when the entire chamber is distorted and every myocardial fiber is arrhythmogenic, so it won't help much. So it will automatically regress in time. So we just reduce the chambers.
Right. So that is surgically they reduce the size
Yes,
of the chamber.
surgically or in the cath lab they put some
a
plug in left atrial appendage because it is small.
appendage.
Yes.
Okay. Are you doing the same, Dr. Hemant?
No, here we ligate it from the outside. You just hold it with the if you are opening the left atrium, or if the patient left atrial chambers are open, then from inside you ligate it. You make from inside it is very easy to do that. But if you're not opening the left-sided chamber, then from outside you can just ligate the left atrial chambers. Left atrial appendage mainly.
Appendage.
Left atrial appendage, because appendage is the one which can lead to this thrombus formation, and they are more hyperactive, it seems. But as such, we are not doing MACE procedures here. There's now majority of these are taken over by a cardiologist. So they are encroaching on the surgical people all the time. So
we also do a lot of cath evaluation of the pathos. It's very common.
Yeah, I mean,
every
we
day
still
almost
record.
every day almost 2-3 cases we do in cath lab.
You still need anesthesia presence when they actually have doing this procedures.
We have full-fledged cath lab running on every day. So
I think AIMS is a huge center, cardiac center. I think saying the 5,000 cases a year, that's a huge number. And I think maybe around anywhere around 1,000 cases or more for cath lab in a day. How much you doing in a day? How many cases a week or day you do in cath labs?
Cath lab, I didn't count, but it is nearly 8,000 to 9,000 cases in year.
For the whole year, okay. Yeah, that's huge. That is huge numbers.
Maybe 10,000. I am not calculating the primary coronary intervention. Apart from that.
Apart from
that. Like every week, minimum 7-8 AST device closure, 7-8 VST device closure, and cart every day 3-4 cart are there. Then other
so what is that? Sorry, I don't know that. What is that?
Radio frequency ablation of the
radio frequency ablations. Yes.
So all the and then PPI. Many PPI were doing in the OR also, and those who are coming for primary placement of the device AICD, they go to the cath lab. That also every day 1 or 2. So plenty of cases.
Achal is here as well. It is joining us. Good morning, Achal. Hello, Achal. Your mic is
off.
Yeah. So Achal was also at the your cardiac center.
Sir was there that time. I was not there.
Yeah.
Sir was there long back.
He's worked very closely with Dr. Venugopalan.
I finished my residency in 2002.
Yeah.
That time, sir was not there.
Devesh, are you ready with your presentation?
Yes, sir, I'm ready. So should I start?
You've been working.
Yeah.
Still going on. Working for a lot of people. And that's why I think we have got a busy program tomorrow. Yeah, so the unknowns are very few, whereas the knowns, there are actually large numbers of things. And also, I think more people will be able to attend tomorrow than today. It's been a working day. So in the afternoon, we have 3 topics. We have Devesh, will be talking about fluid management. Last year, he couldn't do this topic. So we have that. Then we'll be talking about lactates, the role of lactates, which Minati will be covering. And we will end up with Vanita talking about delayed recovery and awakening, which is, I think we're going pretty sequentially as the day passes by. I think most people, I hope they've had a tea break and they're more awake. So Divesh, I don't think you need much of an introduction. You've been part of our regional anesthesia team. You have organized our focused approach to regional anesthesia at Asian Hospital. You are the director there, if I'm not wrong, now for the anesthesia services. So you can introduce, you can tell more about you, and over to you, Divesh.
Thank you, sir, for the kind introduction. Good evening, good afternoon, wherever you are watching from. So today the topic is perioperative fluid management. I'll take just a second to set up my screen.
No problem. Yeah, you're on.
Okay, is my screen visible, sir?
It is visible, yeah, and you're audible as well. So please go on.
So good evening, ladies and gentlemen. Once again, I bring greetings from Asian Hospital, the place where I've been working since past 12 years in various capacities, and presently I head the department. So I'll be presenting on perioperative fluid management. Give me 1 second. I think there is some technical glitch.
Which looks like that was actually a recorded version.
Yeah, maybe I think.
Yeah, that was a recorded version. I think you need to go on a PowerPoint. This is a recorded version.
No. This is a.
Because it says play on it. I can actually see that it comes on a play.
Okay.
Yeah. It's like a video. It's like a video.
Yeah, that is why it's not moving. Just give me 1 minute.
Yeah.
Okay. Can you see my screen, sir?
Yeah.
Okay. So these are certain disclosures. I'll be using certain images from Google. As I always say, Google Baba ki jai ho. Some references from PubMed. And I'll be giving you an overview about perioperative fluid management. So just to introduce the topic, fluid management is the cornerstone of the hemodynamic management. As we know, both underdosing and overdosing are deleterious. And whenever we are not able to do the fluid management properly, the end result is low perioperative arterial blood pressures, which are associated with myocardial injury, AKIs, and this is totally preventable. And fluid therapy and vasoactive drugs are used to maintain BP levels during the surgery. And the aim is to maximize stroke volume and treat hypovolemia. And basically, we all agree that euvolemia should be the target. So this is some of my lecture outline. I'll first talk about traditional fluid management. Then as we proceed further, I'll try to refute the myths which are associated with the traditional fluid management, discuss some of the strategies, and then how to choose the fluid therapy, and then certain guidelines which are available to us. So as we have discussed, we need euvolemia. So underdosing and overdosing has got its deleterious effects, which are known to us since ages. And two of the main references I've already cited. If we do not dose it properly, we get hypoperfusion, reduction in blood pressures, myocardial injuries, acute kidney dysfunctions, as well as stroke can occur. But if we overdose, then we lead to edema. And itself, it can lead to accumulation of water in lungs, thereby leading to disturbances in oxygenation and GI tract, thereby leading to ileus, decreased wound healing, and there's a host of adverse outcomes which are possible. So let's have a look at the traditional practice of intraoperative fluid administration. Traditionally, we have all believed that fasting induces hypovolemia, and overnight fasting, whenever we come to OT, it's a lot of loss of volume, and this is exacerbated in case we have undergone a mechanical bolt preparation. And the insensible losses from the skin and airway get exaggerated the moment the skin incision is placed. And the concept of third spacing, and it means that for a big size abdominal incision, around 8 to 10 ml of kg per hour has to be given extra. And we were of the belief that kidneys can handle as much fluids as we can give. So if you pay attention to this slide, you'll realize this slide is from Miller, and this is from 7th edition. And when I was doing my post-graduation, I read 5th edition, and in the 5th, 6th, and 7th, the same table has been given, which I'd like to explain in detail before I progress further. So traditionally, we have been used to calculating the basal needs by the formula 4-to-1, which was given by Holiday Cigar as early as 1957. And in Miller, it has been stated that for initial, whenever you give general anesthesia or neuraxial anesthesia, you need a compensated vascular expansion, which is to the tune of 5 mL per kg. Then the maintenance fluids have to be calculated at the rate of 4-to-1, and we need to calculate the NPO hours. So for example, if you're fasting for 10 hours, then for a 70 kg, then 1100 mLs you have to add. And these have to give in 50% in first hour, 25% in second, and next third hour, 25%. And third space losses, depending on the extent of surgery. In particular example in which Miller has cited, the third space was calculated at the rate of 5 ml per kg per hour. So if you actually look at it, the deficit NPO hours, the blood loss was 100 ml in first hour, and again 100 ml, and being replaced by 3 times the crystalloid volume, that is 300 ml. And in the third hour, it was almost 50 ml. And we calculate the third space at the rate of 5 ml per kg per hour, because this was not a big kind of an incision. So if you closely look at it, the cumulative balance at the end of 4 hours of the surgery is around 4 liters. So is this kind of fluid do we want to give? The answer is certainly no. And from 8th edition, which was published in 2014, Miller has cited the modern day concepts, and which has continued in the 9th edition. So traditionally, we have been using to give this kind of fluids. So if we give these kinds of fluids, what we get is a weight gain. And there it has been proven as early as 1990, and there are more subsequent studies, that if the perioperative weight gain is around less than 10%, for a major surgery, the mortality morbidity is around 10%. If it's between 10 to 20, it reaches 20. And if it's more than 20% of the weight gain, it will reach almost 100%. So we have an understanding that the excess of fluid is responsible for this weight gain and responsible for morbidity and mortality. So slowly and slowly, as I progress, I'll try to refute the myths which are associated with the traditional fluid handling. So overnight fasting. So the traditional concept was that the patient who lands up in the OT is going to be hypovolemic. But there are a number of studies to prove that preoperative fasting for approximately 10 hours does not significantly reduce intravascular volume. This was shown in 2008 in Scandinavian Journal, and very recently in 2018, again in Scandinavian journals, where they tried to fast healthy individuals overnight till 4 p.m. next day. And there was a slight reduction, which was not significant. So we have to get above this notion that it will lead to some kind of intravascular volume depletion. It doesn't result that way. So if you actually look at the fasting guidelines, which have been there are so many fasting guidelines by American Society, European, all of them are changing their terminology from allowed clear blue liquids to be allowed up to 2 hours to be encouraged. So that is the modern day concept, where you have to allow clear liquids up till 2 hours, and in pediatrics up till 1 hour. So this will take care of subtle dehydration or subtle decrease in the intravascular volume which happens. So what is the fasting guidelines in the context of ERAS protocols? So ERAS also suggests the same, that you minimize the fasting period, maintain hydration until 2 hours, you encourage oral water or simple carbohydrates. And it is a recent network meta-analysis where they have shown that excessive, like kind of complex carbohydrate is not encouraged. So what about mechanical bowel preparation? Whenever some kind of intestinal resection and anastomosis has to take place, the surgeons advise some kind of mechanical bowel preparation. The idea is to reduce the surgical site infection as well as anastomotic leakage. And it results in some degree of intravascular volume loss. But in 2011, Cochrane, as well as in 2018, JAMA Open Network, they have shown that even if you omit in the context of colonic surgery, if we do not do mechanical bowel preparation, it was not associated with anastomotic leakage. So majority of the surgeons these days may not opt for mechanical bowel preparation. Even if they do so, we can have certain degree of fluids to take care of the depletion of the intravascular volume. So what about insensible losses? So it is a traditional concept that as soon as the bowel is exteriorized, a lot of insensible losses keep happening. But as early as 1977, a study which showed very basic things, that the basal fluid loss via insensible perspiration is approximately 0.5 ml per kg per hour, and which extends to 1 ml per kg per hour during a major abdominal surgery. So that is not much of a loss. So traditionally, we have been told about third space loss, which gets sequestrated in either traumatized tissue or some kind of wound spaces, and it's not available to the circulation. And we have been very rigorously replacing this third space loss with huge amounts of fluid. For example, a midline laparotomy extending full length abdominal incision with 10 mL per kg per hour. Do we need that kind of fluid? Answer is strictly no. And my concept, and I think everybody's concept, would have changed by reading this article published in Anesthesiology 2008 by Daniel Chappell and colleagues, where they actually showed that third space is a more of a fiction rather than a fact. And they showed the concept that endothelial glycocalyx, which lines the endothelial cells on the vascular lumen side, is the gateway to interstitial space, thereby meaning if this layer gets disrupted somehow, then the fluid gets tracked from the vascular lumen to the interstitial space, thereby leading to weight gain. So how does this endothelial glycocalyx gets disturbed? Whenever there's kind of ischemia, reperfusion injury, hypoxia, some kind of inflammatory cytokinase, and atrial natriuretic peptide. ANP is released whenever there is hypervolemia. So hypervolemia is one thing which anesthesiologists can certainly control by giving restricted fluids. Whenever hypervolemia occurs, ANP is released. This causes a damage to endothelial glycocalyx and thereby worsening the fluid shifts which are happening from the vascular lumen towards the interstitial fluid. So let's look at the fluid compartments. This slide, I think everybody would be able to recognize that from our physiology days, that we have 2/3 of the body weight as the total body water. And in this case, example of 70 kgs, around 45 liters. And subsequently, it's again distributed as 2/3, 1/3, and the majority chunk is in the intracellular fluid, around 30 liters. And intravascular is 5 liters and interstitial is around 10 liters. And as you can recollect from my previous slide, whenever the glycocalyx gets damaged, we get a fluid shift. So if we talk in context of crystalloids containing sodium, it will reach up to interstitial. But if you talk in context of free dextrose like D5, then dextrose gets eliminated and the entire water is available to get shifted in the 3 compartments. So how do we actually monitor the intravascular volume status? We have been traditionally using static parameters, and we all understand their limitations, be it heart rate, blood pressure, urine output, CVP, mixed venous oxygen saturations. So more and more evidence is available in this last 20 years that we should start using dynamic parameters. In case you haven't started as yet, it's high time that you move on to dynamic parameters. Couple of them I've already cited: pulse pressure variations, systolic pressure variations, stroke volume variations, stroke volume estimates, left ventricular size estimates, and non-invasive technologies. So how do we actually assess fluid responsiveness? And if we look at this Frank Starling graph, we realize that the preload is the stroke volume is directly dependent on the preload. And if we are on the sharp side of this graph, we realize as the preload increases, the stroke volume increases considerably. But if you are on the flatter side of the graph, we realize there will be a very slight or there will be no increase in the stroke volume. This fact can be interpreted in the context of arterial line waveform analysis. So whenever we secure our arterial line and we are mechanically ventilating the patient, we realize during inspiration, because of positive intrathoracic pressure, we are not able to get good venous return. And this fact results in certain kind of variations in the arterial trace, which can be easily recognized and can be used subsequently. So how do we calculate the pulse pressure variation? So there are various ways: the manual way, the automatic way, and the visual estimate. The manual way has been discussed in our group, the Facebook group, the anesthetist, as early as 2013 by Dr. Shiv Kumar Singh and late Dr. Piyush Malik. So I will not be going into detail. Whosoever is interested can go back and look for those, how to do the manual calculation. And modern day monitors, like this is the monitor I have, Philips, we get a automatic calculated value where beat to beat we can have a pulse pressure variation. What about visual estimate? Does it provide a good, accurate estimation of PPV? My dear friends, the answer is big yes. So as early as 2012 in anesthesia and analgesia, they tried to assess the degree to which it provides the estimate of PPV using an eyeball technique or a visual estimate. So on the basis of clinical significance, authors concluded only 1% of the treatments based on the visual estimation would have been incorrect. So it's almost correct to the tune of 99%. And in case you do not have automatic calculations and you are securing an arterial line, then visual estimate will provide you a good idea of the pulse pressure variations. So coming on to the goal-directed fluid therapy, where we exactly set a goal for ourselves, like stroke volume variation more than 10%, MAP more than 60. If we are not able to achieve, we look at the cardiac index. If it's less than 2.5 liters per minute, we use inotrope agent. More than that, vasoconstrictor. So in last 15 to 20 years, we have a couple of papers which have shown the benefit of goal-directed fluid therapy versus control in high-risk surgeries. A couple of trials are there, particularly optimized trial and the Fedora trial. So friends, now coming on to the various perioperative fluid strategies which are actually available to the anesthetist. The traditional is the formula-based approach, which should not be used. As we have seen, it will cause a considerable degree of perioperative weight gain and can lead to problems. The liberal fluid therapy is almost equivalent to that, or maybe slightly lesser than that. And then came the concept of restricted fluid therapy, where there was a less of fluid being given to the patient and excluding the third space losses. But in the context of ERAS, the restrictive fluid therapy means zero balance, which can lead to acute kidney injury in the postoperative period. And the latest concept, the goal-directed fluid therapy, which I've already discussed in one of my slides. So how to choose which strategy is good for my patient? So we have to individualize the strategy for each and every patient. It will depend on the type of surgery, the extent, the duration, and particularly if you are having some kind of departmental guidelines for the perioperative fluid management, then the outcomes will be much better. In this study in British Journal of Anesthesia 2015, they tried to analyze the departmental guidelines for fluid therapy in the perioperative period in 2 centers. And they found wherever the departmental guidelines were not available and every individual was acting in their own way, the outcome for the patient was not good. So if you are working in a department, it's worthwhile to have certain guidelines for perioperative fluid management. I would like to request every one of you to pay attention to this relief trial. And subsequent to this trial, there have been certain modifications in the perioperative fluid therapy. Published in NAGM very recently in 2018, where they tried to analyze around 1,500 patients in both groups, in restricted fluid group as well as in liberal group. The fluid intake was around 3.7 liters for restrictive, and in liberal, it was around 6.1 liters. It was considerably different. But if you actually look at the rate of acute kidney injury, it was 8.6% in the restrictive fluid group and around 5% in the liberal fluid group. So we are going for kind of restrictive regimes, but at the cost of some kind of organ dysfunction. And in this context, it's the kidney. Should we be using that kind of regimes? The answer is no. So how do we actually go about in day-to-day practice? And this is a landmark article to me in Anesthesiology 2019, where they have discussed the perioperative fluid therapy for major surgery. So they have made a risk matrix. On the x-axis, we have the patient risk. Y-axis, we have a surgical risk, which takes into account the blood loss and the protein and the fluid shifts. Let's look at a scenario, for example, a lap cholecystectomy happening in a young patient. So the risk matrix would belong to this box. So we do not do a goal-directed therapy because the surgery is going to last 1 hour, and we can aim for a positive fluid balance. In this, it's mentioned as 1 to 2 liters, but for minor surgeries and daycare surgeries, they have mentioned in the article that you should aim for only 0 to 1 liters. So let's have a look at a patient risk is high. For example, a 60-year-old gentleman with the LV dysfunction, ejection fraction around 40%, but still the patient is going for a surgery or a prostate surgery, then in that context, a goal-directed therapy is certainly recommended. That means you secure an arterial line, monitor pulse pressure variation, and decide a goal for yourself. You can still aim for 1 to 2 liters. And this is a high-end surgery, for example, Whipple's, where you have to consider a surgical ICU. In all, if you notice, they have written you aim for 1 to 2 liters of positive fluid balance. That means they are refuting, they do not agree with the concept of restricted fluid therapy, or in brackets, the zero fluid balance concept, and which, as per relief trial, we should not be encouraging also. So, my friends, moderately liberal fluid strategy with overall fluid balance of 1 to 2 liters at the end of surgery should be our target. So, how do we go about it? Preoperatively, encourage the patients to have clear fluids up till 2 hours before surgery. Intraoperative, decide the fluid as well as the hemodynamic management plan depending on the severity and the risk matrix. Aim for 1 to 2 liters of positive therapy. Wherever you have to give maintenance fluids, give crystalloid. And wherever you have to give a volume therapy for blood loss or fluid shifts, please use either crystalloids or colloids. Goal is to optimize the volume first and then add vasopressors. And in high-risk cases, certainly use a goal-directed therapy. Post-operative, please try to ensure that patients switch over to oral fluid therapy as soon as it's possible and remove all the IV lines as soon as possible. So the next question comes to mind, which fluid? So we have classically crystalloids and colloids available to us. And over the years, the concept of balanced crystalloids and balanced colloid has also come into being. But as we know, whenever we give crystalloids, 4/5, around 80% will extrude into the interstitial space within the next 30 minutes. Excuse me. So what we are left with, just 20% inside the intravascular space. Whereas in case of colloids, we are well aware that colloids cause good volume expansion to the tune of 80 to 100%, depending on their molecular weight for 4 to 8 hours or much more also. So we have to discuss that the fluids have to be taken as drugs. For drugs, we decide which drug to be used, how much to be given, what should be the duration, and when should we stop. So the bottom line is give the right fluid in the right dose to the right patient at the right time. So this concept that fluid should be treated as drugs is available very recently from the International Fluid Academy. So my humble request, we should think on these terms. So the next question which comes to us is which crystalloid should be used? The answer is very clear, balanced crystalloid. This has been stated very well in European Journal 2016, where they have given guidelines for intravascular volume therapy. Their recommendation is whenever you have to use any crystalloid or colloid, please use balanced one. And balanced crystalloid isotonic electrolyte solutions must be used for peri-interventional volume substitution. That means in OR or any other kind of intervention. So what about colloid versus crystalloid controversy? The traditional belief was that if you have to use crystalloids, it has to be 3 times. And over the years, we have realized from various studies that this ratio was quite high. We actually do not need that much of crystalloids. We actually need in between 1.3 to 1.5. And we have to realize that the volume expansion of crystalloids and colloids is context sensitive. For example, if we try to infuse 1 liters in a normal volemic patient, then majority will get extruded into interstitial space very fast. Whereas if the patient is hypovolemic for any reason because of trauma or anything, and we infuse around 1 liters, then we'll realize that the major chunk of the fluid would be retained in the intravascular space. So there lies the importance that we have to judiciously use fluids, and the timing of giving fluids is also very important. So what about hydroxyethyl starch in the perioperative period? In the previous slide, as you can recollect, I had shown you certain trials, CHEST trial, 6S trial, all of them had shown around 2012, 2013 that HES is not good in critically ill patients. It leads to decrease in the renal function, leads to disturbance in coagulations. That is why around 2012-13, FDA and various other associations had introduced a warning that HES should be avoided in critical ill patients. So what about HES in perioperative period? Can it be used? Because right now we are talking in context mainly of elective surgeries. So again, the same guidelines published in European Journal of Anesthesia. The recommendation is colloid solutions, be it HES, gelatin, can be considered equal to crystalloids as volume substitutes in the peri-interventional therapy of acute hypovolemia. So in context of elective surgery, where the creatinine is normal, where coagulation is normal, please go ahead and use HES. So I'm almost coming to the tail end of my presentation. So I'll be issuing certain kind of recommendations on the basis of the studies which I have quoted, on the basis of guidelines. So one should be using a balanced crystalloid solution for maintenance perioperative fluid therapy. Crystalloids to the tune of 1.3 to 1.5. Please avoid dextrose containing solutions because hyperglycemia does happen because of stress and we'll be exacerbating that hyperglycemia. And normal saline, we should be avoiding large volumes, particularly in the context of critically ill patients. And we know because normal saline, because of high content of chloride, can lead to hyperchloremic metabolic acidosis, which can further lead to deterioration in kidney function. And for volume therapy, that means for certain fluid shifts or for that matter, blood loss, we have to use crystalloids and colloids till the threshold for the blood loss replacement has been reached. So are there certain guidelines available? As I have discussed with you, one of the guidelines, I'll discuss other also. The first one was by British Consensus Guidelines, published, I think, in 2008 and then revised in 2011. And we have European guidelines. Then we have guidelines from International Fluid Academy, published very recently. Then we have guidelines from Perioperative Quality Initiative Consensus Statement. So whatever these guidelines have said, I've already discussed with you. So to summarize, my dear friends, perioperative fluid management has to be patient-centric. The third space doesn't exist. So we have to think in terms of moderately liberal regime, where we have a positive balance of 1 to 2 liters at the end of surgery, of a major surgery, and a minor intermediate surgery around 0 to 1 liters. And whenever the invasiveness of the surgery is in the range of moderate to severe, please use goal-directed fluid therapy. Pulse pressure variation can be very easily used. We generally insert an arterial line. You can, if you do not have time to calculate using manual methods, or you do not have that monitor which gives you automated value, visual estimate will hold true. And we should think fluids of as drugs. And certainly, if you are in a department, please have certain kind of departmental guidelines. So thank you very much for patient listening. If there are any questions, I'll be more than happy to answer.
Anyway, starches are out completely. Like our department got rid of starches quite a long time ago. So starch is whether balanced or unbalanced doesn't. And rather now is even gelatin based. There is question about actually them. They're talking about balanced gelatin base, which is actually combination of gelatins with balanced crystalloids. So that's been actually the thing. Then again, goal-directed therapy, there were recent trials in which they had actually looked at just empirical fluid versus goal versus directed therapy. And I think in perioperative period made no difference to the outcomes. And they're looking at long-term outcomes. So in most cases, I think people tend to be, I think, pretty okay with predicting the requirement for fluids. And like you clearly pointed out, it's a balance of actually positive balance of 1 to 2 liters makes no difference, especially in patients who actually have got a functioning kidney or do not have any cardiac problem. So in patients who have got deranged renal function or deteriorating kidneys, or patients who's got signs of any signs of heart failure or other causes, in most patients, they would actually just V out. They would actually take care, the body will take care of the, the excess fluid. I mean, you can see it in patients, long surgery, you see it. You keep giving more fluid, they will just keep passing urine like anything. You will have to keep changing the urinary bag from time to time, or they will just sometimes, we had cases where it has actually burst because they passed so much of urine. So fluid therapy is important, but I think the main message, like what you have said, that it's okay to be sort of moderately liberal with your fluid. It doesn't actually, you don't have to keep them dry as it was. And one of the cases of which I think you did talk about surgeries like Whipple's when you're talking about how much fluid we give in situations. And this was the observation that patients in Whipple's, they used to keep patients very dry. And the patients would come to the post-op critical care unit. They would actually be hypotensive. Especially what happens is that they activate the, their epidurals towards the end. And they have hypotension from that. And then they also are dry and they get, it's kind of hypotensive. We are pouring in fluids because the CVP is in negatives. And that actually causes more harm. Acutely loading patient and then vasopressors. So maintaining the fluid throughout the intraoperative period, even with a slight positive balance, is probably better than trying to keep them dry and giving more fluid in the post-operative period when kidneys have probably already taken a hit. And like Dheeraj has already mentioned, it is actually also important that we maintain the mean arterial pressures. Studies have shown that it need to be kept over 55. That is in general thing. And patients who get, so most of our monitors, we try to actually set the mean arterial pressure, which most people don't actually record. They do look at it, but they don't record it. To that, keep it at 60. The limit, the lower limits is kept at 60 millimeters of mercury. So that intraoperative pressure, mean arterial pressure, is maintained around between 55 to 60 millimeters of mercury. Any level of hypotension below 55 does knock out the kidneys a little bit.
In the context of colloids, as you have mentioned, so I'd like to share that whatever papers are available in context of perioperative period, and in context of goal-directed fluid therapy, 90% of the times to achieve the goal, colloids have been used. The baseline fluids were crystalloids to maintain the maintenance, but the volume therapy, 90% of the papers which I've read, but I've not cited, the colloid was being given. So there are only 4 or 5 I came across where they have actually compared colloid with crystalloid as a bolus in terms of goal-directed fluid therapy, where they found that you will require more of crystalloid to achieve the same goal in comparison to the colloids. That's why in our setup, and maybe I think many setups in India, initially we were skeptical. In 2012-13, we had totally stopped using, even for a normal kidney function, for an elective case, I mean, total laparoscopic hysterectomy. Suddenly there is a sudden blood loss, blood has not been arranged, we thought it, and we were not giving. But over the years, we have again started for the last 5-6 years. And I have cited the European guidelines also, where in context of thoroughly elective surgery, normal kidney functions and normal coagulation parameters, we can certainly use HES, not to 30 mL per kg, we do not require. And we can buy time till the time we get our blood products ready. I think that is what we are using.
I think Achal has got his hand up and want to tell us. Hi, Achal.
Hi, thank you very much. Good morning, everyone. Just a couple of comments. One about the use of hexaethyl starch or any starch for that matter.
Yeah.
I think our center did a study and published it, but that was in relation in the cardiac surgery. And we used colloids and compared with crystalloids after cardiac surgery. And there was clear evidence that there was more renal damage in patients they were used, colloids were used. So as Shiv said, that same thing in our center, we have taken in our pharmacy, the only colloids available is albumin or any blood products. So they have been taken off the shelf. So that was my one comment. And second comment is related to, I was on call yesterday, so I did a case. I'm still confused. So it's a 77-year-old female came with melena and bowel stricture, so booked as laparoscopic hemicolectomy. So we started the case. We had an arterial line, 2 well-running IVs, and we gave, and it turned out to be ischemic gut, and they had to do the colectomy open. I gave 6 liters of fluids, 2 units of packed cells, and she was persistently still hypotensive. Urine output was low. PPV was always high. All indications of a patient was still needing some more fluids. So after 7 liters, we were little not sure what is going on. And we were already on norepinephrine infusion. Then we did this was in recovery period, we did the POCUS and found her IVC was still collapsing. That means she was still hypovolemic. Then we gave a liter of albumin, another liter of crystalloid, and then we were able to switch off the norepinephrine. So sometimes we can be totally taken aback, whatever fluids we give. And I believe in giving a little bit of extra fluids, but again, sometimes you can be totally taken off guard.
That's a great observation, Achal. I think Divesh just say there is nothing called third space, but I do still believe there is third space, especially if you have obstruction. Patient can sequester a huge amount of fluid into the gut itself. You will likely see the actual fluid within the bowel. Now, that is not part of your compartments. That is outside the compartments. This is not. So you do lose quite a significant amount of fluid in obstructed gut. And
That's
again,
true. For intestinal obstruction, we lose.
Yeah, or bowel obstruction or stomach or anything, you do actually lose quite a significant amount of blood. And that's what I think Achal's case was about. Despite giving, I'm pretty liberal with fluids. Like I said, I look at 2 things in my cases, whether patient has got history of heart failure and is their kidney function okay or not. If that none of them are there, I don't even care. I'll have the fluids running kind of like a tap. We have 1 liter bags. Most of us use a liter bag. So most of our patients will likely get at least a liter before even the surgeon actually starts.
The point I wanted to emphasize was that we should not be practicing restrictive fluid regime. This is going to cause harm to the patient. Whatever ERAS may say or whatever they may say, we should use a moderately liberal regime where if you are positive by 1-2 liters, and it won't make much of a difference. We should not aim for zero balance. This will 100% cause harm to the kidneys for sure.
Yeah. And I would still, I think, say, well, again, Achela also has agreed with this. Starches are not good. If you have to use any colloid, I would actually go for a balanced gelatin based. So if you're still using starches, I would actually, starches are no good. I think probably if you are looking at they're using albumin, we don't actually use actually. We still actually have gelatin, so gelispan. I would actually move on to balanced gelatin based. They're probably much safer than starches.
Crystalloids, which crystalloid do you prefer? Balanced one or
So we
ring
have,
lactate?
absolutely. So we either use Hartmann's or we use Plasmalite. These are the only two
Yeah,
crystalloids.
Plasmalite is, I think, quite common in India. So,
Yeah, one of the only thing which plasmalites you would actually observe is hypocalcemia. It just sequester calcium. So if you're actually having a patient who is still hypertensive, just check their calcium. This is my observation, and this has been consistent. I mean, without doubt. If you have used 4 to 5 liters of thing, you will invariably see drop in calcium levels. And I normally use almost 40 mLs of calcium gluconate and sometimes more depending on duration of surgery. I will just put 30 to 40 mLs into the bag of fluid and run it. And you will actually see that the requirement for the vasopressors goes down significantly in these patients. So be careful with plasmalite hypocalcemia, very, very common.
So what is your strategy? Like, I'm sorry if somebody.
No, that's not.
Whenever you put an arterial line, do you assess the PPV by a visual estimate, or you manually calculate, or you use automated values?
So we have got LIDCO, which can be connected to the arterial line.
Okay.
So you can, but saying that, I would actually use a LIDCO or use measurements only for cases where you're going to see significant shift in fluids. Like for example, when I mean, a lot of people do it, but if I'm actually doing an open aneurysm case, say abdominal aneurysm case, which I know is going to have a fluid, that makes no difference because I know at one point there'll be a huge amount of blood loss. So that blood is collected into a cell saver and I will get back that. So I will give that back. I have never actually needed to use a parameter looking at. I know it will happen. The blood pressure is going to drop. There will be requirement of fluids. Okay, see, there's no point in actually using that. But in a cases where you have very long cases where you're going to see significant shifts, then like for example, Whipple's is probably one, or long abdominal open surgeries. Maybe those are good idea to use a PPV or whether you use LIDCO. There was a time when everybody was using esophageal Doppler for most cases. But problem was that you don't get a proper position with Doppler. You have to keep fiddling around with them. So we have moved to LIDCO, which can be attached to the arterial line. So all you need is arterial line, and it'll calibrate on itself, give you all the work.
The Philips monitors, I think majority of us are using. We can get it's a small algorithm. We have to just type in some codes and all. So it can be used to get a automated value. But visual estimate is quite good, I guess. I mean, we can just with eyeball, we can come to know variation.
Absolutely, yeah. And I've shown on the thing how you can actually compress the whole thing and
As early as 2013, I remember.
You can calculate. You can calculate in 5 steps. You can actually calculate. If you want to give it a number, you can. But otherwise, most of the times, as we always say, it is not the absolute number. It is how the trend is over the time, and just use that.
For PG students and DNB trainees, I think they should know how to manually calculate this.
Manually as well, just to give an idea. But with time, you will actually get that, this is significant pulse pressure variation is actually happening in this cases. So hypovolemia is, okay. I think let's move on to the next one again. Minathi, you are back again to another important, I think that is again related to fluids as well. Minathi we have introduced her this morning, and she'll be talking about the lactates, the value of lactates, how we can use that in perioperative period, importance of lactates. It's not open, nothing. Yeah, that's it.
I think it is visible.
Yes, it is visible, and you're very audible, very clear.
Again, I'm back with this is something different, and most of the PG students, especially because this crisis management symposium is mainly meant for the PG student, And most of them, even while I was a PG student also, I used to ignore lactate. But it has a lot of significance value while you are managing the patient. So we'll talk in brief what is lactate, how it is get metabolized, how it is get generated, and mostly, and I'll show some few cases how actually increase in lactate can be managed, and whether that increase in lactate is significant, it should be intervened or it should not be intervened, until what extent it should be intervened. The first case has minimal intraoperative change in the lactate, and the second case there is a massive increase during the perioperative period, and this patient also had increase in blood sugar level in the entire post-op period. The third case, however, has no hypoglycemia and no hyperglycemia, but there is again massive increase in lactate. And the fourth case, there was wide post-op fluctuation, and this child has some increase in pre-op lactate, and the increase in was minimal, but there was wide post-op fluctuation. So how we are going to manage all these things? If you come to lactate, what is exactly lactate? This is a strong anion, and this result from the dissociation of the lactic acid, and this is the end product of glucose from anaerobic glycolysis. We all know that. So why we want to measure this thing perioperatively? Reversibility of the elevated lactate is a favorable prognostic indicator for surgical patient and the critically ill patient. This is what many literature says. But however, there is not much of study in the general surgical scenario, and many of the studies are especially happen in the cardiac setup. And lactate also help in goal-directed resuscitation, but not exactly in the presence of sepsis. And focusing on lactate clearance would rescue many patients from harm. So usually one normal human being produce 0.3 to 1 millimole per liter, that is 1300 millimole per day of lactate. And this plasma concentration of the lactate, this is a balance between lactate production, metabolism, and conversion. Actually, very little is excreted. And the major tissue sources of this anion is myocardium, hepatocyte, kidney, skeletal muscle, and skin. So if you can see the glucose particle on the process of the glycolysis is get converted to pyruvate. If the aerobic metabolism happens, and it goes to the Krebs cycle or citric acid cycle to give rise to ATP, which is utilized for energy. And if anaerobic metabolism happens, then it get converted to lactate. And more of lactate again help in gluconeogenesis apart from accumulating in the body. If the liver function is all right, it get converted to pyruvate and in neoglucogenesis. So increase in lactate in the aerobic situation also, this goes parallel with the hyperglycemic status. So when you come to the lactate metabolism, it is more complex, and this is basically balance of production, conversion, and clearance rather than the balance between the production and the clearance, because most of the lactate, they got taken up by the peripheral hepatocyte and the monocyte. Almost majority of the 70% and 30% excreted in the kidney. And this whatever is taken by the liver, many of them are get converted apart from the 5%, they get converted and help in neoglucogenesis for the energy utilization. So this is a very common terminology, hyperlactatemia and lactic acidosis. Hyperlactatemia is there is increase in the lactate level, that is 2 to 5 millimole per liter, but there is no acidosis. Whereas lactic acidosis, it is much more dangerous. There is persistent increase in lactate level that is more than 5 millimole per liter, and this is definitely associated with the metabolic acidosis. So this is which need attention. So 5 millimole per liter lactate level with metabolic acidosis is more harmful rather than 5 millimole per liter without acidosis. So the previous one, this need attention. So the term lactate clearance is a misnomer. This is because most of the lactate, they get utilized in the glucogenesis. So the serum lactate level represents a dynamic process, the net result of production, conversion, dilution, and the clearance. So when it comes to the increase in level of lactate, it is usually two types. So hyperlactatemia type A and type B. Type A is more risky, and this need attention. This is mainly because of the anaerobic glycolysis and the ischemic condition produce the type A hyperlactatemia. Whereas the type B, this is aerobic metabolism occurs here, and this can be because of the disease condition itself, like diabetes mellitus or any hepatic disease. This can be due to some drug or toxin, or it can be due to inborn error of metabolism in which the lactate cannot be get converted to help in converted for neoglucogenesis, and it get accumulated. So all these things are happen in the presence of aerobic metabolism, and they go in the classification of type B lactic acidosis. Another important thing is a lactate pyruvate ratio. The normal lactate pyruvate ratio is 10:1. And what is the significance of this ratio? Because this, in case of lactate accumulation, this ratio become increased. That means you have to keep an eye and monitor the patient seriously. So these are few conditions in which there is a increase in blood lactate level, like if there is increase in rate of glycolysis, especially in the hypoxemia, anemia, hypoperfusion, shock, and carbon monoxide poisoning, severe exercise. In all these cases, there is type A lactic acidosis happen. And pheochromocytoma, use of salbutamol or catecholamine. And in case of enzymic deficiency, thiamine deficiency, all these cases, again, the type B lactic acidosis is happening. So hepatic metabolism is important for lactate clearance. If any case there is impaired liver blood flow, enzymic defect, or cyanide toxicity, so this case also there is increase in lactate level. Similarly, if there is neogluconeogenesis impaired because of biguanide therapy, especially metformin, that is very notorious for causing lactic acidosis, alcohol intoxication, diabetic, all these conditions give rise to inhibition of neoglucogenesis. So whatever lactate is there in the liver, they get accumulated. And in case of if there is again impaired renal excretion, they account for less than 5% of the hyperlactatemia, especially, and they increase in the lactate level. So as I said, both hyperglycemia and hyperlactatemia, they go together. And there is increase in glucose in especially in the sepsis, or in case of the cardiopulmonary bypass. And in case of steroid use, the increased glucose level again give rise to increase in pyruvate and increase in lactate. And CPB also, because of inflammation, reperfusion injury, there is lot of oxygen-free radical. They decrease the level of pyruvate dehydrogenase, and there is increase in the level of lactate. Increased level of lactate again give rise to insulin resistance. So there is lot of glucose accumulation, and which give rise to hyperglycemia. So that's the reason why most of the type B hyperlactatemia, they usually accompanies with the hyperglycemia. So hyperlactatemia in the perioperative period, if it is a type A, especially the ischemic origin, it is a contributor in the major vascular trauma and the cardiac surgery, and it can be due to anaerobic metabolism secondary to tissue hypoperfusion in all these cases. And this tissue hypoperfusion can be global, entire body, maybe regional, especially in the limb ischemia, or in the microcirculatory level, especially when the patient is put on cardiopulmonary bypass. In this case, there is alter in lactate pyruvate ratio, which is more than 10:1. And there is metabolic acidosis, which is definitely present, and however the serum glucose level may be normal, or it can be variable depending upon the diabetic situation of the patient. And this kind of hyperlactatemia, it usually occurs early in the perioperative period and within 6 hours of the thing. And if it is a type B, and this is not always usually associated with inadequate tissue perfusion, the patient may be having normal blood pressure and normal heart rate, but however patient may have hyperlactatemia. The pH is usually normal in this case, but it can be slightly acidotic. And hyperglycemia is usual, as I said, and this is correlate with the rise of the lactate. And the lactate pyruvate ratio, again, it is important, and this is usually maintained in case of the type B hyperlactatemia. And this is usually late onset, and it occurs 6 to 12 hours post surgery. One can remember most of the routine surgery, it is not essential, will develop type A or type B lactic acidosis, especially the surgery which lasts for longer duration and there is massive blood loss. These are the cases in the general surgical side. They have lactic acidemia or lactic acidosis in the post-operative period, but not other small surgery like cholecystectomy and all. So now come back to the case, come to the first case. This case has gone for aortic valve replacement. There was mild hypothermia, and there is minimal rise in intraoperative lactate. People say even if the lactate is more than 2 to 3, so these are the cases the literature says they do, there is more of morbidity and mortality in the post-op period. But whether exactly that happens or not, most of the time, because lactate is actually not properly studied until date. There is not lot of literature again available when the surgical things are concerned. So this is a case, and the initial lactate level was 0.8 and it increased to 3.2 while we shifted the case. And there was a gradual increase when we put the patient on bypass from 2 to 3, and while we shifted it was 3.2. So did we intervene? We didn't intervene for that case. And these kind of cases, lactate abnormality, mostly they are transient. So this patient, after 12 hours, the ABG become normal and lactate came down to the preoperative level. And till discharge, it remained below 1.2 millimole per liter. So these are the cases in which lactate rise occurs due to transient reperfusion injury, which is mainly related to bypass, or if it is a prolonged surgery, again reperfusion injury can also happen in that case. It is a lactate increase related to that, and systemic inflammatory response syndrome. And these are the cases which revert back usually normally, they don't need any intervention. So now come to the second case. This case has undergone a major vascular surgery, and you can see, and the hemoglobin was 13.5 and the lactate was 0.7.8. And then there was some damage by the surgeon occurred. The lactate keep on increasing 1.5, 5.1 within 30 minutes. Then 6.8, and this time the patient was highly hemodynamically unstable, and you can see the hemoglobin came down to 6. So we went on emergency cardiopulmonary bypass. In the bypass also, lactate level keep on increasing for certain time period. And while we came off bypass, lactate level was 11, but that time hemoglobin level was normal, but still then the lactate was in the higher trend. When we reach in the ICU, lactate was 10.2, and we settled down the hemoglobin and it was 11. And the blood sugar was normal, however, throughout the period. And we didn't administer any steroid to this patient. However, we started off some adrenaline, noradrenaline, and dobutamine while coming up the bypass. And you can see ICU at the 12th hour, it was 9.8, and hemoglobin was nearly normal throughout the case, and 24-hour it is 8.2. Then day 3, it is 6.8, it came down much more. And this point of time, we switched off the adrenaline. Then next day, again, it down further, noradrenaline was switched off. And day 11, patient was off oxygen and the lactate was 0.8, it was pre-normal value. So this patient is again, but the blood sugar was throughout remain increased, and this is the patient which developed insulin resistance transiently. The blood sugar went up to 250, 280 in that case, and a lot of insulin infusion was needed for this case. So, but however, initially the lactate pyruvate ratio was abnormal. We did a pyruvate also for this patient, but on the day 3, lactate pyruvate level came down to the normal. It remained 10:1 and below that. And but however, the hyperlactatemia that persisted till very late day 5, 6, and later on it came down to the normal till the discharge. The third case, this is a case post-chemo, post-RT, huge mediastinal mass abutting to the SBC and the PA. And patient was otherwise normal hemodynamically and the blood gases and all. And initial lactate was 10.8. But however, there was a rupture of the PA while dissecting, and there was sudden cardiac arrest and the rise of lactate 6.9, 7.5, like that. It keep on increasing. But however, during shifting of the patient, it again come down to the normal. So this patient also have a transient lactate increase, but however, there is no hyperglycemia in between. So this is the case. The lactate may be due to ischemic origin, and that is a type A lactic acidosis. So this came down with the management. So the final case, so that is a 14-year-old child. It is a recently operated. The pre-op lactate, this case was however 3.2. So this can be due to because the child is cyanotic, so some kind of ischemic event is there. So initial was 3.2 and it keep on increasing, not much, but 3.8. We shifted the patient to the ICU, and you can see the intra was uneventful, and the CPB time and cross clamp time was not much, and the blood sugar level again remain normal. So that means this patient is again having type A lactic acidosis at this point of time. Immediate post-op also everything was fine, and the patient was extubated after 6 hours. But however, on the day 3, the child started unstable hemodynamic. The blood sugar keep on rising, and we had to add on multiple inotrop because the child developed severe RV dysfunction. So if you can see lactate, it again came up from the initial value. And the day 3, day 4, it again started. That time also, if you can see, the blood sugar level was also 1.70, 170, 146, like that. It keep on increasing. From the day 5th, again the lactate value came down 1.11, like that, and the blood sugar also keep on doing. So this case has a mixed type A and type B lactic acidosis, we can say that. So this is how the cases you can diagnose. So how you are going to manage the hyperlactatemia in the perioperative period? And the first step, look for adequate tissue perfusion is there or not. And this you can know from the physical examination, from the hemodynamic parameter, if there is any adequate urine output or not, and what is the core versus peripheral temperature gradient, the NIRS value, and alveolar arteriovenous oxygen difference. Suppose you don't find any adequate tissue perfusion, that patient is in shock, then you can go for inotrop, volume replacement therapy, or oxygen to bring up the lactate. Suppose a patient has adequate tissue perfusion, but still then the lactate is high, then you go for the blood sugar at the same time, and most of the time it is, as I said, this is accompanied by hyperglycemia. You have to treat the glycemic status as well, and this is type B. You have to observe this patient. Then next step, and look for any regional or local perfusion, especially in the limb in case of the gangrene or any gout ischemia, or if there is any shunt or any compartmental syndrome. Suppose if it is there, then again you have tried to fix the cause and repeat inotrop, repeat volume, and give oxygen. Suppose all these things are not there, patient is still having increase in lactate, then that means it is type B, and you have to observe. Then coming to the next step, look for the any iatrogenic. Suppose these things are not there, then you look for any iatrogenic contributor, like if the patient is having any high dose catecholamine going, any steroid repeat dose, or any metformin therapy, or massive blood transfusion, or any toxin. In this case, if all these things are there, you try to fix this problem or discontinue the things if it is not essential, and then your patient will be managed. Then next thing, suppose all these things are not there, but still then patient is having hyperlactatemia in the post-op period, look for patient is having any uncontrolled diabetic mellitus, and fix the insulin, and any liver dysfunction, you have to manage that. Any thiamine deficiency in burn, then that has to be addressed, and any mitochondrial dysfunction, especially microcirculatory state, those things has to be managed, and this underlying condition to be treated to manage the hyperlactatemia. Suppose again these things are not there, but you have to find out if there is any metabolic demand is there. Patient is having recurrent seizure, fever, any infection, thyrotoxicosis, or malignancy. So all these things are need to be addressed, and these are the things basically they give rise to type A hyperlactatemia along with the lactic acidosis. Suppose all these things are not there, then it can be type B, and you have to wait and watch. So hyperlactatemia in the perioperative period is usually mixed etiology. It can be due to type A and type B, and mostly it is type B, unless there is hypoxemia and ischemia is not there. And isolated type B hyperlactatemia more common in the post-CPB setting. It is associated with hyperglycemia. pH is usually normal, and the prognosis is good. Hyperlactatemia in the type A variety, and it is usually seen in the intraoperative period, especially if surgery is extensive. Patient is on cardiopulmonary bypass, and these are usually self-limiting, and these continue till early post-op period, and pH is usually acidic, and these are the cases who have high morbidity and mortality unless addressed rigorously. So treatment is early treatment and aggressive treatment is essential. So sepsis per se is not alone responsible for hyperlactatemia. There should be some other component as such. And there is no cutoff value of lactate to be used during resuscitation in the hemorrhagic shock patient, because in the hemorrhage we have seen it goes like 15, 16, then patient used to be come back to the normal situation and go home very nicely. So many of the time, it is more a practical thing rather than I can say go for literature blindly, because the patient spectrum is different, patient genomic is different across the globe. So you have to look for other many factors rather than going fixed into the literature. This is written, we have to go till if lactate is 2, we have to treat, and it's not like that. So you have to manage the patient as a whole and clinically examine the patient as a whole and how the patient is behaving. All these things has to be taken in the consideration. So, but however, the bottom line is hyperlactatemia patients should never left until they are addressed or managed, and this should be continuously visualized. So thank you so much.
That was amazing, Minati, again. I think a difficult topic, which is not very well covered, but I'm sure everybody would have actually gained quite a lot from this topic. All our machines, I think one of the problems with ABG machines, not all ABG machines actually measure lactates. So I think it's useful to actually have a blood gas machine which actually shows lactate
Absolutely.
level.
Initially also we don't used to have a ABG machine to measure lactate in my center also, while I joined as a student. But these neuro people used to have a ABG machine which is to measure lactate. So we used to I did 2 projects on that. So I got fixed up with one of the technical staff, and he used to take my sample and do lactate measurement. Then while the result come out, our chief was very happy then because all the patients were from his theater only, and then all the machine, now we got lot of parameters, ABG machine, lactate, magnesium, many ions and many things we used to have.
Absolutely.
After that.
Absolutely. From a little sample, you can get so much of information.
So much of thing, yes.
Yeah. And I mean, for my cases, even if I don't have arterial line, I tend to actually have an external jugular, especially giving fluid, take a venous sample.
Venous lactate, yes.
And put it into a blood gas machine. You get so much information. And I think you can be pretty, happy if your lactates are normal. I think you have maintained most of the hemostasis quite well.
Yes.
Achal, yeah.
Again, Dr. Minati, thank you very much. So I just want to comment a couple of things. So one is point of care testing. I think if you have the facilities, this makes a huge difference. So I usually have, for any big cases, the point of care, our blood gas machine in the operating room. And whenever the resident or the fellow or I'm doing the blood gas testing, the first thing I look at is lactate. And the other important thing is the trending of lactate. Like the baseline was 1, now it is becoming 2, then it is becoming 3. So that gives us a lot of information that something is going wrong, not correct. We need to address that. So these are my couple of points. But yes, I enjoyed your lecture. Thank you.
Thank you, sir.
Absolutely. I think if your fluid balance is also right, your lactate should rise. Another thing to note, isn't it?
I purposely did not cover the biochemical markers
Yeah.
because I, like Dr. Chaudhary, Minati Chaudhary would have is going to cover. So I purposely left it out.
Yeah. Achal? Yeah.
Yeah, just, we are dealing with one human being, one person. So we try to separate out for our understanding purpose. This is respiratory system, this is cardiac, this is fluid management, this is kidney. But ultimately the body responds or not responds to whatever we do. It is one body, one person. And all these different gadgets we use are basically to improve the outcome of these patients.
Absolutely. I think we need to look at body as a whole rather than actually going in a silos and looking at only one part of it. We look at everything in total. Yeah, I think, coming to the last part of the lecture, Vanita always gets the to the last very important topic, and she covers this very well. Vanita was at at AIMS at the Neuro Center, but she has recently moved. Am I right, Vanita?
Yes, sir.
Yeah. I'm sorry, I forgot the name of the hospital you moved to. Is it in Delhi itself?
Yes, sir. It's in Delhi. It's Institute of Human Behavior and Allied Sciences, sir, which is a neuropsychiatric center now.
Okay, where is this exactly? Where?
Sir, it's in Dilshad Garden, sir, East Delhi, near GTB
East Delhi.
Hospital.
Okay. So I will let you introduce yourself and over to the last lecture where we'll be discussing about delayed recovery and awakening. I think which can be quite stressful for some people when you need to go home. You're finishing the day and your patient is now waking up. That can be quite stressful. You either promised your family that you're taking them out or you have an appointment and the patient is now waking up. That's very stressful. And Vanita is going to take us over to this topic. Over to you, Vanita.
Thank you, sir. Good evening, everyone. As we come to the close of the symposium, I'll be discussing delayed recovery from or delayed emergence from anesthesia. As sir has rightly said, he has emphasized one importance of this topic, that is, apart from, as anesthesiologists, we put the patients to sleep, so it is our responsibility to get them fully awake as close to the preoperative status as possible. And in addition to increasing the mortality and morbidity in a patient due to the delayed emergence, this can also cause a delay in the operating room schedule and add to the economic burden of our healthcare system. I have no disclosures. The objectives of this discussion would be to identify the occurrence of delayed emergence following general anesthesia, to recognize and develop a differential diagnosis with attention specifically to the reversible causes, to identify risk factors for delayed emergence, to identify what to assess in a patient who is having a delayed emergence, and identify the management of delayed emergence. So firstly, what is emergence? Emergence is the transition from an unconscious or anesthetized state to complete wakefulness. Here, the patient is alert or arousable and fully aware of his identity and his surroundings. Now, the recovery phase from anesthesia can be divided into three parts. One is the immediate recovery, where there is return of consciousness, the recovery of the protective airway reflexes, and the resumption of the motor activity. This usually lasts for a very short time. Then is the intermediate phase, where the patient regains the power of coordination and the feeling of dizziness usually disappears. Now, this phase is important. It is usually within about 1 hour of a short procedure under anesthesia. And for daycare procedures, this is the phase where the patient is fit to be discharged with a responsible attendant or an escort. And next is the long-term recovery, where there is complete recovery of all the coordination and intellectual function of the patient. And this may take a few hours to even a few days in some patients. Now, what is delayed emergence? Delayed emergence is the inability to regain an adequate level of consciousness, usually 30 to 60 minutes after cessation of a general anesthetic or after stopping of all our anesthetic agents. Here, the patient is unresponsive or still deeply sedated. Now, there are several risk factors for delayed emergence. These can be broadly grouped as the patient factors, the drug factors, the surgical factors, and metabolic factors. The patient factors include the extremes of ages, that is the neonates and elderly. There could be genetic variation in the patient, which can lead to a delay in emergence. The body habitus of the patient, like again, patients who are frail or neonates because of small muscle mass, these patients can have increased susceptibility or increased effect of muscle relaxants. This is just one example. This is what the body habitus, how it can cause delayed emergence. Then the presence of comorbidities can affect the metabolism of various drugs and thereby cause delayed emergence. Obstructive sleep apnea, cognitive dysfunction, seizures, and stroke are other patient-related factors. Now, coming to the drug factors, the dosages, the absorption, distribution, excretion, metabolism, drug-drug interaction, then the local anesthetic toxicity and fluid overload. Surgical factors, again, if it is a prolonged surgery, then the anesthetic time is also prolonged, because of which the emergence can get delayed. The use of muscle relaxant, the regional techniques with the use of sedation, decreased pain to stimulation, intracranial surgeries, cardiac surgery, carotid surgery, and surgeries which are at high risk for embolism are other surgically related factors for delayed emergence. And coming to the metabolic factors, we all know hypo or hyperglycemia, hypernatremia, hypothermia, hypothyroidism, hepatic and renal dysfunction. And then we have acidosis, coagulation defects, and central anticholinergic syndrome, which is a diagnosis of exclusion, which can result in delayed emergence. Now, the causes of delayed emergence can be drug, metabolic, neurological, and other rare causes. Now, drug causes can be pharmacokinetic or pharmacodynamic. Now, among the pharmacokinetic causes, we have an inappropriate dose, which can be either absolute or relative. If there is an impaired transport or distribution, if the metabolism is impaired, which can occur with systemic illnesses, if there is impaired elimination, for especially drugs which are eliminated by the kidneys, depending on the duration of surgery and drug-drug interaction. The pharmacodynamic causes are because of the genetic variations in the individual, hypothermia, and drug interaction again. The metabolic causes we have already seen. Neurological causes include hypoperfusion or ischemia, intracranial hemorrhage, thrombosis, embolism, and central anticholinergic syndrome. And rarely we can have conversion disorder. Now, how to assess the patient? First is we'll have to take a good past history, make sure that all the agents, all the anesthetic agents are turned off. We have to review the anesthetic record to see the last timing of the anesthetic drug and look for any drug-drug interaction. Review our fluid administration, assess the vital signs of the patient, ensure that there is no hypothermia. The temperature should be above 35 degrees centigrade. There should not be any hypo or hyperventilation. All metabolic parameters should be normal. The residual muscle paralysis should be ruled out. And we do a neurological examination. So this is an algorithm for delayed emergence management. First is the rapid assessment of ABC. We should make sure that the airway is patent and protected, the patient is breathing adequately, and the circulation is supported. So if not, we give 100% oxygen and use any airway adjunct and institute mechanical ventilation if required. And most important is to make sure that the airway is protected. Then we go to assessment of the GCS or the Glasgow Coma Scale and stimulate the patient. Then we review the anesthetic chart, the drugs, the timings of the last dose, any interaction with any other drug which the patient is already on, and consider the patient characteristics. Now, certain antidotes can be used, like naloxone for opioids, flumazenil for benzodiazepines, neostigmine for muscle relaxants, and doxapram. What we have to remember here is naloxone, though it is an antidote or reversal agent for opioids, we must remember that it also reverses the analgesic effect. So we must ensure that the patient does not wake up agitated. So we must ensure that some other form of analgesic has been given before we reverse the respiratory depressant action of an opioid using naloxone. And again, all these reversal agents are short acting. So the patient may again go into a depressed state when the action of these drugs tend to end. Then we monitor the capillary blood glucose to rule out hypo or hyperglycemia and correct if required. The temperature should be above 35 degrees, so we have to warm the patient up. Then we draw a sample for arterial blood gas analysis and correct all the metabolic parameters if possible and rule out hypoxia, hypercapnia, and acidosis. Then we go for a full clinical examination with particular attention to the various systems. And in the nervous system, we look for any specific focal or lateralizing signs. Then we go, if this is present, then we go for further tests like an X-ray or a CT head to rule out any intracranial cause for delayed emergence. Then we draw further blood samples for doing, we can also do a urine screen and then a complete blood examination, thyroid function test if we are suspecting hypothyroidism. And if the patient still remains unconscious, then we have to decide where this patient should be managed, then decide about the further course of action, and consider a dissociative test where other diagnoses are absent. Now we will discuss a few clinical scenarios. Case 1 is a 4-year-old child for repair of congenital hernia. This patient undergoes an uneventful surgery under general anesthesia, was extubated at the end of the surgery and was okay. The child started shivering and developed stridor or laryngospasm. And in spite of substitutional oxygen, the child is getting cyanosed. So what do we do? Based on our discussion, this child being at the extreme of age is already at a risk for delayed emergence. Among the, what could have happened here is, though it was a short procedure, because of exposure and this child could have been hypothermic, because of which the child started shivering in the post-operative period, that would have led to, the residual effect of muscle relaxant, which could have led to stridor and laryngospasm. Or post-operatively, there could have also been a tongue fall, which could have led to this. And so that is what our management will be on the lines of ABC, that is to see if the airway is patent, protected, child is breathing, and maintain circulation, and then look for the causes and manage accordingly. Next case is a 19-year-old lady post-LSCS for severe preeclampsia. She undergoes emergency lower section cesarean section under general anesthesia. And in spite of a good or uneventful intraoperative course, after reversal, she is not regaining consciousness. She is hypertensive and tachycardic and not responding to verbal commands. So what are the likely causes in this patient? One is, it could be inadequate reversal, because we all know that pregnant patients are susceptible, or they are more susceptible to the effect of our anesthetic agents. And the other possibility is for preeclampsia management. In case this patient has received magnesium, then that can prolong the action of our muscle relaxants. Other things, important things which we have to remember is, again, importance of coagulation. Though it is preeclampsia, but still if there is any coagulation abnormality, she could be having an intracranial bleed, which can cause delayed recovery. Amniotic fluid embolism could also be a possibility in this patient. And other thing is, preeclampsia per se can cause cerebral edema that can also lead to delayed emergence. So we'll have to, again, our management will be ABC, look for the causes, treat, and whatever is reversible, treat it and manage this patient. Next is a 70-year-old man, a 70-year-old patient for colonoscopy, and only intravenous sedation was given. The drugs used were propofol and midazolam. The patient started having ventricular premature beats. Injection Zylocard 1 mg per kg was given. Now the patient becomes drowsy, bradycardic, and unresponsive. So what could have gone wrong? A combination of drugs in an elderly patient, though it decreases the dose of, each individual drug, but the cumulative effect could be high, because of which the patient could be drowsy. And we already know that elderly patients are at high risk for cardiac events peri-procedure, even if it is a endoscopic procedure. And when Zylocard, when it is given, that could further add to his drowsiness. So again, our management will be on the same lines, ABC, look for the causes and diagnose and treat. Next is a 65-year-old patient for TURP surgery. This was done under spinal anesthesia. The patient is hypotensive, tachycardic in the recovery room. He's treated with boluses of crystalloids. Now the patient becomes depressed and drowsy. There is hypotension worsened. The saturation starts falling, and in spite all efforts, the patient is worsening. Now, the most common likely cause in this case is dilutional hyponatremia, which we all know because of TERP syndrome. And this can be, the patient initially ABC management, and then we'll have to restrict the fluids, cause diuresis, and correct the sodium and see how this patient improves. Coming to the last case, this is a 28-year-old patient for infratentorial craniotomy and tumor excision. He underwent a ventriculoperitoneal shunt for obstructive hydrocephalus under general anesthesia 1 week prior to this surgery and had a normal recovery at that time. During this procedure, he received osmotherapy with mannitol and Lasix. Then the anesthetic management or regime was switched over to total intravenous anesthesia with propofol, and the patient was mildly hyperventilated for an intraoperative brain bulge. The rest of the intraoperative course was normal. After reversal, the patient was breathing regularly, generating adequate tidal volume with acceptable respiratory rate and stable hemodynamics, but there was no spontaneous eye opening and the patient was not obeying commands. So what to do in this case? Maintain the airway, breathing and circulation. What could have gone wrong? One is the patient could have developed an operative site hematoma, or the one likely cause is the patient was already shunted, the tumor is out, so the very high chance of pneumocephalus, so which can cause a delayed emergence. So in this patient, we will go for a CT scan to see what the intracranial, if there is an intracranial pathology. At the same time, we will have to rule out other metabolic and other reversible causes and then manage the patient accordingly. So to conclude, delayed emergence from anesthesia is multifactorial. There are no set rules as to in which patient this would occur. There are many variables which can lead to this. So what we need is eternal vigilance and careful balancing of our anesthetic technique to have a good outcome in our patients. Thank you.
And another wonderful session, Vanita. Very crisp, to the point. And I think you are the right person to take this lecture. You did a great job. I think, like I said, I think delayed recovery, not very common as such, but it does happen. I mean, and sometimes it's missed. And one of the commonest causes have been undetected hypothyroidism. We've had quite a few discussions on, where patients have high TSH, and people say, oh, what do we do with them? So people need to be very careful with, especially drugs like benzodiazepines, which can lead to delayed recovery. I don't know whether flumazenil is easily available in India or not. I'm not a proponent of using benzodiazepines that commonly, but I think in India it is used. Every case, which is posted on the group, I see people actually using benzodiazepines very regularly for patients. I think my way of looking at it is that use it if it is required. Otherwise, it's not. Most people use that part of their usual induction technique. Other things, again, obstetrics, I have seen patients who with preeclampsia developing large bleeds, so not uncommon. I think you had one of the cases posted, you were discussing about that. So I think, again, very, very nice case. Inadequate reversal, amazing. That is actually so common because you tend to give reversal, diaphragm and your vocal cords recover, but rest of the muscle and the patients are still, they can't move as much and they feel that they can't breathe. They're breathing fine, they're saturating fine, vitals are stable. Okay. And so it is again very common, and that's because, again, not everybody uses neuromuscular monitoring. So it is actually a great topic, and I think you have covered it really well. I think the algorithm was fantastic. Tells you at what stage what you need to do. Anybody, anything to add? Achal, David? Any? Sudipta?
No, I think she covered very well all the aspects. And again, I would re-emphasize to use neuromuscular monitoring.
Yeah.
unless you have Sugamadex type of reversal agent with you, which kind of neutralizes rocuronium very easily. But I think this should be standard of care.
We actually recently had a very interesting case. It was not my case. It was, I went into the recovery and they actually had this patient who, they had used neuromuscular monitoring. They had used rocuronium. They said they were all 4 twitches. They again reassessed the patient, but didn't seem right. Wasn't like a delayed recovery. And in the end, we said, we use rocuronium. Why don't we just give Sugamadex and see? And so Sugamadex was given and patient woke up like that. So we just couldn't understand, I think, whether it was inadequate reversal from neostigmine and glycopyrrolate. But this patient, even after they gave half the dose in the recovery period, was still not right. But amazing, I mean, the way he woke up after Sugamadex was amazing. And the other thing I think you mentioned in your algorithm was some of the drugs used, like naloxone, the flumazenil, obviously making sure the reversal is given at the right time. And the last one is Dopram, one of my favorites. I call them magic drug, I tell them. So hypercarbia or CO2 narcosis is very common. So, I mean, you're using opiates, using volatile anesthetics, using benzodiazepines. All this causes respiratory, depression. I'm not saying to the extent that they stop breathing, but they have, they tend to retain CO2. You give them just 20 milligrams of doxapram, they wash out the CO2 and they wake up like, as if suddenly they say, what happened? It's like magic. And you do it in the recovery when recovery nurses have tried everything. Pain, Larsen maneuver. Patient is obstructing, snoring, or laryngospasm. You give Larsen maneuver, that painful stimuli. Again, a good way of waking up. But if all this thing doesn't work, then you have to think of the thing. Sorry, actually, yeah.
Yeah, sorry again. Just some rare cause.
Yeah.
I did a case about 6 months ago with traumatic brain injury, which was about 4 or 5 years ago. Patient had tracheostomy, patient had both posterior and anterior spinal fixation, he had chronic pain, now he had contractures of all limbs. So coming for release of contracture. So block was given, but it was done under GA. So I did awake intubation. And after that gave just a touch of rocuronium and a little bit of fentanyl because he had pain in other parts of the body as well.
Yeah.
And he took more than 2 hours to wake up after the procedure.
Yeah.
I gave flumazenil, I gave naloxone. Patient is breathing perfectly, saturating perfectly, but not opening eyes. And I could not figure out what could be the cause. I could only relate was maybe the previous traumatic brain injury could have caused lots of issues, and he had this kind of delayed recovery. And of course, he was tolerating the tube because of the local topical anesthetic, but he was not opening his eyes, and otherwise all parameters were normal. Quite unusual. So, Vanita, have you seen or have you read something about that? Patients who had 5 years ago traumatic brain injury still responding like very slow recovery.
Sir, it happens, sir. Actually, what one of the causes is benzodiazepines. It is said that midazolam sometimes causes rewiring. So if the patient has had this kind of a thing previously, then they have more chances of having that kind of a situation again, sir. And obviously, once after a traumatic brain injury, the cerebral hemodynamics never return to normal, sir. The autoregulation and all that, though it normalizes, it never returns to the baseline. So the interaction of and the effect of various drugs we'll have to individualize. We cannot say that this is how it will act. So it depends on the individual patient. I have seen a patient, sir, in trauma, like due to, it was not a traumatic brain injury. It was in fact, a blunt trauma, chest and thorax, chest and abdomen. Initially, the patient had undergone gastric splenectomy and repair of a gastric perforation. But subsequently, this patient had to be brought to the OT for multiple surgeries, sir. laparostomy and drainage, and then every time a stoma would be done and sent back. And gradually this patient started developing resistance to muscle relaxants and the anesthetics, sir. Like intraoperatively, we would not have any signs. Like I have seen this patient also, like there would be no tachycardia, though we have not used a neuromuscular monitoring in this patient, but there would be no tachycardia. The patient would not be breathing spontaneously. But post-operatively, this patient, though he was tracheostomized, I have seen him writing that I was completely aware of everything as to what was done to me. So, this is a kind of complete resistance to all our anesthetic agents, though there is no hemodynamic manifestation of that. So anything can happen.
Would he have used like a BIS monitoring on this patient and titrated? Would that actually help?
That could have helped, sir. At that time we didn't have this with us, but then that would have definitely helped. At least we would know that if the patient is actually getting anesthetized or not, because this is actually, I felt criminal when the patient wakes up and tells me that I've been aware of the whole procedure.
It is, I think, one very traumatic experience for patients to be awake. And, so I think if we have BIS monitoring, then at least we know what level it is. And it is amazing. It's the other way around. What he's saying that I have seen that. So I've seen in patients who I do GRA technique, and they give them blocks. When I actually monitor the BIS in these patients, it's very difficult for me to actually try to bring the BIS up to 40. They remain around 40 to 30, despite, I can come down to MAC of 0.6 and still the BIS will actually remain. It doesn't just go up. So I think a combination of a lot of things they're not perceiving, but these patients are not aware. They're not, 0.6 is fine for 0.6 to 0.7. I usually maintain patients spontaneously on 0.7 MAC, 0.7 to 0.8 MAC is my usual one. Achal? Right.
Yeah, just pointing out on the BIS monitoring, of course, it is important. And recall or awareness, as Vanita said, is one of the most devastating thing we can ever think of. Just at least in North America, the BIS cannot protect you in the court of law. You can say that, yes, the BIS was 40, 50 throughout, but patient complains that he had awareness or recall. So that is not considered as in the court of law, number one. And number two, there are some, I don't know what your experience is, Shiv. If you give ketamine, the BIS usually tends to be on the higher side. And again, BIS is not very much correlative with the depth of anesthesia if you use agents like ketamine.
Yeah. Opioids and ketamine, you can't rely on them.
Yeah.
It is, I think, solely, based on your intravenous anesthesia and maybe volatile anesthetic, but other additional things, people are not aware how they will affect. Ketamine, again, you're right. You can actually have much higher scores, even though patients sleep. So maybe that's related to the dissociative anesthesia aspects of ketamine.
Yeah.
Opiates can make you sleepy, but you can still actually have higher, BIS level, scores. So I never rely on opiate for prevention of, it's not. In UK, we would actually still consider BIS, as a protective thing, because the Royal College of Anesthetists advocates that. It does say that, it'll be protective if you are looking at that. And if you have a patient with awareness and you did do monitoring, awareness can still happen with even monitoring, but at least you say that I knew the patient was at risk of awareness and I did monitoring. So from your side, you have taken all the precautions.
Oh, absolutely. Yes. You have a great point that you did your best to prevent awareness. Yeah.
Yeah. And you just have to apologize and say, sorry, this still happened. Yeah, we tried our best, but this still happened. So thank you very much, everyone. I think the afternoon session has been another great session. I think all the three topics so very well covered. Great discussion as well. with great inputs from Achal and others.